down. Actually, very interesting. First time we had a 200 plus registrations. So about half of them here, maybe the rest will trickle down. And as you saw, this will be our 8th year of top 10. And we changed it to every speaker is going to talk about top 10 advances or points in their field. Little different. It's a kind of experiment. And actually, idea was Dr. Deepak Bhatt's that why don't we top 10 clinical topics and within there just give top 10 advances, because rest we learn from the books and so many other things and so let's see how this works out. But welcome all of you to Mount Sinai Fuster Heart Hospital for this annual event, and hope you'll enjoy. The purpose would be that to give each speaker will give salient points for in their field, and they are all expert, as you can see with their bio and expertise. Enough opportunity to ask your personal questions about your practice, about your patient care. We have the mics, there's a QR code, very simple, I tried it. You just take QR code and you can later on type the question which will come here. And of course, we'll continue to emphasize on that point. With that note, I'll ask now my associate, Dr. Annapurna Kini, Anu to make a comment, and then after that, Dr. Bhatt will take care of the rest of the day and show to welcome all our faculty, national, international, and Sinai faculty, which has really made this a very exciting curriculum. Hopefully, will be useful to everyone. And thank you very much. Anu?
Okay. Good morning, everybody. Actually, it's a beautiful Friday. Everybody like to come to New York, and thank you for being here to get the knowledge from the great faculty that have agreed to come and talk to all of us about the top 10 advances. Enjoy the meeting, and like we said, keep asking us questions, so it becomes very interactive. Thank you.
All right, Deepak.
Great. Well, we're off to a wonderful start. Let me first say thank you, of course, to Dr. Sharma and Kinney, who are co-directors here with me of this program that you all hopefully enjoy. We've put a lot of thought into it. We've got the best speakers from internally, from externally. There are people attending here from all over the country, mostly the tri-state region. But I'll let you know there are actually thousands of people that are online. We don't have the final tally yet, but last year it was upward of 4,000. Yeah, it was. So we're hoping to cross the 5,000 mark. So just so you're aware that there are a bunch of folks. As Dr. Sharma mentioned, though, please do, when you have questions and you're thinking of them, put them in there. For this morning session as we're going on, I'll be monitoring them. That way we can efficiently go through questions. So we do have at least a couple of microphones here, but we will want to keep things on time. All right, well, with that, let's go ahead and get started here with things to stay on time. And if you can queue up in the back there from the AV team, the first presentation, we're starting off with Dr. David Rich. So if you could pull up his presentation. Dr. Rich is really someone of many talents who wears many hats here. He has been the president of Mount Sinai Hospital for quite a while. He led this hospital and health system's efforts bravely, wisely through the COVID pandemic, and has made really indelible contributions to this health system. Most recently, in recognition of all those efforts and contributions, was named the chief clinical officer for the entire health system, not just Mount Sinai Hospital. On top of that, he's an active practicing cardiovascular anesthesiologist. He had been the chair of anesthesiology here. You'll see him come up in a moment. In his scrubs, he's even wearing his booties, so he literally just ran down from the operating room. So he not only leads our efforts here at the hospital, he's actually in the thick of it, caring for patients. As well, he leads the AI efforts, and lots of different places, health systems talk about the research that they're doing in AI. We do a lot of great AI research here. You'll hear about some of it through the course of the day. But researching AI is one thing. Actually implementing it in clinical care and improving things like patient quality and safety is altogether a different thing. And I'd say nationally and internationally, he's been a leader on that. And he's going to speak to us about some of the great things he and the Mount Sinai Health System are doing with respect to AI and healthcare. So please welcome Dr. Rich to the podium. And AV team, if we could just pull up his slides so that they're here. Okay, great.
you. Thanks so much. Thank you so much for that kind introduction. And yes, I am trying to make an honest living today. So I'm going to skip through this very quickly. I didn't do a top 10, but I have a top 10 minutes, so that's about all I have. So that'll be the way I'll approach that. I want to start by saying that we spent a lot of time over the last few years, everyone building predictive analytics into everything. You can build it into electronic health records for sepsis, clinical deterioration. We have things here that predict malnutrition. But one of the things that I want everyone to be very cautious about is that when we create our models, when we train our models, we often train them on data sets that have inherent biases. And the reason is, well, it's pretty clear. For many centuries, since the medicine first became medicine, wealthier people have better access to health care than poor people. And so we have to be cautious that we don't introduce bias into our algorithms. And so we intentionally test our algorithms on different subsets of populations here as one of the underlying principles. The other thing I want to point out is that we can introduce a confirmation bias. We'll call it an automation bias, is sort of the new term. This is an example of where radiologists were getting advice from an algorithm that helped them grade mammography in terms of the grade of cancer. And on the left side, the AI suggests a correct category. And whether you were on the left, inexperienced, meaning a resident, in the middle, a junior attending, or on the right, an experienced attending, you were probably about 80% chance of getting it right. But then as soon as we started introducing, or in this study, they introduced intentional errors, the residents were only 20% likely to get it right, the inexperienced attendings 25%, and even the experienced attendings less than half the likelihood to get it right. So the obligation is to be not biased, and the obligation is also to be correct, because if you're incorrect, you're going to lead people astray, and that's bad. And then the next one is workforce. We work very carefully with frontline providers when we develop new tools. And it is incredibly important to do so. This was outside, I believe, Kaiser Permanente headquarters, California Nursing Association. And these are going to be huge upheavals in the future. And the only way to get your hands around it is to say to our nurses, to say, we don't want any AI at Mount Sinai. It's like, well, we have about 25 AI products clinically that are already in the background. And we work with our frontline nurses to make sure that they see them as positives if it makes your life better. But when we get to the future where AI might start to change or alter positions, then we're going to have to really considering things. So let's talk now about how we might leverage the AI to become the world's safest health systems. The first thing is the concept of quality. So the Consortium for Healthcare AI, or CHAI, has developed the concept of an insurance laboratory, and they're starting to work with Joint Commission. So in the not too distant future, there are probably going to be entities, I hope Mount Sinai is one of them, that will be able to test tools, algorithms for quality, safety, absence of bias, and refining the products to fit best in the workflows. And also, frankly, to create revenue streams for these organizations to invest in the innovation. And I also want to point out the issue of advocacy. Where you have CHAI aligned with Joint Commission, the physicians need to be at the table in Washington and state capitals, aligning government regulation with the concepts of assurance lab certification, expanding access to care through agentic extenders of licensed providers. That's an entire change in scope of practice, but getting the tools out to more people in rural areas, even in urban areas, are very important, with the caveat that we shouldn't have computers as the only access for poor people, and you have to be wealthy or well-insured to see a human. And then the final thing is rational regulation that protects public safety, but doesn't hamper us from innovating in the interest of actually improving public safety. Robotics is something I'm just going to skip over fairly quickly, but and it may not be so much in the realm of clinical cardiology practice initially, but a lot of the support services in hospitals, things like delivering of supplies, cleaning of floors, things of that nature, will probably be changed somewhat radically. I want to talk about a couple of agentic AI use cases. An agentic, well, you think of an agent. So now we have large language models, but think of the agentic tool as an interface between a large language model and the clinician or the patient. And what we have here is an example of where we applied it. Our overworked and under-rested surgical residents are tasked by the department with doing an analysis of every surgical complication. So let's say there's an anastomotic leak. The resident has to go through the record and find all of the things that might have gone wrong and write up a sort of a quality assurance performance improvement summary. When the residents do it alone, they just try to get through it. It's these massive charts, and they're not paper anymore, but they're even more massive electronically because of the sin of cutting and pasting or copying and pasting. And so the residents only found about 3 errors per chart. But then we tried AI only, and it found 53, but more than half of them were hallucinations, basically meaning they were wrong. And then really this is the point of this discussion is the middle bar is the sweet spot. When you have the AI working with the resident, they were able to say, oh, I missed that, that's right, or no, that's completely wrong. And so that concatenation, bringing the human together with the tool seems to be something that will be very important for us to build into our workflows. Now let's talk for a moment about a concept of driving care standardization through a nudge unit. What is a nudge unit? It's to push people in the right direction to impose some degree of care standardization. So I'll give examples. Medication safety and stewardship. How many of you still prescribe Benadryl in the hospital for somebody over 75 for sleep? I hope you don't. But the point is some people do, and we need to impose some degree of safety and standardization for medication. Diagnostic laboratory stewardship, so we order the right labs and we don't over-order to decrease expense. Radiology test ordering, 80% of tests ordered at Mount Sinai are stat in the hospital. Are they really stat, or is it just that everyone makes it stat? So creating order out of chaos in terms of better standardization and making the right choices. And I would also add case selection for high-risk treatments or procedures. You have a golden window of opportunity when someone is scheduled for a procedure before that procedure actually happens. And we know that about 80%, let's say, of the risk of an operation or let's say a cardiology invasive procedure, 80% of that risk is known before the person ever gets on a table. So it gives us an opportunity to have a discussion. I never don't want an AI algorithm saying, no, you can't have surgery, but I want an AI algorithm to say, oh, we should have a discussion here, and maybe have more advance and review. And already we do a lot of activation of special consults in the background, rapid response teams, stroke, delirium, wounds, falls, violence prediction, and palliative care prediction. But the key is that's getting the right team to the right patient at the right time. It's less controversial because people make their own assessments. So thinking of it like a model, how are we going to bring large language models into clinical care? It's by creating agents. So let's think of inpatient rounds. Of course, the patient's at the center of everything, but think of each of the players and how they will interact and how they will be advised. And so this is the work of the next 10 years, is how we bring this into live action and to have all of our staff see it as a positive, that it's augmenting their care. Sophia, you'll probably hear more about it today, but it is a beautiful example done by our cardiology team. Here in the cath lab, they have an agent that does a pre-catheterization nursing interview. We can't really make it agentic because agentic is supposed to be autonomous, but we have barriers to entry. This is a key point. We have scope of practice issues, we have state licensing issues, so we always must keep in mind that when we build things into our workflow, we're building things into a workflow that is in a highly regulated industry. And we want to do the best that we can. And also, will this agentic agent remove nurses from this process? Absolutely not. We need the nurse to say this is right. Would a nurse maybe be able to do 2 or 3 times as many of these calls more effectively? Perhaps. And so we'll have to see how this plays out over time. But it's an excellent application of the concept of the agentic AI principle. You keep the human in the loop, but you're setting the stage for future iterations with more truly agentic capabilities, which are autonomous. But that'll require change. Let's also talk about biomedical. You are in a world, you're clinical cardiologists. your patients have wearables. You should and hopefully will be prescribing some kind of remote monitoring, whether it's by a wearable or some other technology, to be able to better monitor your patients. And when they come in, you'll be able to review a lot of data. Some of you may be doing that already. Computer vision in the hospital should be a major advance in safety. And brain-computer interface is more the neurosurgeons, neurologists so far, but these biomedical advances are truly going to revolutionize. But the agentic AI use cases that I think are more appropriate for clinical cardiology will be improving ambulatory patient access, care optimization, care delivery, with the proviso, again, we don't want poor people only seeing a computer and wealthier people seeing a doctor. The learning health system is something I think we can come back to. Right now it's more of a slogan, but I think we really have to expose ourselves and let large language models learn on ourselves, our behaviors, our patients' behaviors, and all of our data, so that we can start to get that, not just clinical guidance, but also strategic guidance in terms of where we fail to meet the mark. And I would see it as a 24/7 call agent, computer vision in a hospital room, that would help us with safety. It would call a code if someone stops breathing. It helps with communication, food, ordering, entertainment, education, discharge planning, transitions of care, and hopefully educating people that leads us to reduce readmissions. Let's talk about governance for a minute. To be able to bring things in, it doesn't matter if a large language model were free. Building anything into a workflow and working with information technology professionals takes time, and that means money. And so you have to have a thoughtful determination of what is a return on investment. Now, could that be experience, safety, and quality other than money? Of course it could be. And that's exactly where the physicians have to lead. And so I want all of you, as you start to build these tools into your practice, to keep in mind, what is that return on investment for your patients and for yourselves? So it could be decreased mortality, falls, readmissions, complications. As a chief clinical officer, that's my obsession. But it could also be financial gains, such as pharmacy revenue growth, getting more people on SGLT2Is who have heart failure. We vastly undertreat, even within our health system, because we fail to identify the patients. How many people in Mount Sinai Health System have an LDL greater than 190 that are not getting appropriate therapy? Far too many. And we're looking to correct those, and building the expert systems in should be helpful. And that's an example where AI would have a return on investment, both clinically and financially. And then the key point is scalability. Point solutions are expensive. Avoid death by pilot. If all you do is pilot after pilot after pilot, you're destined to fail. You must pick something that you know is going to be ready for scalability from the outset. So how do we make our hospitals and all of your hospitals the safest in the world? So certainly we already are in the world of trying to use predictive algorithms to prevent and to intervene whenever we can to prevent mortality, complications, applying interventions at critical junctures. Let's think about that for a moment. An emergency department admission. Well, you might move palliative care upstream. Think about it. We have a moment there in time where we could have a goals of care discussion. Think about inbound transfers to our hospital from elsewhere. Doing SOFA scoring and building in predictive algorithms to think about whether we're actually doing a patient benefit by bringing them here. Scheduling for procedures and operations, I already talked about in creating stratification and escalation of high risk, and the concept of the nudge care unit standardization. We're currently using a tool. This is not an advertisement. We use AgileMD. I'm sure you can find other tools out there that do that. We currently have about 10 use cases in production, 8 of them in the emergency department. And other things we already talked about, I think, related to clinical decision support. So let me end by talking about the past, the present, and the future. Predictive analytics are very 2017. We were, early in this business. Back then we called it our little big data group, a little bit of a joke. But the predictive analytics, the digital twin, I get sick every time I hear that term. It's so overused these days. And we're going to, at this point, say that predictive analytics are here to stay. They're not that hard to do. The tools are out there, and you can build them into your workflows. Electronic health records like Epic, beware, sometimes they do it really well and sometimes they're still on a learning curve. The present of AI, of course, predictive analytics always continues, and now it's about moving into building AI into workflows to create pathways towards care standardization. We don't do a good job following our own society guidelines. We don't do a good job in many ways. We drop the ball. We fail to have people follow up. We can vastly improve that. And of course, workload reduction. Who doesn't want an ambient AI tool listening to them and writing a note for them? That's obvious. The future, personalization, taking genetic data, imaging data, electronic health record data, wearable data, lifestyle data, and truly moving past care standardization to care personalization. Thank you so much, and I'm very pleased I was able to join you this morning. Am I sticking around for a question or two? Because I will have to head back. Lines have to be placed.
Oh, yeah, no, you've got
Universal protocols
important
must
life-saving
happen.
work to do. Any questions from the audience?
Good.
Seeing none, I'll
Thank
thank
you
you
so
for
much.
a brilliant lecture and everything that you're doing for our health system. Thank you. All right, next up, if we can cue up Dr. Fuster's talk so we're ready to go. AV folks, if you could pull that up. So really a pleasure to have our keynote lecture here delivered by none other than Dr. Fuster. The heart hospital that you're in is the Dr. Valentin Fuster Mount Sinai Heart Hospital, named after Dr. Fuster. It was named that for a variety of reasons. One is the incredible contributions he's made over decades to building up cardiovascular services here, cardiology, cardiac surgery, and beyond, but in part to recognize his global contributions to the care of patients and to the education of physicians and other health professionals. As I travel from place to place, universities in the US, around the world, it's incredible to see the impact that Dr. Fuster has had. I don't think there's anyone alive in cardiology right now that has had the impact that he's had on trainees, on people that have gone on to lead programs around the country and the world, on patient care. What he's doing, and he'll speak a little bit about this, is truly transformative in terms of approaching young people, children, adolescents, to alter their behaviors, to promote cardiovascular health at an early age and families so that there is a durable impact that can then change this cardiovascular epidemic that is present throughout the world. So really no one better that I can think of to talk about heart and brain health, which are so interlinked. Dr. Fuster.
Thank you very much, Deepak, for this introduction. It's a pleasure to be with you today and to discuss what I think is an exciting topic. About 15 years ago, I decided to move my investigational approach from disease to health and trying to understand health. And what I'm going to be talking today is healthy or subclinical vascular disease in the heart and in the brain. When you approach this subject, you realize very quickly that there are 3 different ages in which health is different. From birth to age 20, from age 20 to 60, and from age 60 to 100. This is in 3 circles, the 3 ages, and I'm going to be talking about one subject in each age. We'll start with the PESA study between age 20 and 60. I will go into the brain between age 60 and 100, and I will end up with children from birth to age 20. Let me begin by saying that the main challenge that we have between age 20 and 60 is to know whether we have arterial disease or not, coronary artery disease. So we got about 15 years ago into the issue of imaging. And the question is, can we do imaging technology that can be applied to the world, not just to the individual patient who comes into a hospital? We developed the so-called PESA study. This is in Madrid, which is a study of 4,200 people over a 20-year follow-up, and we follow them every 3 years. What we do? We do imaging technology, which is certainly the peripheral vasculature with 3D ultrasound, iliofemoral region and the carotids. We then do CT for calcification, and recently CT angiography at the same time. And then we have MRI and PET of the large vasculature. And we look at the body in itself and then the brain. And then we approach this trying to see what relationship has with 4,000 parameters, which we use AI in terms of risk factors and this technology, and then multiomics on every aspect from genomics and so forth. Well, having said this, let me go into the critical technology that we developed and is now fully validated. And that is, this is basically a device, a 3D, that you put in the neck, iliofemoral region, and artificial intelligence tells you where the lesions are. And then you move, and artificial intelligence tells you what is the volume of the lesion, and this may appear in your phone, exactly what the volume is. You don't need technological expertise for this. We developed this in Madrid, and now it's being used here in this institution in the so-called PRICAT study. This is the basic technology of imaging. This is the PESA study, and actually we started 15 years ago, and the results are all coming in the last 2 years. And in green is what I presented here about a year ago. In red is what is new this year. The disease begins at age 30, particularly in the iliofemoral region. It progresses 33% every 6 years. Long-term risk factors in a young have much more impact in the reactivity of the arterial system than in the elderly person. A cholesterol that is high at age 40 has much more impact than at age 70. Well, all of this is actually in the references system that you have here. Then short-term, if you put your device at age 50 or 60 in the iliofemoral region or in the carotid region, what about cardiovascular events and mortality? We have the data, the bioimage, very, very related, and this actually was published very recently. What I want to emphasize today, what is new. What is the relationship of what we do that we think we can apply globally in high, middle, and low-income countries with coronary artery disease, and we have the data. The importance of microvascular disease, and finally, inflammation in the bone marrow. Let me begin to go into the study we just finished. This is a study of near 600 individuals that we look at first whether there was coronary artery disease at CT angiography. Mild or no disease, mild, moderate, and significant, more than 50% stenosis. What is in the abscissa? No disease in the carotids or iliofemoral region, carotid disease, femoral disease, and both. Look at here. If you have disease in the carotids and iliofemoral, you have a 75% chance that you are developing already coronary artery disease. The other way around, if you don't have disease in the carotid or iliofemoral, the chances of having significant disease in the coronary arteries is close to zero. So we are talking about a technology that is quite valuable in understanding if we are developing the disease or not. And if you have to summarize the data, carotid and iliofemoral disease actually are strongly correlated with early subclinical disease in the coronary arteries. Particularly, they are additive if disease in the carotids and iliofemoral are both present. What's very interesting is you rule out coronary artery disease of any significance if there is not by 3D ultrasound disease in the iliofemoral or in the carotid region. Most importantly, coronary calcium score didn't work in young people. And that is about 60% of the people who were developing early disease was zero, the calcium score. And you know why? Because calcium score is a healing. And in early age, what we are talking about is the development of the disease. So there's no time yet for calcium to take place. I think this is very important. Having said this, let's now move into the microvasculature. We all know what the microvascular is, but what I'm going to present to you is quite interesting. This is actually in about 900 people. And what we did is first, risk factors that can lead to subclinical atherosclerotic disease in the carotid, iliofemoral, and coronaries. But also at young age, between age 40 and 55, we see a lot of microvascular disease when we use magnetic resonance imaging and reserve, and myocardial reserve. And this is fascinating because it's not transmitted clinically. But you will see later on when we talk about the brain, the importance of this aspect of the microvasculature in cognitive dysfunction. I will be discussing this in a moment. And then the question of inflammation. We all talk about inflammation, but you know what we are talking about, the bone marrow. The inflammation comes from somewhere. And this is actually what we did, positron emission tomography, and this is very well validated across the world. And you can see how the bone marrow is activated in blue. And this is the large arteries, carotid or iliofemorals. You know what is in yellow here? Is the combination of monocytes and cholesterol. So you see activation of the bone marrow, you see disease peripherally. Well, the interesting aspect is what this has to do with acute coronary syndromes, with CHIP, that is mutations of the bone marrow, and with the risk factors that we talk usually. Well, let me talk about, first of all, about the acute coronary syndromes. What you see here is with PET, is the peripheral disease, which is the combination of cholesterol and monocytes. And that's very interesting with PET. But you might see with MRI fibrosis, this is when this is healing. No problem. Now comes, this is what we call actually compensated, and that is the so-called fatty streaks that were seen at autopsy. They become fibrotic lesions. And with two different technologies, you can see that. The problem is, when the substrate is very significant, the monocytes commit suicide. This is apoptotic phenomena. And they release cytokines. You know the two most important ones? Metalloproteinases, which may lead to plaque rupture, and tissue factor, which may lead to the thrombotic phenomena. In fact, we believe now very strongly that some of the acute coronary syndromes, perhaps most of them, is a decompensation between a risk factor, between a defense mechanism that decides to kill itself and the development of cytokines that actually make a devastated process in the artery with plaque rupture metalloproteinases and tissue factor causing the thrombus formation. This is about the acute coronary syndromes. But the question is the lipids the only attraction for monocytes? And it's not. In fact, here is we look at the volume of plaques, and here we see the relationship between plaque and you have LDL cholesterol. But you see there are other factors that are inflammatory, like fibrinogen and white cell count, that actually are even more significant. What it means that you may have a pro-inflammatory process that is not only guided by cholesterol, asking the bone marrow to help. And that's the issue that leads to CHIP. CHIP are mutations of the cells of the defense mechanism of the bone marrow. These mutations in 20 to 30% of the adults. This is very fascinating because this is a pro-inflammatory process when there is such mutations. Particularly, these are the two genes that are mutated, DMT3 and TET2. This is what we found in the PESA study, okay? So the question is what these mutations have to do. And since we follow individuals every 3 years, we now have the data, and this was published in Nature Medicine very recently, and that is the mutations take place before the plaque develops. So there's a pro-inflammatory process that leads to plaque formation and actually trouble. How this means clinically? You go to the TIMI trial. 5 TIMI trials show the relationship between CHIP and cardiovascular events in the upper line that you see in the slide. But there's even more. About a week ago, this was just published in the women's study. Exactly the mutations that we found, TET2 and DMT3A, they are very significantly correlated with coronary artery disease. So what I'm saying to you is we see many patients that no risk factors, but the risk factor is actually a genetic problem, and that is the bone marrow is affected by mutations, and you have a pro-inflammatory effect that has nothing to do with the conventional factors that we have today. CHIP will be very easily measurable probably within the next year or two, and will be part of the testing that we do in patients. Now, finally, risk factors. We all thought hypertension is a hit into the vasculature, the endothelium, but my friends, it's much more complicated. What we are finding is in the metabolic syndrome here, or even central obesity or hypertension, you see in blue, this is the activation of the bone marrow. And what we are seeing is that the risk factors that usually think they have an effect directly to the artery have a pro-inflammatory effect that goes to the bone marrow. And we see this with positron emission tomography. But this is actually not the end of the story. we're now working with the group at the Mass General. We have now data indicating that you can have a sedentary life or you can be activated. With sedentary life, so as we remember when I started platelets 50 years ago, nobody believed on platelets, only the hematologists. I can guarantee to you that all of you will be talking about the bone marrow in the next 3 to 5 years. This is my prediction based on the data that we are presenting. Well, this is all in terms of disease in the heart and in the vasculature that between age 20 to 60. This is what we have learned, and I think is fascinating, the microvasculature, the relationship between external imaging and coronary artery disease, and finally, what we have been discussing on the aspects of the bone marrow. Well, this being said, now we are beginning to understand the disease much more by going into health. But what about the brain? So all the technology I presented and more, we have used it in the brain between age 60 to 100. And I will be presenting 3 topics. First, the relationship between risk factor profile and cognitive dysfunction and Alzheimer's disease. Then I will present the issue of coagulation in the brain, which we didn't think was a problem, but it is in patients with cognitive dysfunction and Alzheimer's. And then finally, I will present chronological versus biological age. These are the 3 subjects we have been studying. First of all, there is data already evolving very rapidly that the risk factors that affect the heart also affect the brain. And we have a paper coming out in the next few weeks pointing out how significant is the literature in this regard over the last 3 years. Well, it's a pity. I don't know what happened with the slide here. But basically, here are the risk factors that we usually talk about cardiac disease, but there is diabetes, and then there is hypertension and hyperlipidemia, very important in the brain. You know, this is education, poor education. And this is actually, at the end of life, what really is the aspect of whether you are active physically or you are not active physically and mentally. Here you have it. So these are the risk factors, this is early life education, and here is actually isolation and lack of motivation. You know what? This is all critical in cognitive dysfunction, as I will be presenting in a moment. So this is the study as we started with about, I think it's a large number of individuals in which they had 2 of the 3 risk factors we mentioned, either diabetes, high cholesterol, hypertension. And we followed them over 6 years. This is the positron emission tomography entry of glucose into the brain. This is 6 years later if you have such risk factors. And this is now correlated with decreasing flow by MRI in the brain. And the question is, where is the problem? I think the problem, as you will see in a moment, is in the microvasculature, intimal thickening with the risk factors that affect cardiac disease. And this is actually very interesting that we are now testing this in the PESA brain study. This is a study of 1,000 people that we use all these technologies in the middle. Obviously, we look at cognitive function, and then in the blood, there are now biomarkers. As we use troponin for the heart, we now have NFL, GFAP, and so forth, affect slight injury of the brain. You see these biomarkers in the blood. Well, this being said, our hypothesis is very simple. We believe that the conventional risk factors, and particularly those that I mentioned, diabetes, hypertension, not well controlled, and hyperlipidemia, affect the microvascular of the brain. But you know how? When we talk about intimal medial thickening of the carotid arteries, this is happening in the brain. It's not necessarily atherosclerotic disease, but you see how MRI flow decreases with these risk factors, and then you have a problem with the uptake of glucose into the brain. We think this is the origin of a lot of senile dementia related to risk factors, and this is what we are addressing. And now something that you should be aware of. These biomarkers in blood are now providing a lot of good information. If 2 of these 3 biomarkers are present, the chances of having actually cognitive dysfunction are over 50%. If you don't have any of them, the chances are close to zero. Now, this is very expensive stuff, so you cannot just do these biomarkers. We have a grant, and it's a lot of money. It's just in measuring biomarkers. Very, very expensive today, but certainly with a tremendous future of what we are talking about. Well, this being said, now still within the brain, there is hope. I don't know how old you are, but you might be age 60 or 70, and you may say, too late. I already don't recognize my brother. Just a moment. Here's the story. There are 3 studies that are quite helpful and hopeful. The first is the US Pointer study of 5 centers, patients at risk or individuals at risk of cognitive decline and dementia. This was a structural approach of intervention. Very interesting. This had to do with taking care of the risk factors and at the same time taking the patients out of isolation. Social isolation is critical in cognitive dysfunction. And another factor is lack of exercise and lack of motivation. Well, they look at all of these and they found greater benefit of global cognition with a structural intervention. I don't present you the data, but similar data just came out, and this was published also in the United States, doing exactly the same thing, but with people who have mild cognitive impairment or early dementia. And they found exactly the same story. After a couple of years, you see stabilization or even improvement in the cognitive dysfunction. Remember, risk factors, isolation, exercise, and motivation, making your brain to work. These are critical issues when we talk about this aspect. And all the studies are beginning to show the same. This is a fascinating study in China. Uncontrolled hypertension, 33,000 people, they were randomized, treating the blood pressure very aggressively. They were able to drop 22 millimeters of mercury. All-cause dementia was lower in the intervention group. Very interesting data. What I'm really telling you is that the risk factors that affect the heart are affecting the brain. And if we don't believe that, we are not really good cardiologists. We should really move from the heart to the brain because it's a similar situation. Comes a little bit later in life, and the microvasculature appears to be critical. The second issue about the brain is clotting. Well, we published this in 2024, but our work began in 2019. And very basically it was in the mouse model. The concept is that one of the aspects of dementia is clots in the microvasculature. And you say, where this came from? This is actually the first study that we published in 2019. And this was in a very well-known mouse model that develops Alzheimer's. And the mouse model at autopsy, post-mortem, was small clots actually coinciding with the beta amyloid in the microvascular of the brain. And when we gave dabigatran at the same levels in blood that we see in humans that are treated with dabigatran, with atrial fibrillation, no clots were present. And actually, it was complete stop of the Alzheimer's phenomena in the mouse model. This was the beginning in 2019. But this has progressed significantly, and we have submitted this actually a week ago for publication. And that is, we are now able, in vivo, in the same mouse model, through positron emission tomography, to identify fibrin. And that is, in 24 to 48 hours after injection, you can see the identification of fibrin compared with controls. And this is, you see the images. This is the fibrin, actually, and this is the color, and this is the control group. And this is fascinating, because we are now able to detect clots in the brain through positron emission tomography. But there is more. What about humans? And this is the data that we just obtained, in which we can compare the identification of fibrin in the brain, and here is in the abscissa, in the right side at the top. And then in the vertical axis is the platelets. They are all correlated. And this is actually at autopsy. It was just labeling. And here is the blood clots in terms of fibrin in the brain at autopsy of humans with dementia. What we are really talking about here is something that is completely new, which is leading us to develop a significant trial of anticoagulation for the prevention of cognitive dysfunction in Alzheimer's. These are very complex diseases with many, many factors, but I am trying to tell you we're beginning to see the importance of risk factors, the importance of clotting, and so forth. Well, this is the story. about the clots in the brain. Finally, talking in the brain, I said that I'm going to call chronological versus biological age. All the newspapers and the televisions this talk these days, somebody died at age 2007. Well, look, I will tell you the data that is fascinating, that is evolving. Is your age really your chronological age, or you are younger or older biologically? That's the question. Well, the story is evolving very rapidly, and I think it's important to realize the following. The concept is beginning to be understood. There is a methylation of the components of the cells that lead to cytokine release. Bad news. It's like the apoptotic phenomenon of the monocytes. These cytokines affect all the other cells. Then the cells are not able to proliferate. This is the cells in the body in general. And actually, there is a question. Even if they proliferate, the telomeres are getting shorter, which is the supply of DNA in the moment of proliferation. So you have three aspects that in the literature are becoming very critical when you talk about chronological and biological age. And that is the basic of biological age is whether the cells are viable or not. And the issue of methylation, the issue of cytokines, and the issue of telomeres are being investigated very aggressively. Well, today we can measure methylation. The evolving technology is now with us. But interestingly, if you go to the brain, you can already begin to say chronological versus biological age. Here it is. The biological age is getting significantly handicapped if you have thin cortex here. If the volume of the gray matter of the brain is decreased, and if the density of the white matter is increased. So now the research of people working on methylation and telomeres and chronological age are beginning to realize that imaging of the brain is another parameter that you can look at. And this led to the cover of Nature Medicine actually last week, which is fascinating. This is the cover. And this is basically a young guy who is not exercising at all, he's all the day in front of the computer. And this is what in the future, everything that we are now measured, it will be measured. And this guy who appears to be young is actually pretty old. And I think this is evolving. So what I'm really saying to you, we have talked about mortality for a long time. We have talked a few minutes ago about cognitive dysfunction, but now we're talking about chronological age. What I'm really saying is all this new technology is evolving from the heart into the brain with aspects that are different and different ages, but I think are equally important. And now the interesting aspect in industry is that the sirtuins actually is a family that actually has a lot to do with the methylation of the cells that tend to the cytokines and the shortening the telomeres. So the question is, can you enhance sirtuins pharmacologically to make a biological age longer? And that's the issue that is now being entered into industry. I finish in the last 5 minutes about something we have been very intrigued. And that is all of what I presented is exciting, very exciting, at least to us it is, because it's really breaking through what is health and how we may prevent disease. But the question is education. And here is the issue that I want to talk about finally. This actually came out in the Lancet Commission. It was published a few weeks ago. And if you read, adolescents are the future leaders of our world. We must ensure their health and well-being to secure a more just society and a healthier and more productive planet. The future of the young people, whether we like it or not, that's what it is. Now the question is, what do you do about it? And actually, this graph is presented, and it's a fascinating graph, because you can see that if you do something before age 20, you may have an impact on these people. The question is where this data comes from. Well, I don't have to go into the details, but I have to say that I have a brother that has contributed significantly to the field. He's at UCLA in Los Angeles in neuroscience. And basically, this is the concept. And when you are young, under the age of 20, you have the receptors of the brain are in number is relatively small. And then what happens is whatever you tell a child, particularly under the age of 10, it sticks there. and it comes out when you are an adult. Just look who are you today, and you will remember how important were the first 10 years of life, your environment. That's the issue. What happened later on, everything gets dense, the connections between the receptors is very high, and whatever you tell a guy from this ear gets out in this other, because it's very complex, it's very chaotic. So the question is, can you infuse health at young age? That's the question, based on this biology. And so we developed 4 programs in over 7,000 children, all randomized, in which one group was actually intervene, how the body works, food habits, physical activity, to control the emotions, to tell them you are in charge of yourself when somebody brings drugs, when you are older and brings alcohol and so forth. Self-esteem, very important. And then these done, these 4 aspects are presented over 6 months or in 60 hours. And the other groups serve as controls. 4 randomized studies. The first one was in Bogota and Harlem, New York, 2 completely socioeconomic entities, very different. The results were fantastic at 2 or 3 years of follow-up in terms of knowledge, attitude, and habits in the group that served being intervened versus the group that served as control. And the same in Harlem. The total of children that were intervened in both aspects were close to 2,000. This just came up last week. For the first time, the global prevalence of obesity has surpassed that of underweight among children and adolescents. This is across the world. And the main reason, unhealthy food environments. I don't have to get into this, but that's the problem. Now, here's the issue. The children that we did in Harlem and Bogota were 3 to 5 years of age. You cannot measure anything, obesity and so forth. You can only go knowledge, attitude, and so forth. So we went into all the population. Most of the children we intervened within 8 to 10, near 2,000 children in Madrid, Spain, and they were randomized into exactly the same process I mentioned before. What happened 3 years later? This is the quantification of fat by the most modern technologies of fat identification. This is BMI, in the control group, in the group being intervened. This is the circle of the abdomen, the control group, the intervened group. And this is the relation of the height and circle of the abdomen. Trying to say you, for the first time, a study shows that in young kids, you can have an impact in terms of obesity and fat deposition. And I think this is very exciting. But the third project is interesting. There are not always good news in research. What we found in the group of Bogota, that is the first that we intervened, is that if they really were compliant to the intervention, they did very well, but those who didn't comply didn't do too well. But bad news at 10 years. They were intervened at 3 to 5. 10 years later, we went to them and said, how you are doing? Bad news. There was no difference between the control group and the intervened. And we say, maybe we have to do something about it. And we found that adherence was important, but most important was reintervention. When we reintervened, here in blue, the group that were intervened before, the results are exponential. So reintervention is critical if you want to have some effect. And in us as adults, we have a lot of data, not only on health, on everything else. If you are up there, if you not reintervene or you don't do something about it, you will go down. So I think it's an issue that we see in children that applies to all life. But it's very fascinating, the issue of intervention. We have good data until age 16. We don't know more reinterventions later or how long you have to do this. And the final study is the control groups did reasonably well, much better than would be expected. Why? Because if you go to a school and you intervene, the control group is in an environment of intervention. They begin to take care of themselves too. So we found the importance of the environment. And this led actually to the family project. And this is fascinating. We now get into families with the 4 aspects that I mentioned before. But here the intervene is the parents, the children, and the grandchildren. And actually the results are fascinating when the environment is involved. So this is much better than just go into a school system. But even more, in Colombia, I think in 2 or 3 countries, in in Latin America, we went to the waiting rooms of the doctors and we put a video. Do you want to participate as a family while they wait there to be seen? And they check up. The results are fascinating. What I'm saying is this is leading to something that is very interesting, and I'm going to finish. First, what we have learned with children, over 7,000 children, all randomized. By the way, today we are working with 50,000 children around the world, all randomized study. Adherence is critical. The environment is critical. The sustainability with intervention is critical. What is this question mark? How these kids are going to be at age 60? How many times we have to reintervene? We know now until age 16, but we don't know later. I mean, that's the key question. And this leads to something that the American College of Cardiology made a decision very recently, and is to work between 26 to 35, a roadmap in which I will be really driving primordial prevention across the world by training cardiologists and physicians to work in their communities and to work in their environment, to teach what we are teaching and see if we can have an impact by dealing with children at different ages and having an impact on health. This is actually a last statement of the last commission that I presented to you a minute ago about children, presented in the Lancet. The investments made in this generation of children and adolescents will determine human and planetary futures for good or for ill, and the time is to act now. I just finish by saying to you the following. I try to present to you something that to me is quite very important of all of us who deal with medicine and cardiology, and that is to take into account there are 3 H's. Imaging is evolving. It's evolving in the hospital, but it's also evolving globally. We are really moving globally with this technology that I presented to you. The brain, we cannot disregard the reality. The brain is being affected by the same aspects and risk factors that affect the heart. In addition, isolation, poor education at young age, there are other factors, and the issue of clotting is also evolving. And finally, if you're asking me, what would you like to do in the future that might have impact in terms of health? I would go into childhood. That's basically what I reached after many years of working all sorts of things about clots, coronary arteries, and so forth. This is prevention, but rather than prevention, I would call it education. Thank you very much. I think you can leave it. No?
Do you want questions now?
Okay, no problem.
Okay, so let's take some questions now. And anyone that has questions, please use the Slido so we can get through them efficiently. There's some great questions here. But before I get to the questions that people ask, I actually have to ask a question. That was really outstanding. I'm sure everyone in the audience feels that way. And it's incredible what you're personally doing for health right from infancy all the way to the end of life. That's remarkable. I don't know anyone else that's doing that sort of thing. So you talked about dementia. I'm going to talk about that end of life because, you know, perhaps people in the audience here are more worried about that end of the spectrum than the beginning end. You mentioned things like lipid lowering, the microvasculature, blood pressure control as ways to reduce the risk of dementia. And that's something that everyone here, of course, can do and can help with. But you also mentioned another pathway to prevent dementia, which is a bit harder, that is preventing things like social isolation, engaging older people. How do you see bringing all these together to actually make an impact on dementia, which around the world right now is, I mean, it's a real crisis. People are living older. There's a lot of folks with dementia.
Yeah, I think isolation is becoming, I mean, it's in the literature. In the last 3 years, the literature is evolving very rapidly. How can you change isolation? I mean, society has to be aware that isolation is a problem. It's a culture that we have to learn. Once the culture is there, I think we can make a change. On individual basis, you can certainly work in your family. I was actually very interesting. My father was a psychiatrist, and he always told me, as older you get, be sure you are always motivated. And I say, why? Because your brain will be clear. This was my father was a psychiatrist. And I think he's right. It's now becoming very evident that it's not only the isolation, but but you have to be motivated. Your brain has to work. You cannot go home and go to bed. You just have to do things that motivate you. This is a very important issue. And the other one that is evolving is education at young age. And that is whether you are highly educated or not. How you change this, Deepak, I think is a matter that we talk about it. And that's why I am very happy to be here, because there are people who can have influence to people and to develop a culture on this. I hope it will work. May take 10, 15 years, but I think the culture will come.
Yeah, no, really helpful answer. Terrific. Thank you. So let's just go through some of these questions here. Maybe we can start with this one on clots in the microvasculature. I was wondering about that too. You showed some intriguing data there. But is any implication of that, for example, if someone has atrial fibrillation, they're taking an anticoagulant, does that, of course, it lowers the risk of stroke and it reduces the risk of stroke-associated vascular dementia, but how about the risk of cognitive decline in general?
Atrial fibrillation, unfortunately, dementia has been pointed out in the literature, cognitive dysfunction with atrial fibrillation. And the whole thing there are microclots, I believe. I mean, that's what you see with MRI. And that is, you may give anticoagulants to a patient to prevent a stroke, but I'm not entirely sure you are preventing the very tiny clots that may go to the brain. This is my interpretation of the dementia in atrial fibrillation, but I think the question of anticoagulants is becoming an issue in cognitive dysfunction, and we are now in the process of developing a huge trial that is addressing the issue I was talking today about the small blood clots. I believe the blood clots have something to do with the risk factors. I don't want to get into this, but I think this is my feeling. So we are dealing with risk factors, and maybe we'll have to deal with anticoagulation.
And this question about the bone marrow inflammation, how much exercise and what type would reduce bone marrow inflammation?
Well, we don't know. Actually, we are working with your friends in Boston on this. We don't know how much exercise, but we have already data in PESA and in Boston independently that exercise makes a difference in terms of the bone marrow activation. It's much less activation of the bone marrow with significant exercise. I cannot quantify because we are going over the manuscript. I cannot quantify for you how much exercise it makes a difference.
Sure. Now, but at a minimum, one can state that exercise is beneficial among many other reasons for reducing inflammation as well. Any thoughts about preventive screening measures such as bone marrow PET? I don't know that I'd really call that a preventive measure, but bone marrow PET or biomarkers on screening?
Not really. Frankly, in the future, I see to put the device. You don't have to be an Einstein. Put the device here and there, and the phone will tell you if there is disease or not. The highest risk factor, and we have a lot of data, is if the disease is there. That's the highest risk factor. That's why also calcium score is important. You know, in the older people, I believe, and you will hear this in a few minutes. But I think these are issues that are easy to do and so forth. I wouldn't go in terms of biomarkers to try. I don't think we reached that stage yet. This is all investigational.
Yeah, absolutely. The FDA, with respect to Alzheimer's, did just approve a biomarker for looking at that. But yeah, much of this is investigational. And I think the final question we'll take here is just the bottom one. How young should cardiologists start screening for patients for subclinical athero, whether it's calcium scoring, well, although you pointed out the limitations already of calcium scoring in the young, lipoprotein analysis, or 3D ultrasound?
Frankly, age 30. There are some people who develop disease earlier with familial hypercholesterolemia and so forth, but in our study of over 4,200, well, actually we have done this in 12,000 people now, is age 30 is the time to start, because this is when the disease begins to start. No? So I think the guidelines, all these the guidelines at age 50, Framingham, this is fine to me, but it's old. What we have to do is much earlier, imaging, and then at age 30, begin to do our job if we can. The only problem, and I finish, is that hypercholesterolemia at age 34, 35, the young people don't like to take a statin, so we have to take another approach.
Yeah, well, even the older people don't like to take statins, is the truth. Thank you so much. That was really brilliant. All right, if we can cue up Dr. Martin's lecture next so that we're ready to go. AV group, if you can pull that up now. That was really brilliant from Dr. Fuster, truly a keynote lecture in every sense of the word. Next up now, we're going to actually start our top 10 theme for the rest of the day, going through the top 10 advances in a variety of different areas of cardiovascular medicine, somewhat rapid fire. So keep the questions coming, please. If you, as you think of it, go ahead and put it into Slido. So Dr. Martin's going to speak about the top 10 advances in lipid management. He's a professor of medicine at Johns Hopkins. He's the director of the Ciccarone Advanced Lipid Disorders Clinic. He's also the director of digital health innovations at Hopkins. He has a variety of other leadership roles, including in the Osler Medical Residency. He was actually named one of the top people at Hopkins in terms of their global mission to improve patient care. So really a giant in the field of prevention and lipid lowering, and we're lucky to have him here to give us an overview of what's new in the lipid lowering field. Dr. Martin.
Well, good morning, everybody. Let me start by thanking Dr. Sharma, Dr. Keeney, Dr. Bhatt. It's truly an honor to be here amongst such incredible leaders and luminaries in cardiology. So thank you very much. Okay. These are my disclosures. So number one, I wanted to start with PCSK9 inhibition. So this has been around. We've now had PCSK9 inhibitors for a decade in clinical practice, and it's truly been a triumph of bench to bedside, and has been very useful in clinical practice, but we're still learning and still adopting PCSK9 inhibitors. The monoclonal antibodies are what we have had for the last decade, and these are data that have just emerged that I thought were really interesting, published in JACC by Kash Ray, along with Dr. Bhatt and Dr. Harrington, the whole Odyssey investigator team, showing earlier time to benefit with alirocumab in post-acute coronary syndrome patients in those that have elevated LPA. So what we see on the left-hand side here is that if your LPA is less than 50, the time to benefit was about 3 years. If it was 50 or more milligrams per deciliter, the time to benefit was closer to 1 year. So really a significant difference there. That level of 50 milligrams per deciliter, if you're using nanomole per liter units, would roughly be equivalent to the 125 nanomole risk threshold, which is a risk-enhancing factor in our guidelines. So I think these are further data that if someone has high LPA and they meet eligibility for PCSK9, we should be especially reaching for this class of therapy in them. And then the other key monoclonal antibody therapy that we have is evolocumab. And the latest kind of hot off the press announcement, the top line results are from the Vesalia CV trial. The unique aspect here is that these were individuals that did not have a history of cardiovascular events. They had coronary disease without MI, CVD, without a stroke, peripheral arterial disease, and advanced diabetes. They had LDL levels of a 90 at baseline, so 20 milligrams per deciliter higher than the prior Fourier trial. And so these are exciting results that we'll be learning more about at the upcoming AHA meeting in November. And then when we, looking beyond the monoclonal antibody therapies, we have the approach of silencing the PCSK9 gene with siRNA therapy, which is already into clinical practice with inclisiran. This turns off the production of PCSK9 in the liver. And what the unique aspect here is the frequency of injections every 6 months instead of every 2 weeks with monoclonal antibody therapy. And although we don't yet have the pivotal cardiovascular outcome trial data yet for inclisiran, we do have encouraging early data from the trials that have been completed to date. Sticking with the PCSK9 theme, but moving on to a totally different strategy with gene editing, I wanted to acknowledge the progress that's being made by Verve Therapeutics. They were just acquired by Eli Lilly. Congratulations to Sek Kathiresan and the whole team. These are data from their Verve 101 product, which was used in 7 individuals, including one highlighted there who had a history of heterozygous familial hypercholesterolemia, had suffered a heart attack before the age of 30. You see the trend there with an LDL cholesterol reduction time averaged at 58 reduction over 2 years. So this is evidence that this is potentially a one-and-done strategy of injecting, getting base editing of your PCSK9 gene and having sustained LDL reduction. And then we have a number, really additional progress being made here with the VERVE-102 compound. So this adds a GalNAc targeting ligan to avoid some of the off-target effects, and is really what Verve is going to be moving forward with. And so here we see a 60% PCSK9 protein reduction, as well as a more than 50% LDL reduction using this VERVE-102 product. There's multiple companies in this space, so I can't go through all of them, but one other notable Nature Medicine paper just came out from Chroma, showing an epigenetic editing approach where you use DNA methylation. So you're not cutting the DNA, but you're modifying its expression through DNA methylation. And so here, this was done in monkeys, whereas the Verve data are coming from humans, but in monkeys, really strong PCSK9 reduction, as well as strong LDL reduction. So it'd be interesting to follow the multiple companies in this space, because it really could be game-changing for the way we practice lipid management in the future. Meanwhile, something that is closer to getting to clinical practice than the gene editing therapies is obicetrapib, or OBI, which could be a really interesting comeback story for this class of CETP inhibitors, where there's been 4 notable failures previously. Obicetrapib is being developed, and the trials are being powered based on the LDL cholesterol lowering rather than the HDL raising property of CETP inhibitors, which is what was done with the prior drugs. Obicetrapib blocks cholesterol ester transfer protein. This blocks the transfer of cholesterol esters from HDL to LDL, but what's been also shown is that there's an upregulation of hepatic LDL receptors, such that obicetrapib has a similar mechanism to what we see with statins and ezetimibe and PCSK9 inhibitors. I like to think of those LDL receptors as the garbage trucks of lipid metabolism, and so really that's the central way that we modify lipids, and OB having that mechanism makes it promising, I think, to ultimately show the cardiovascular outcome benefits. But what are the latest studies that we have with obicetrapib? So the Broadway trial was in patients with heterozygous FH, as well as with atherosclerotic cardiovascular disease, showed a more than 33% reduction in LDL cholesterol levels, and encouraging safety data. And then we have the fixed dose combination strategy shown in the Tandem trial. So here obicetrapib is being combined with ezetimibe, and you see on the lower blue curve here at the bottom a more than 45% LDL cholesterol reduction that's achieved with this combination therapy. So this is a similar strategy to what's already been taken with bempedoic acid and ezetimibe as a fixed dose combination. This 45% reduction is on par with what you would get with the combination bempedoic acid and ezetimibe, and on par with what you can get with the lower dose of alirocumab, as well as in the same ballpark as inclisiran. So this leads me then to number 4, that we're doubling down on the use of combination lipid-lowering therapy. And so this is a nice figure that came from the latest European guidelines that were released this summer at ESC. Our US guidelines are forthcoming in early next year. But what we're seeing is an embrace of combination lipid-lowering therapy. We had a non-statin consensus pathway from ACC that acknowledged the opportunity to use more combination lipid-lowering therapy. I think we'll see that cemented in the forthcoming US guidelines, and it's been shown here in the European guidelines. So we've really moved solidly from a time of focusing on statin monotherapy, where we could get upwards of a 50% or so LDL reduction, to now moving solidly beyond statin therapy for those patients who need multiple drugs to get to goal. We can get a 60 to 80% plus reduction in LDL cholesterol levels. This can be particularly helpful in patients who have trouble tolerating statin therapy, as well as patients that are just starting at really high levels, such as with familial hypercholesterolemia. If you use a combination of high-intensity statin, ezetimibe, bempedoic acid, PCSK9, you can get an 86% or so reduction in LDL cholesterol levels. So I have a patient with homozygous FH who started with an LDL level close to 1,000, had an ileal bypass procedure at an early age. She's on that quadruple therapy plus evanicumab and has now an LDL in the 50s. So it's just incredible what we can achieve with modern combination lipid-lowering therapy. And related to this concept, number 5 is the traction with reducing long-term cumulative exposure to LDL. So we can go low, but along the lines of what Dr. Fuster spoke about so elegantly is the need to look earlier and to reduce risk factors earlier in life. And so we have genetic data that if you are lucky to be born with low LDL and have lifelong lower LDL, the amount of risk reduction related to that is quite sizably bigger than you get with later introduction of lipid-lowering therapy, speaking to the importance of long-term cumulative reduction in LDL cholesterol levels. And then we have the data from the PCSK9 trial showing that we can drive LDL levels down to the lowest levels below 20 milligrams per deciliter, and it further reduces ASCVD risk, and it's completely safe. It does not cause increased diabetes, liver issues, cognitive issues. And in fact, that's been studied very carefully, the cognitive side of things. And in the long term, one can certainly think that doing this earlier in life could be beneficial from a brain standpoint. So all of this leads to the new paradigm, lower for longer is better. And so the data are there, but it's really a matter of implementing this in clinical practice. When we think about how to find people earlier in life, one new innovation is the PREVENT equations, which are starting to be adopted into US guidelines. They allow us to predict 10-year and 30-year risk, including it starting at younger individuals. It adds new risk factors like A1C, UACR. But we have to be careful about the way that new risk equations are implemented. So this was a recent paper in JAMA, and you see on the y-axis here those who would be eligible for statin therapy, and on the x-axis their 10-year risk. And so if we use the pooled cohort equation shown there in the bluish green color, that's with the pooled cohort equations compared to PREVENT there in the yellowish orange color. If you estimate using the existing risk threshold of 7.5%, there would be more than 10 million fewer people eligible for statin therapy using the new risk equations, because it gives a risk that's quite a bit lower. So we have to be really careful with the way that these are implemented, and I think you'll see that addressed in the forthcoming guidelines early next year. Beyond risk equations, we can measure single biomarkers like CRP, LDL, LPA. This is a paper from Paul Ridker and team teaching us that these, in healthy women over 30-year timeline, these individual biomarkers are complementary to each other in risk stratifying, so that could be used as motivation for earlier prevention. Sticking with the biomarker theme, and I know it's a talk about lipid management, but we use biomarkers to make clinical decisions about lipid management. Typically, we use LDL cholesterol levels, but there's been increasing interest around apolipoprotein B. ApoB is a complementary metric to use for clinical decision-making. This was a recent National Lipid Association statement that I was part of around ApoB, where we recommended a threshold or a treatment goal of 60 in relation to 55. You could simplify that just using 55, as I'll mention in a moment, for the as the equivalent LDL to an equivalent LDL 55 in those very high-risk patients. You can use 70 and 70, so 55 and 55, 70, 70. I wouldn't recommend using an equivalent at the higher LDL threshold of 70. It doesn't, the higher LDL threshold of 100, it doesn't work as well in ApoB. It really should be around 80 or 90 at that point. This is a nice review paper from Anne-Marie Navarre and the UT Southwestern team depicting ApoB. There's one ApoB for every LDL and atherogenic particle. So you can think of it as a metric of LDL particles. The ApoB you can think of as kind of that stitching on the baseball wrapping around those LDL and atherogenic particles. They had this really nice figure in the paper showing that on treatment ApoB levels are similar to LDL levels, which really can lead to that justification for having an equivalent goal of 55 and 70. But again, it doesn't work as well at the 100 level. So when we look at the concordance of these across clinical categories in individuals in a large lipid database that we have, there really is quite a good amount of concordance. But there are people who have elevated ApoB that's discordantly elevated who have controlled LDL, and you could then thereby use ApoB as justification for further intensification. I don't think you need to check it every single time in all your patients, but you could do it once, and if it's discordantly elevated, it could lead to treatment intensification. Why I say to be careful about the 100 level is there's a large amount of people who would have an ApoB that's below 100, who have an LDL above 100, and I would be cautious to undertreat those people just based on ApoB. This is great data from one of our fellows, Allison Peng, who was formerly at Stanford, Hopkins now, is going to be presenting these data at AHA, and hopefully he'll have a simultaneous publication with that. LDL cholesterol still is the main metric we use to make decisions around lipid management. I want to just comment briefly, because this is a topic I've spent a lot of time on, around the accuracy of LDL equations. There's been more than 20 equations published in the literature. The classic equation is the Friedewald equation, but the Sampson NIH equation has been one of the newer innovations. And the latest paper to come out here is the modified Sampson equation. And this is a figure on the left here that shows LDL levels along the x-axis and bias compared to ultracentrifugation on the y-axis. And the modified Sampson equation is shown in red. So interestingly, the modified Sampson equation does solve some of the underestimation with the prior version of the Sampson equation at low LDL levels. But it has this kind of weird trajectory where it then overestimates, where it underestimates as you go higher. And we've now tested in our own data and find the modified Sampson equation actually overall performs worse than the original Sampson equation. You see my equation there in blue, and even in their data, you know, these are data where you're doing an internal validation based on equation they derived in that same data set. So even when you do an external validation of our equation shown in blue, it's performing quite well there with a bias close to zero across the range of LDL. So I still would, and I'm biased in this area, but would definitely encourage the use of our equation, which has been adopted by Quest and many other labs. Some labs have had a limitation of their IT systems to implement the original LDL equation we have. So for that reason, we've developed a machine learning version using an approach called MARS that allows for a transparent equation as a single line of code that can be then implemented in lab IT systems. So we're presenting that as well at AHA. It shows comparable accuracy to the original version of the equation, but could be more easily implemented by some labs. So be aware of where the LDL, how the LDL is being calculated by the lab by which you're getting. If you get it from Quest, it's going to be using my equation. If it's from LabCorp, it's going to be using the NIH Sampson equation. So there could be a little more underestimation from LabCorp. From other labs, it can be, and you know, it typically should be specified on the lipid lab report. And we also have a free smartphone app if you want to type in the total cholesterol, HDL, and triglycerides and calculate it yourself. We were actually playing around with that last night with somebody. Okay, so advance number 7 is the, and this ties in a bit with what Dr. Fuster was speaking around, where there's limitations of CAC, but when you get into middle age and older individuals, CAC can be a way to identify risk that wasn't previously appreciated. And there's been a lot of interest around the use of incidental CAC, which can be identified visually and qualitatively, or using AI tools to quantify CAC. A lot of the work here has come out of from Stanford. This is a nice review article that covers the opportunities here. And basically, if you have someone that doesn't have CAC, they can typically focus on lifestyle and not as intensive pharmaceutical strategies. Whereas once you start identifying CAC, you want to be more intensive around lipid management. So CAC is really, I think, helpful in lipid management for this reason, that can tell us how, should we be setting the LDL goal lower. one of the key trials here using this strategy of incidental CAC. So these are CAC scores that are being found on non-gated CT scans. They were done for non-cardiology reasons. We're getting this information, it already exists, and now we're extracting this information and using it clinically. These were data from the Notify trial, which was led by Alex Sandu and Fatima Rodriguez and the Stanford team. Interestingly, they showed that of those people who had this notification to their physician of incidental CAC, about half started on a statin. And I was really pleasantly surprised by the persistence. So they found when they looked out at 12 months and 18 months, it was 95 and 80% persistence on statin therapy. I was not expecting it to be that high. And they are seeing the LDL budge downward. So this is really encouraging, and I think there's an opportunity to then layer more strategies on top of this incidental CAC strategy. And of course, you'll be hearing more about imaging later. So I'm gonna move on to digital health and implementation. I think this is really key, and and of course ties in with some of the AI discussion earlier. It's just so shocking how much the mountain of evidence we have around lipid management and how little it still is getting implemented reliably in clinical practice. And I think that scaling up digital health paired with protocolized care and implementation strategies is going to be really key here. So we're talking about smartphone apps, wearables, AI. There's a wide spectrum of health applications here. This is a figure from an article I did for the 100th anniversary celebrations of AHA as part of the Centennial Circulation Series. And I think we're going to see AI and digital health impact every aspect of the patient journey, from primordial prevention to primary prevention to secondary prevention and long-term care. One example of this is the Cori Health Lipids program. That's something that's a homegrown app that we developed a decade ago and have iterated on since. It's been used in post-MI care, cardiac rehab, and now we have a lipid-focused implementation program which is supported by the Lattice network, which is an implementation science network. And along the lines of what was mentioned earlier about kind of moving beyond death by pilots to implementing, the app is well developed. It's been used by many patients. We want to get up to 1,000 patients as fast as we can in an implementation science framework. So we're using the REAIM framework. So we're giving the app, it has animated educational videos that can engage and activate patients in their care. We're setting a rapid titration of combination lipid-lowering therapy to ideally get them to their goal within 6 weeks or certainly within 6 months. And so we'll see how this works. We want to get to 1,000 patients across 3 institutions as fast as we can, and then scale up hopefully more from there if things are working. As I get towards the end, advance number 9 is LPA. So of course, this could be a huge game changer in cardiology if this pans out in the cardiovascular outcome trials. We have the monoclonal antibody therapies already lower LPA 25%, but the drugs in development can lower LPA 80, 90+%, including siRNA therapies, small molecules, antisense oligonucleotides. So we're expecting next year the results from the Horizon trial of pelacarsen and then the results of olpasiran not long thereafter. So we're going to find out very soon the clinical benefit that can be realized with directed LPA lowering. As we await those results, I think we can use LPA as a risk-enhancing factor. I showed you the data from Odyssey earlier that it leads to earlier time to benefit. We can drive down LDL and mitigate other risk factors. We can enroll patients in LPA RCTs, including now an RCT of those with subclinical atherosclerosis. And there's also something that I found about recently is the olpasiran expanded access program. I actually have a patient that just got approved for that and is going to get injected on Tuesday as part of that expanded access program. And then we can cascade test LPA in family members, including younger members in a family, and inspire prevention earlier. So as I get to the close, I wanted to then also acknowledge the shift from the sort of more the LDL focus to the triglyceride focus, where it's really fantastic to see the progress that's been made around pancreatitis reduction with ApoC3 inhibition. This is in familial chylomicronemia syndrome patients who started with triglyceride levels over 2,000. These were reduced significantly with olezarsen and nearly eliminated acute pancreatitis, really strong risk reduction. 71% of the patients had pancreatitis in the past, and here the rate ratio is 0.12 with olezarsen. This has been approved for use in FCS. I've started using it in some of my patients, and it really is a valuable addition to clinical practice. And then there's other drugs in this area as well, including plozasiran, which has less frequent dosing given its siRNA strategy of targeting ApoC3, and has similarly shown an impressive reduction in triglycerides along with a strong risk reduction for pancreatitis with an odds ratio of 0.17. So this brings me to the end, my top 10. It was the PCSK9s and all the new data and experience we're learning there. Gene editing strategies, that could be a one and done strategy. OB as a potential comeback story for CETP inhibitors. The movement towards combination lipid lowering therapy, because lower for longer is better. And to guide our lipid management, we have ApoB as an LDL particle measure. We can use incidental CAC, and you'll hear more, I suspect, this morning about broader use of CT imaging for atherosclerosis to guide prevention. There's digital health and implementation strategies that I think we're going to help scale up in our health systems to better implement all that we know. And then in the future, there's LPA therapy very closely to coming to practice, and ApoC3 therapy, which is already in practice, and I think could have a much larger role in the future. So thank you very much. If I can just have one moment, I wanted to share these pictures of my sons from the ASPC meeting in Boston. They had a great time at the Boston Fire Museum. My son was still wearing that same shirt the next day when we were going down the elevator for breakfast, and we ran into none other than Dr. Deepak Bhatt, and my son got to show off his shirt and his badge to Dr. Bhatt. So thank you again for the invitation to be here. I'm looking forward to the rest of the day.
All right, yes, if you can pull up Dr. Budoff's presentation so we don't lose a minute here. But we will take some questions. There are thousands of folks online already, and so great to see the interest in the room and virtually. So let me start with this question saying, I request a direct LDL on all lipid measurements. This removes the problem with calculating LDL. Do you have any thoughts about direct LDL? I personally do measure it myself.
Yeah, that's another option. The gold standard is ultracentrifugation, which is something that we typically don't have access to in clinical practice. So the direct LDLs use proprietary chemicals to block the non-LDL lipoproteins to attempt to measure LDL. So there can be variability in how well they perform. They're not standardized by the CDC, but that is another metric you can use to assess LDL. But I would still highly recommend using the most accurate equations if you can.
Yeah, no, that's great advice. And it seems like you're a believer in ApoB
Yes.
as well. Great. If you've got a person in the highest quintile of LDL, Lp(a), and hsCRP, but with a CAC score, coronary calcium score of 0, would you still hold off on starting pharmacological therapy?
Not necessarily. So if someone has familial hypercholesterolemia, for example, with really high LDL, we're definitely going to treat regardless of a coronary calcium score. And it does depend on the age at which the coronary calcium score is done. As Dr. Fuster was pointing out, there can be limitations in doing a coronary calcium score at a younger person, so that would matter a lot. So the simple answer is I would say I might hold off, but in many people I still would not hold off, especially if the levels of the biomarkers were particularly high and it was a younger individual.
Yeah, I'm with you on that. I would, if the LDL were high enough, and there are additionally these other risk amplifiers like Lp(a) and hsCRP, I personally would still treat. And the final question here is how can we use pharmacogenetics to find the best lipid-lowering therapy for hyperlipidemia that does not respond to initial statins?
This is a really interesting question. There's been some attempt there actually in the CTP world. It didn't pan out. So I don't know. I think the short answer is I don't know about that one yet. But
yeah, no, I mean, I think it depends on evolving data, really. Here, for example, Mount Sinai, we're genotyping 1 million patients, not just in cardiology, that's throughout the hospital and health system, and we're up to, I think, about 400,000 or so. And, other health systems around the world are doing that sort of thing as well, maybe not quite on that scale. But I think when all the data are in, we might have an answer. It's a good question. We don't know right now. Well, fantastic. Really wonderful lecture. Thank you so much. So let us move on now to the top 10 advances in imaging with Dr. Matt Budoff, who is an endowed professor of medicine at the Harbor-UCLA Medical Center, has been a leader in imaging and prevention for many years, heads up the preventive efforts there as well, but has also been a leader in imaging. I must say there's sort of a marriage of prevention and imaging that's going on nationwide, and he's been leading that charge as well. He's been named the top physician in California by their chapter, by the chapter of the American College of Cardiology there. He's won the gold medal from the Society of Cardiovascular Computed Tomography. He's just really a leader in both those areas. And maybe this is premature to ask because we'll see what your top 10 are, but at the end I would want to know what your answer is as well about CAC of 0, because at least for a while the Society of Cardiovascular Computed Tomography was advocating, at least on social media, the power of 0. And what if a calcium score is 0? You don't need to worry about anything. That it's a little bit discordant from at least what Dr. Fuster said and Dr. Martin said. So we can come back to that if you don't cover it. But please welcome Dr. Budoff to the stage.
Well, thank you very much, Dr. Bott. It's certainly a pleasure to be here. I'll touch on, I don't know if calcium is my top 10, but I'll certainly touch on that at the end if I remember. These are my disclosures. So I reached out to my colleagues in other imaging areas. I'm not an expert in all things cardiac imaging, but I reached out to some of the past presidents of the different societies and got some of their top ideas as well. I'll do it backwards from what Dr. Martin presented, and I'll start with number 10 and work up to what I think is the most significant advances. But we heard a lot about artificial intelligence already this morning, and certainly it's going to help us in, I think, raising the bar to at least a moderate level. So I think AI for imaging helps the people who are the least empowered. So, and you saw that as well with the errors that was pointed out by Dr. Rich in the first talk. The experts probably derive less benefit from AI, and the novices derive more benefit. But for something like Echo, where there's a broad range of readers, it really can raise the bar quite a bit. And there are now some very powerful AI tools to help us read Echo. And it's not just improving the interpretability, but improving the image quality, helping the techs acquire better images, and real-time AI feedback to improve time. So it enables care teams to expand capacity. It really, I think, importantly adds higher quality diagnostic images to any technologist. It'll improve their ability to acquire images, and I think it'll speed up and maybe improve interpretation and reporting capabilities. We don't really have great proof of concept yet that I've been able to find, but in this one paper, it did reduce quantification time by 51% for the readers. It saved 82% of time for acquisition and analysis by the technologists, and it did reduce the echo exam time by 20%. So I think acquiring data faster and maybe more on a level playing field will be helpful. Moving on to number 9, this is called FAPI. It's used with for myocardial fibrosis. I think you'll hear a lot about fibrosis, maybe even in the talk on hypertension. We're talking about new agents that might help us with fibrosis. But FAPI, it looks at fibroblast activation protein inhibition. It's done with a PET scanner. So you can now look for activated fibroblasts in the myocardium. So this is going to be helpful for fibrosis of the myocardium. It's going to be helpful for remodeling and really targeting many chronic diseases. So we're going to have it potentially be helpful in post-MI infarction for who's at risk of remodeling. It's going to help us, I think, with hypertrophic cardiomyopathy. It certainly has a role in heart failure, and it might even help us direct which drugs to use. If we have drugs that are good for fibrosis, there are some of the newer things like the non-steroidal aldosterone agents that might have some antifibrotic activities that might be helpful. And the extent of the FAPI index, or the more fibroblast activation that we see, correlates with disease severity and risk of sudden death. And this is just a pretty picture showing on the left, you can see the uptake of this in a patient with dilated cardiomyopathy and the potential use of this to identify patients at higher risk or more active disease. Number 8 is, I think, still being utilized a lot, maybe not quite as novel, but I think I'll show you some interesting new data. But FFRCT, or fractional flow reserve estimated from a CT angiogram, anatomical testing, I think, is where we're headed for a lot of first-line diagnostic testing. It's certainly more accurate than functional testing as far as who has obstructive disease, and for the interventionalists who might need intervention, but we lose something if we don't have functional anatomy or physiology, and that is we don't understand which lesions are physiologically significant. And I read a lot of cardiac CT, and I see a lot of moderate and even some severe disease, and not all of those lesions definitely need revascularization. So if we can guide not only in whom may need revascularization, but which vessels may need revascularization, that might really help us target different therapies and different approaches to revascularization. So with FFRCT, we can now model, again using AI, we can now model which vessels have physiologic significance, and red is bad, is lower flow. This has been highly validated against invasive FFR, and you can see that it really helps us in deriving which lesion might be most amenable to revascularization or where those lesions are. It does raise our accuracy as well for when we use FFR, invasive fractional flow reserve, as our gold standard, and this was the Pacific study. They looked at a SPECT in orange, not very accurate for physiologically significant lesions. It had an AUC of 0.7, so think about 70% accurate, not great. Both sensitivity and specificity were suboptimal. CT angiography and PET both did better. They were in the low 80s. And then FFRCT really raised the bar and raised the area under the curve to 0.94. So really highly correlated the physiological lesions that we saw invasively with the non-invasive imaging modality. Number 7 is four-dimensional flow now with cardiac MRI, really providing a comprehensive and dynamic view of the heart and the aorta. It can look at blood flow patterns. It measures velocity. It quantifies hemodynamic parameters like shear wall stress. And it's really useful, I think, for more complex conditions, including aortic diseases, but planning surgery and monitoring diseases more accurately than traditional measures. So here's a nice example of an aorta with four-dimensional imaging. I don't have a movie to play you, but this would show the flow patterns and hopefully help plan out who might need intervention earlier. We can use it in heart failure. This is, again, an opportunity to look at both flow and regurgitation in a more accurate way. And finally, I think very interestingly, we can look at not only ejection fractions and flow, but we can look at residual volumes and delayed ejection flow and hopefully help target therapies a little bit better. So four-dimensional MRI giving us a little bit more information without extra imaging. Number 6 is our echocardiographic imaging to guide tricuspid interventions, or what we call TEER or TTVR. So echocardiography has really advanced our evaluation of the tricuspid valve, and as you know, kind of the last of the big valve domains that we're tackling now in cardiology. But the aims of the pre-procedural transesophageal echo now in a patient who needs tricuspid valve repair is going to be to quantify the tricuspid regurg severity. We're going to look at the leaflet morphology and anatomical variations, assess annular and adjacent anatomy, which is going to help, I think, with targeting which approach is better. And really, I think, helping the interventionalist with both the potential adverse features, but also what approach may be safest and best for the patient. Again, just looking at examples of some tricuspid valve interventions with clips, very easy to see on transesophageal echo. Sometimes intracardiac echo can also be used, or ICE. But I think looking at the different valve lesions and looking at the interventions, both pre and peri-procedural, is going to be very helpful. So for peri-procedural guidance, echo will help us with real-time images to guide the delivery of the catheter and the device. It really ensures that there's optimal placement, looking at opposing leaflets and placing new valves. As far as 3D imaging and ICE, definitely as an adjunct to transesophageal echo for difficult cases, helping confirm leaflet grasping and device placement. And of course, I think most importantly, hopefully, looking for things like shadowing and other things that may interfere with device placement to really hopefully help guide the intervention. Back to MRI for number 5, we have quantitative myocardial perfusion. This is now really looking at the ability to look at blood flow to the heart muscle, which was previously only available by PET scanning. So now MRI is moving into the PET domain. So, back in the day when I was doing cardiac CT in the early days, we had this battle between CT and MRI as the two advanced imaging modalities, kind of trying to establish a role against the nuclear and echo, stress echo world. Now it's really MRI and PET kind of battling it out for some of these more less used or less common problems. But I think when we talk about coronary microvascular dysfunction and we start thinking about things like ANOCA and MINOCA, I think really understanding myocardial blood flow to help diagnose conditions like this, to look at accurate and objective analysis, is really going to be helpful for us to help quantify these diseases and identify perhaps those men and women who are suffering with non-obstructive disease who have ischemic burden. It's been adopted in the newest guidelines by the Society of Cardiovascular MR. This is their expert consensus document, and really has put forth this concept that CMR is at least as accurate in the detection of obstructive disease as PET, and provides more accurate estimation of the total ischemic burden in patients with coronary disease. Again, both are good, but again, ANOCA, MINOCA might be a special role for MR and quantitative myocardial perfusion. We can really see clearly the utility of this in microvascular disease. This is a stress MR, and you can look at the bullseye target, and the numbers have gotten worse, implying that there is microvascular disease that's affecting myocardial blood flow during exercise. Another MR advancement, this is kind of a unique one, but I think it's pretty interesting, is using non-contrast studies. So taking two non-contrast MRs, or basically an MR with two different modalities, without giving gadolinium or any other enhancing agent, and emulating contrast-enhanced imaging. Gadolinium, as you may know, has some toxicity, especially in renal disease, but it's very costly, and it does slow down the procedure quite a bit. So if we could use what they call virtual native enhancement, or using MRI, non-enhanced images, to give us pretty pictures that emulate contrast enhancement, I think would really go a long way towards making MRI a more useful tool. It's very time consuming, it's very hard to do, and when we start adding contrast, it makes the procedure both harder and a little bit more expensive. So it uses two different images, pools them together using a T1 mapping program as well as cine images, and then it pools them together to give us what's called virtual native enhancement imaging, again using AI to kind of combine the two images into one. So there's no contrast required. This virtual native enhancement eliminates the need for gadolinium-based contrast agents. It's faster and cheaper than using contrast-enhanced studies, and at least some of the studies report superior image quality compared to conventional gadolinium scans. These are a couple examples that were published recently. You can see on the left in each column is the virtual native, and on the second column is the late gadolinium enhancement. So this is with contrast. And you can see that they look, at least these examples look fairly similar, even though there's no contrast given in the green VNE columns. So we are getting better at now emulating contrast, which I think for MRI is going to be an important aspect. Number three goes back to cardiac CT. Plaque imaging, I think, has come a long way, and we touched on coronary calcium scanning. I think when we start talking about CT angiography, if we're going to use this tool, especially maybe useful in the younger patients, now that the radiation doses are low, I think Dr. Fuster's correct, we can't use coronary calcium probably below the age of 40 for sure. In most patients, it's just not going to show up. I think it dominates as people get older. It's a better tool, but I think early on we might use AI and CT to quantify plaque. Patients like a number. They want to know what their calcium score is. When I do a calcium score with a CT angiogram, and the CT angiogram shows no obstructive disease, but their calcium score is high, all they want to talk about is the calcium score because they like the numbers. We've taught them numbers, right? Dr. Martin's taught them to know their LDL, and the endocrinologists have taught them to know their A1C, and the blood pressure experts have taught them to know their blood pressure. So they want to know their score. Well, with a CT angio, we weren't able to give them a score. So the calcium score was their number. But now we can start quantifying plaque, and we can get total plaque volumes, and you can see this was from Scott Hart. In blue is a high total plaque volume. In yellow was a low total plaque volume, and it predicted risk really well. 7-fold hazard ratio. That's a really robust number, much higher than what we see so far with biomarkers or polygenic risk scores. On the right, if we look at just low attenuation plaque, or what we call necrotic core, you can see again, highly predictive and additive to what we learn from plaque imaging. So we can use these AI tools to quantify plaque. But I think we can go beyond that now. Again, we have calcium score, and there's actually some nice AI algorithms to look at the calcium score, more than just the original, what we call the Agatston score, to derive density, location, even the morphology of the calcium, to help us predict who's going to have more events. And then we can use the CT angio-derived AI QCT, this quantitative CT plaque volume, to get things like percent atheroma volume, as well as non-calcified plaque volume and low attenuation plaque. And all of those improve the area under the curve significantly. And as we start looking at these additional metrics that we can derive from CT, it improves upon risk factors. It then improves upon risk factors plus calcium scoring, and even upon risk factors plus calcium scoring plus PAV. There was a nice study that was done by the Confirm group, which I'm a part of at the European Society of Cardiology, as a late-breaking clinical trial. We looked at AI-QCT and looked at risk stratification, and it improved the area under the curve compared to CAD-RADS, which is just how much percent stenosis they have. It improved the area under the curve compared to the coronary calcium score, and it improved the area under the curve compared to the Duke index. But I think as we talk about combining these AI tools, we have to put them all together, right? If I'm going to use a CT angiogram and I'm going to give patients contrast and I'm going to spend whatever those dollars are for that study, I want to derive the most information. And I think we're now learning how we can combine these FFR tools. Is there a flow limitation? And is there a lot of plaque? So this was a really nice study done, a 3-year follow-up called Advanced DK. It was published in JACA a couple of years ago now, but I think this is the concept that's very prevalent in our treatment algorithms. For these patients who had no flow limitations, their FFRCT was negative. Their flow down the coronary was normal, but they had a lot of plaque. They're in the top quartile for plaque quantification. They had late events. They had events years 2, years 3, so we have time to intervene. And with all the new things that we just learned from Dr. Martin and more that we're going to learn later today, there's a lot of interventions that we can apply. If somebody has atherosclerosis, we now have time to intervene. But what happens if their FFR is abnormal? There's actually some really nice studies that show if you don't intervene on FFRCT and don't completely revascularize, patients have more events. So while we can talk about the accolades or the failures of the ischemia trial and whether or not we buy into the fact that we can't risk stratify by global ischemia with functional testing, which I believe we can't, I think vessel-specific ischemia is going to really help guide us in who needs to be revascularized. And this is where we start seeing early events. So if you have a positive FFRCT, but not a lot of plaque, your events all occur early. And that's where we want to potentially intervene. And again, there's now 3 studies that show if you completely revascularize based on the CT FFRCT, so the CT-based FFR, that you can bring events down to the same level as patients who have no abnormal flow in their coronary arteries. So you can reduce their risk if we target vessel-specific ischemia. And maybe we'll get Dr. Butt's thoughts on that in a moment. But abnormal events occur in those patients who have abnormal FFRCT, and those events occur early. But then if you have both FFRCT abnormal and a lot of plaque, you end up with a huge a huge event rate because now you have early events and late events. Moving on to number 2, we have another PET discovery, which is fluoropyridinase, or should be able to say that better, I apologize, but a new tracer that's improving our ability to look at proportional blood flow. So it's probably better for obstructive disease, but most importantly, it has a long half-life, so it can be used for exercise, and it provides it's provided in a unit dose, so we don't need to have a cyclotron or generator on site to make this isotope. So this 18F-FDG uses a glucose analog to look at how the heart muscle is metabolizing glucose. So again, long half-life, can be used for exercise, and doesn't require a cyclotron or generator to create. And it can really help us with healthy tissue, scar tissue, and hibernating myocardium in a much more accurate way because it's not looking at just blood flow like our previous PET tracers like rubidium or ammonia. It's now looking at metabolizing glucose. And you can see beautiful uptake. This is combining it with treadmill testing. This was a study by Dan Berman's group in Cedars-Sinai. And you can see beautiful, beautiful uptake of contrast and more uptake with exercise. So again, identifying that hibernating myocardium. So it's going to help us with viability, it's going to help us with scar, and it's going to help us with hibernating myocardium, and making, I think, PET much more useful, again, without needing a rubidium generator. But I think the number one advance, at least in the last year or two, is going to be photon counting CT. Photon counting CT improves the resolution of the images dramatically for cardiac CT. You can see on the top a previous iteration. You can see how the line pairs, how the resolution, and when you take the same picture with a photon counter, you can just see things much more clearly. It literally doubles our resolution and reduces radiation exposure because it's much more efficient at looking at each photon as it goes through the detector rather than eliminating a lot of the scatter issues. So it improves resolution. The image quality is much better. Anybody who's looked at any CTs will tell you that these images are most commonly dramatic. Obviously, any image can be good or bad, but really dramatic images, allowing us to overcome the three biggest limitations that we have with cardiac CT. So cardiac CT angiography, significantly limited by calcification. We can now have less blooming artifact and see calcified plaques better. You can see that in these images here, and very densely calcified plaque, but you can see now that lumen is still open in picture C. We can look at the evolution and look at spatial resolution. Our second limitation is on smaller vessels or on seeing the vessel with higher resolution. And you can go from the 64 slice CT to the middle picture is a 256. And on the right is a photon counting scanner photo. And you can really see not only the vessel more clearly, but the side branches and the smaller vessels as it doubles our spatial resolution. So we're going to see, again, densely calcified. There's a patient with an Atkinson score of over 4,000. And you can now see very clearly that this is non-obstructive in the right coronary. Picture C might show it the best, where you can just see the contrast going right through that calcified plaque. And the biggest advance will be with stents and being able to accurately evaluate the stented patient. Calcium causes a blooming artifact, metal causes a blooming artifact, and photon counting really reduces this quite a bit. And we can now see, with higher resolution and less artifact, we can look through the stent. So I'll leave you with that thought and just this process as we've gone through evolution with imaging and my path. All truth passes through three stages. First, it is ridiculed. Second, it is violently opposed. And third, it's accepted as being self-evident. And I think we're starting to get there. So thank you very much.
Really terrific talk. Any questions, please go ahead and use the Slido. Maybe I will take this time to come back to that question of the coronary artery calcium of 0. What does that mean? What does that whole power of 0 thing that was being touted actually mean? That is, if you had someone that came in with out of control LDL, would you not treat it? If someone's coming in with chest pain, CAC score 0, would you just say, don't worry about it?
Yeah, so I think, keep in mind that calcium scoring, I think, is best used in the asymptomatic person. I think for CT, for a chest pain patient, I think CT angiography now with maybe some of our additional tools, FFR or plaque quantification may be much better. We don't want to miss a thrombus. We can't see thrombus with a calcium score. We don't want to miss soft plaque or non-calcified plaque, especially in the younger patient. But I think a calcium score of 0 in a person who's above age 45 is still an excellent prognostic marker, and the long-term risk, I'm talking about 10-year risk, is less than 0.1% per year in almost every trial ever done around the world. So I have a lot of confidence, not in the patients with LDLs like Dr. Martin was talking about with 1,000 or 800, I'm going to treat them regardless. But in the patients with moderate abnormalities of LDL or some risk factors like family history, a score of 0 for me gives me great confidence that they don't need a lot of pharmacological therapy, and I can stick to those lifestyle changes that Dr. Fuster talked about.
That's terrific. No, I agree. No one would necessarily advocate a calcium score for someone with active chest pain, but I meant rather if you knew someone had a calcium score a month ago that was 0, and now they're saying, oh, I'm having chest pain. Some have said that you don't really need to be that worried about it, but I mean, I agree with you. Someone that's having chest pain needs more of an evaluation. How about this question? Is there data on fibroblast activation visualized in PET in patients with aortic stenosis? Can the fibrosis of the aortic valve be quantified by that? And I'll just say more broadly, beyond just an echo for the aortic valve, anything more we can do to evaluate it. There's a lot of work, for example, that's been done on calcification and CT and severity of aortic stenosis.
Yeah, so I'm actually, I don't think PET has the spatial resolution to look at the valve leaflets, so I think this might be challenging, although maybe in severe aortic stenosis where you have a really crazy calcified valve, maybe you can see a little bit, but keep in mind the resolution of PET is still somewhat limited. So while we can look at the myocardium, it's not going to get down to thinner or smaller lesions. The same with MRI. We don't use MRI to look at coronary arteries. We tried that decades ago and it failed because of the spatial resolution. If you want to see spatial resolution, we're going to have to look towards CT. And just one last comment, the guidelines, the newest chest pain guidelines, 2021 guidelines for ACC/HA do say that if you have a very low risk patient, and you have with chest pain, and they have a calcium score of 0, that can be useful in guiding your treatment decisions. But certainly acute chest pain, please don't utilize that test.
Yeah, no, those are definitely great guidelines. You're quite right. Well, thanks for bringing us up to date. Wonderful, wonderful talk. Next up, it's I'd have to say a real treat, a real privilege to call up a longtime and dear friend, Dr. Bob Harrington, to give us the top 10 advances in thrombosis. To go through his CV would take the rest of the symposium's time, so I won't do that. He's currently the dean at the Weill Cornell School of Medicine, which I'm a proud alumnus of. He's the provost for medical affairs at Cornell University. He's a former president of the American Heart Association, remains on their board of directors, has had enormous impact in the US and globally in that and many other roles. He served multiple leadership roles on the US FDA, helping guide that organization to make patient-friendly decisions in a timely way. His contributions to multiple different fields of cardiovascular medicine, again, are innumerable. Beyond that, though, which you could look up online if you Googled him and saw his impressive accomplishments, I was going to say he's the consummate mentor to people across the range of ages and stages in their career. I often turn to him for advice myself, and you really can't find a nicer guy. It's pretty hard to climb the academic ladder and not accumulate a number of enemies, but Dr. Harrington's one of those rare individuals where whomever you might ask about him will say only great things and nice things. So he must be doing something right. Dr. Harrington, a pleasure to have you here.
Thank you, Deepak. And now that you just reminded me with your alum, I'll tell you where you can send your donations later. But real privilege to be here. My topic is the top 10 events in thrombosis. Let me pause for a moment on my research contracts because I do have two disclosures that are very germane here, one of which is that I have a research grant working with factor XI inhibitors, and the second is that I'm a consultant for a Duke startup that is dealing with aptamer inhibitors of von Willebrand factor in stroke, Basking Biosciences. Everything else is not related to the particular topic I'm going to deal with today. All right, so I'm going to show you two lists, and first is my list of the 10 advances in thrombosis. We'll walk through these one at a time. Here's the top 5. They don't, unlike Matt, who very nicely told you and kept us all waiting for what was number 1, mine are not in any particular order. I tried to group them more thematically. Here's the second 5, and you can see that we're going from acute coronary syndromes to acute myocardial infarction in the area after, in the time after myocardial infarction, and we'll also spend some time in atrial fibrillation and venous thromboembolic disease. But no talk would be complete without some reference to AI, and my prior speakers have all done that. I will disclose that I created my list before I asked ChatGPT for their list. But I wanted to see, did I leave anything out? And I also did what Matt did. I called friends and colleagues in the area. but I did ask ChatGPT to generate a list for me, and I love their list. So let's spend a few minutes looking at theirs. That while it is not possible to name the top 10, well, because I asked her last weekend, because the year's not over, significant progress has been made in several key areas. This is actually, I do think, is helpful, that they grouped it nicely for us. It reflects a growing focus on more precise anticoagulation, better management of complex disease, and leveraging technology to improve care. I think that's a great summarization of the topics that I'm going to deal with. And you can see that while not the same, we overlapped in a lot of areas. And so despite the notion that expertise is no longer required in this country when dealing with science, I think that there's still a role for expert consensus combined with using new tools like artificial intelligence. But I am definitely going to talk about new anticoagulant therapies and strategies, which is probably one of the underlying themes of my presentation, particularly as we think about both acute and chronic coronary disease. There is a focus on an improved understanding and management of complex cases, and a lot of that really deals with our patients with cancer-related thrombosis or other aspects of venous thromboembolic disease. And there's definitely a role for technology-driven and procedural advancements, including more accurate representation of dosing using technology to both predict risk over time and to help us understand dosing algorithms. All right, so number one in my list is publication of the acute coronary syndrome guidelines. While this is not specific for antithrombotic therapies, as you all know, both in the acute coronary syndrome setting and the chronic management of coronary artery disease, the use of antithrombotic therapy is really foundational. And so the updated guidelines, I think, that came out this past February from the ACC, AHA, and a variety of other professional organizations really do, I think, stand as one of the top findings in our top advances in thrombosis this past year. There's been a lot of talk in the literature and emerging in the guidelines about our ability to do something that was previously considered sacrosanct, and that is to drop aspirin over time in our patients who have coronary artery disease. But I want to go back to the acute care setting, is that there's no data to remove aspirin in the acute care setting, and that in the acute care setting, aspirin really remains the cornerstone of therapy for antithrombotic therapy. And if you go back to data that's now 40 years old, we know that in patients having a myocardial infarction, that aspirin reduces the risk of dying in the first 30 days by about 24%. And if you combine it with reperfusion therapy, in that case, streptokinase, it lowers it by almost 50%. So aspirin is critical for our patients with acute coronary syndromes. This is just a good reminder of that. The next thing that I think the guideline writers did very well is to remind us that we should base our decisions on the evidence from clinical trials. And so what you'll see is whether we're looking in the acute care setting in patients with non-ST elevation acute coronary syndrome who are planned to undergo PCI, the weight of the evidence is really with prasugrel and ticagrelor. But they also point out that if patients are going to be managed without a planned invasive approach, ticagrelor is really the one that has the best body of evidence associated with it, rather than prasugrel, where there was an early increased risk in the group of patients who were treated with prasugrel when invasive therapy was not being planned. Clopidogrel is still an excellent drug, although it actually surprises me over and over how much it's used relative to prasugrel and ticagrelor, which have both been shown to be superior to clopidogrel in acute coronary syndrome trials. And then finally, in patients, there's still some debate as to whether or not you need to load people with ticagrelor or prasugrel if they're going immediately to the cath lab. But there's less debate if they have a prolonged period of time before going to the cath lab. In this particular case, it's defined as 24 hours. The next thing that the guideline writers did very well is to help us think through the DAP strategies in the first 12 months post-discharge. And this is just a great chart to have available to be able to think about in three basic categories. What about the so-called default strategy, which works for the majority of our patients? What about trying to balance ischemia with bleeding over time? And how might we think about dual antiplatelet therapy? How might we think about antiplatelet therapy when it's being combined with oral anticoagulants? And then what about that group of patients, which is the minority of our patients, but an important group of patients who are considered at high bleeding risk? So the guideline writers really lay out very nicely for us the different strategies. They ground it in the clinical trials evidence. You can see that when things are class 1, they almost certainly have large-scale evidence supporting them behind it. When you get into the classification of class 2, class 2A, class 2B, that's really where the uncertainty exists and where more evidence is needed. Remember that class 2A, it's more likely than not that that's a beneficial recommendation. When it's a 2B, it's a little more uncertainty associated with that. Number 2, I think that this is a really important paper that came out this past year, and Jack, recurrent events analysis of master DAP, total ischemic and bleeding events after abbreviated versus prolonged DAP in high bleeding risk patients. It's accompanied by a very nice editorial where there's been this balance that people talk about. Can you get additional ischemic benefit while minimizing the bleeding risk? And in this analysis, which I found very elegant, they counted total events over time in the abbreviated version versus the more prolonged version. And whether you look at bleeding events or you're looking at ischemic events, it becomes pretty clear that in our group of patients with high bleeding risk, an abbreviated DAP strategy is really important because it does two things. It actually does reduce your bleeding risk in that group of patients, but it does so without the cost of added ischemic events. And so quantifying that, really important. And it's going to be a theme you'll see emerge from my presentation over the rest of the findings of really the top advances. Number 3 is the evolving understanding of DAP duration. And again, this builds on advance number 2. This is a fabulous review paper written by Marco Vermeulen, who has led a lot of the trials of dropping one of the antiplatelet agents over time. And he really tries to make the case that of demystifying the role of 12-month dual antiplatelet therapy after acute coronary syndrome. His point being that in none of the trials like the Plato trial, did we set out to actually prove what the length of therapy after an ACS event was most beneficial. And so what he asks for is that we pay more attention to the clinical trials that either reduce dose over time, change the duration of drugs over time. And I think that this is a really important viewpoint that came out this past year. And let me give you some examples. Early withdrawal of aspirin after PCI in acute coronary syndromes. This is the NEO-Mindset clinical trials done in Brazil. This is an important trial because a lot of the push lately has been to remove aspirin over time, leave patients on single antiplatelet therapy, which is typically the ADP inhibitor, with the notion being that you will preserve the ischemic benefit while reducing the risk of bleeding. This points out a couple of important things. One of which is that many of the trials that have dropped one of the doses or have lowered one of the doses, have dropped one of the agents, or have shortened the length of time, have shown convincingly that when you give less potent antithrombotic therapy, you get less bleeding. But where there's been a lot more, I would say, uncertainty is do you preserve the ischemic benefit? This particular trial, like many of them, was laid out with a non-inferiority design, meaning on the ischemic side, is it at least no worse than what we standardly do? And on the bleeding side, planned is superiority. Is there less bleeding, in fact, with a less potent regimen? NEO-Mindset really, I think, shows two things, one of which is be careful. that it's not necessarily the case that you can lower a dose, lower an intensity, shorten the time, and you'll get a non-inferior or an equivalent result. In fact, in this trial, it doesn't meet the standard of non-inferiority. Yes, you do get less bleeding. So as you're thinking about taking care of your patients, particularly as we're thinking about broad patient populations in whom you'd like to drop a dose, make sure that there's data that really says to you that on an ischemic perspective, this is as good as, it's not inferior to the standard therapy. There's no question there'll be less bleeding, but make sure you're paying attention to the ischemic side as well. In fact, the guideline writers acknowledge this. They have this fantastic diagram late in the guidelines where they're saying, what are the future directions? And one of the ones that my comment just made reference to is the upper corner here that says transitioning from acute to chronic coronary syndromes. How do we think about de-escalation of antiplatelet therapy? So the guideline writers definitely honed in on this as an area where, despite the pressures to drop an agent, be careful. In some areas we have sufficient data, but in many areas, particularly in that transition from acute to chronic disease, we have less robust evidence. Point number 4, advance number 4, antiplatelet use post-CABG in ACS patients. This is really important because where the recommendation comes from to utilize dual antiplatelet therapy post-CABG, it comes from trials like Plato. And why did it come from trials like Plato? Because patients who were undergoing CABG were included. Now, they were not the point of randomization. Randomization occurred upstream. So then you had this period of time, patients go to CABG, and so CABG in that situation becomes a post-randomization variable. And you can't just say that there's the preservation of randomization, because there's not. A lot of stuff happens between randomization and going off to CABG. So this is a really nice study where they actually took a group of patients who were undergoing bypass surgery and randomized them to dual antiplatelet therapy with the ADP inhibitor or aspirin alone. And what they find, not surprisingly, there's less bleeding in the aspirin alone strategy. And in fact, in this one, it meets the criteria of non-inferiority. There's absolutely no benefit of adding ticagrelor in the post-CABG patient in terms of the ischemic benefit. So really important paper, and I think does potentially change practice and will likely be updated in the guidelines in the future. Since we're on the topic of CABG and CABG-related bleeding, bleeding remains an important part of bypass operations. Upwards of 15 to 20% of patients have serious bleeding events, and many of those patients have a demonstrated coagulation factor deficiency that's measured in the post-CABG period. Upwards, as you know, of 50% of bypass patients get blood products at some point during the procedure itself or after the procedure. It can be a very complicated situation dealing with the patient who's had a sternotomy and has ongoing bleeding after the procedure. It increases the risk of infection. It increases the risk of graft closure because you tend to stop antithrombotic therapy. And so it's a really important clinical scenario. This was a terrific randomized comparison of prothrombin complex concentrate versus frozen plasma for coagulopathic bleeding. One of the challenges with frozen plasma is all the things you think about when you get a blood transfusion. Prothrombin complex concentrate is something that's manufactured from collected plasma. It's safer. There's less anaphylactic reactions given to it. There's less infections associated with it. And guess what? It's better at stopping bleeding in the post-CABG coagulopathic patient. So important observation, nicely done, small but nicely done clinical trial, and points out that you don't have to do 10,000 patient clinical trials all the time. If the incidence of the event is high enough, you can do much smaller trials and learn something important. Number 6, antiplatelet therapy in coronary artery disease patients undergoing non-cardiac surgery. How many of you spend time in the cardiology consult service? This is a question you get asked every day. You had a patient who had a stent put in X number of months ago. They're due to have something done in their abdomen. We want to stop the antiplatelet therapy. You try to argue with the surgeons. You try to say, well, you're doing this minimally invasively. We really think that they should stay on it. Is there any randomized data that says that, in fact, you can do what the surgeons want, which is stop it. In fact, there hadn't been randomized data, and cardiologists, we have been so protective of that stent that we insisted that you couldn't stop it. Or if we stopped it, we'd say, please, at least don't stop the aspirin. Randomized clinical trial evidence now shows us a couple things, one of which is that for relatively low-risk non-cardiac surgery, the risk of having an event is pretty low from a cardiac perspective, but the bleeding risk is not low. And in fact, if you go to if you go to the strategy of no antiplatelet therapy for at least 5 days before the surgery, you in fact can lower the bleeding risk, and then starting it up in the post-operative period. So again, a really important clinical question, something that we had drawn inference from a lot of other data, but didn't have real randomized data to support the perspective. Patients undergoing relatively low risk to moderate risk non-cardiac surgery, you can go ahead and stop the aspirin 5 days before. Now, the knowledgeable antiplatelet person among you will say, well, doesn't the platelet pool turn over every 7 days, not 5? And that is, in fact, true, that the platelet pool turns over every 7 days, but within about 5 days, you start getting return of platelet function, et cetera, enough to have hemostasis. So I think it was a legitimate test. Another really important paper, and both Seth and Matt made reference to things that came out of the European Society meetings. This was a trial, aquatic trial that came out at the ESC meetings, really important because this did not show what I thought it was going to show. This was asking the question of antithrombotic choices in the management of chronic CAD. This took a group of patients who needed to be on chronic oral anticoagulation, mostly for atrial fibrillation. And the feeling had been, well, you get them off the dual antiplatelet therapy in the early period, but you leave them on one of those drugs over time. Well, in fact, this raises the question of whether or not you should actually do that. If they're on oral anticoagulation, might that be enough for the management, not of acute coronary disease, but of chronic coronary disease? So at some point of time, it does look very reasonable to leave them on the anticoagulant, but drop the antiplatelet agent. Now, this will get a lot of press as other clinical trials are coming onto the scene, but this is a pretty well-done study by a group of French investigators, and in fact, the trial was stopped prematurely by the Data Safety Monitoring Board because of the increased risk of the antiplatelet plus anticoagulant strategy, including an increased risk of death. So important paper, important that it isn't what people thought it was going to be, and the finding of an increased risk of death, I think, is obviously critically important. This is an area that I'm working in just in way of disclosures. My work in this area is covered by research contracts and grants. Factor XI inhibition in atrial fibrillation. A couple of important papers came out this past year, the first of which is asundexian versus apixaban in patients with atrial fibrillation. Factor XI inhibition looks to be comparable to factor X inhibition with regard to ischemia in early clinical trials. This is the first test at scale to see if factor XI inhibition with this particular small molecule inhibitor, asundexian, was not inferior to apixaban while leading to less bleeding complications. That's a pretty high bar, given that apixaban, the factor X inhibitor, is certainly both more efficacious and safer than warfarin in the patients with atrial fibrillation. So can asundexian do better? In fact, it did a lot worse. And this trial was stopped again by its independent data safety monitoring board because there was an excess risk of stroke or systemic embolism in the asundexian group versus apixaban. Really important observation because, again, not what was expected. And it's raised a lot of questions about why. And one of the questions about why was the dose, the antithrombotic dose of asundexian enough with factor XI inhibition? There's a second clinical trial reported this past year with an antibody inhibitor of factor XI, forget it. Antibody inhibitor of factor XI against rivaroxaban in patients with atrial fibrillation. This was a phase 2 trial to just try to demonstrate less bleeding with the antibody inhibitor relative to the small molecule inhibitor. Really important question for things like, can you get less bleeding, and give the drug more infrequently than you have to take a small molecule inhibitor, an oral pill. Trial also stopped prematurely by this Data Safety Monitoring Board, but not for harm, but really just because what was needed to be learned was learned, is that there was a lot less bleeding associated with the factor XI inhibitor than with the factor X inhibitor as used in this study. And now larger scale trials are going to be done to look at the efficacy side of the question, like we had seen in the previous trial. There's another small molecule inhibitor of factor XI called milvexian. There's a trial underway called the Librexia atrial fibrillation trial. The clinical trial design was published this past year, or within this last year, in the American Heart Journal, laying out the trial rationale and design. Very similar in design of the asundexian trial, looking for non-inferiority against apixaban, looking for more safety against apixaban. Key difference is that the dosing strategy of milvexian is many-fold higher than the dosing strategy of asundexian. So we'll see if that is that the difference. Trial number, advanced number 9, duration of anticoagulation in provoked VTE. This is a really interesting question that somewhere in the 3 to 6 month range, it's been recommended that you can stop anticoagulation if someone had a provoked DVT. They had a lower extremity injury and a DVT. They had been on a long trip and confined in a tight space, and they've had a DVT. That's considered to be a provoked DVT. And the question is, okay, you have your course of therapy and then you come off anticoagulant. That's very different than the unprovoked VTE, which people for a long time have talked about prolonged therapy. But now it looks like, in fact, you do better with more prolonged therapy in a provoked venous thromboembolism than with an unprovoked. It also helps if you can think about lower doses of the anticoagulant over time, something that, again, can reduce the risk of bleeding while still holding on to the efficacy. Final, advance number 10, is a really important situation of cancer-associated VTE. For those of you who take care of cancer patients, you know that there's an increased risk of VTE. Everything from the indwelling catheter thrombosis to pulmonary embolism really exist along a spectrum in the group of patients with cancer, and particularly some types of cancers like adenocarcinomas associated with an increased risk of VTE. This is a really interesting study which looked at extended reduced dose apixaban for cancer-associated venous thromboembolism, showing that you can get excellent antithrombotic effect, reduction of the VTE risk while lowering the risk of bleeding, not surprisingly. But important that the clinical trial was done. Another study looking at even more prolonged anticoagulation in a group of patients with cancer, with pulmonary embolism, rivaroxaban for 18 months versus 6, and the longer course of therapy with rivaroxaban, better than the shorter course of therapy. I think the next question is, can you look at reduced doses over a very prolonged period of time for our patients with cancer who are at risk for venous thromboembolism? That's my 10 advances, and I'm happy to answer questions.
That was really terrific, succinct, and just hitting on all those major highlights. If people have questions, go ahead and put them in the Slido. While questions are potentially coming in, let me ask you, you covered a lot of different important areas. One area that came out, you talked a bit about clopidogrel and how used it is, and I agree with you in the context of, say, ACS. There's great data for ticagrelor in particular. But in more chronic coronary syndrome, of course, aspirin remains the most common antiplatelet used in the U.S. and worldwide. But this summer at ESC, there was a late breaker that Marco Vaglamigli, who you mentioned in another context, presented the Panther meta-analysis that was published in Lancet. Actually, Dr. Moran, who just came in, and myself were also part of that international collaboration, pooling at a patient level all the clopidogrel aspirin data, finding the clopidogrel was superior, and unlike it's usually the case, better efficacy with an antithrombotic, but not more bleeding. In fact, if anything, numerically less bleeding. Now that it's generic, what do you think the role should be of clopidogrel versus aspirin in secondary prevention?
Yeah, I think it was a terrific presentation at ESC, and I think it solidified for me things that we've known going back to the original days of clopidogrel. That clopidogrel, in fact, in Capri, was shown 30 years ago to be better than aspirin, and to have less or comparable bleeding in different populations. I think this is solidifying that years later in a more contemporary setting. And I, for a while now, Deepak, have at some point have transitioned patients from aspirin to clopidogrel if they had been on single antiplatelet therapy. I think that the ADP inhibitor is superior to the aspirin.
Yeah, no, I certainly share that feeling. Here's a question. You're welcome to answer this, but I can quickly answer. Should we follow serum calcium scores on patients with statins? No. I mean, if anything, calcium score might go up. You already know it's positive in that patient with a positive calcium score. So I don't.
Glad you answered. I was going to have to call a friend on.
Yeah, no, I wouldn't recommend that approach. Another question, not asked here, but that comes up: is there any role for platelet function testing for any of these antiplatelets, clopidogrel, prasugrel, ticagrelor, or genotyping in your practice?
Remember, this is really a clopidogrel issue because of the metabolism issue with CYP2C19, and this is one of the great debates of cardiology. Deepak, I still reference the paper that you wrote on this years ago that said that genetic testing is great, or platelet function testing, but the big reason that clopidogrel doesn't work is people don't take it. Right. And but all kidding aside, this is an area where your intuition tells you that it ought to be better, because all the observational data are that there are a group of patients who have this genetic type that are at risk for not metabolizing fully clopidogrel to be able to have the active metabolite that inhibits platelets. And in fact, the observational data goes a step further that says in the clinical trials, the group of patients who in fact are CYP2C19 star-stall allele, that they do have more thrombosis. But randomized trial after randomized trial has been done using both genotyping and platelet function testing, and none of them have reached statistical significance to show that the strategy is better. The one that came closest was the Mayo study, Taylor PCI, and people continue to present it as a story that is a positive story. I would say at best, it falls into the class 2 indications that it'd be okay if you did it, but there's no class 1 level of evidence A that requires you to do it. So I would say, sure, you can do it. I wouldn't argue with you, but you don't have to do it.
Yeah, no, really terrific answer to that common question that comes up all the time. Well, any questions from the audience? Let me just check my Slido here to make sure there's nothing else. Great. Dr. Moran's here, so I'm going to give her a chance to ask a question of Dr. Harrington, and it doesn't even have to be about thrombosis. You can ask him anything you want to.
She knows more about thrombosis than I do.
Well, what a wonderful honor to have the Dean of Cornell here on this top 10 meeting. But importantly, thank you. I'm sorry that I was late. I just flew in from Argentina and was with your AHA colleagues there as well.
Excellent.
So, and I came directly. I was trying to make it as fast as I could. But I will just say I'm really excited about this next possibility of dealing with hemostasis and thrombosis with factor 11. If that comes true, how do you see the future of how we would be managing patients? And let's start with our patients with coronary disease, antiplatelet therapies. We're going to learn a lot from the ACS trial that you're leading. But importantly, also in atrial fibrillation, with the current massive increase in left atrial appendage closure procedures, as you know, it's the fastest growing procedure in the world right now. And as you all know, that CMS has reduced the CPT codes down 27% for payments back. So there is a lot of angst about what's going to be the future. So Maybe you can give us a lens.
Yeah. So as you know, Roxana, we're doing 3 very large-scale trials with milvexian, totaling almost 50,000 randomized patients in 3 distinct categories, one of which is atrial fibrillation. We've enrolled over 20,000 patients, and we're in the follow-up phase of that trial. In the acute coronary syndrome, it's post-ACS, as you know, with milvexian with dealer's choice for antiplatelet therapy against placebo with investigator's choice for antiplatelet therapy. And we've enrolled north of 10,000 patients in that, north of 12,000 patients in that study, with a goal of randomizing up to 16,000 patients. And so those data will be available a year plus from now. And then if you look at the secondary prevention of stroke, that's also milvexian versus placebo, again, on a backdrop of antiplatelet therapy. There are far more patients that have to be treated with antithrombotic therapy, let's take atrial fibrillation, than there are people to occlude their atrial appendage. I would also say that at scale, when the technology moves out from the expert centers like this to other centers, it's going to be really important that we assess the technology versus, as used in the community versus the drug therapy. So there's probably going to be a role for both. A lot of that will involve local expertise, patients' values and preferences as to what they want. But I don't think that we'll stop treating people with medical therapy because we can close the left atrial appendage.
Yeah, really important question and great answer. Well, thank you so much. And I know you said that you have to go introduce your own speaker, so please don't feel obligated to stay for the panel since we're running late. So I think we'll have to jettison this morning faculty panel anyway. But thank you so much. A privilege having you. Now let me move on to my topic, which is the top 10 trials at Mount Sinai Fuster Heart Hospital. And I'm going to go through this relatively quickly just to get us back on time so that we can have the lunch break as planned and an opportunity to see the exhibits and so forth. These are my disclosures, and I will be covering some trials where the research funding does come in to Mount Sinai under my name for trials I'm involved with. And you'll see which trials my name will be listed there. So let me start first with some innovations in Mount Sinai Fuster Heart Hospital. Just this past June, we had a supplement in Science come out that detailed some, not all, of the different cardiovascular research going on at Mount Sinai Fuster Heart. And one of the topics had to do with cardiovascular trials. And there are a number of trials that are ongoing. Again, for the sake of time, I'm not going to be able to go through everything going on here at Mount Sinai and focusing on some of them. But a lot of them are targeting this concept of residual cardiovascular risk. Touched upon it a little bit this morning, but if the LDL is already pretty well controlled on a statin and someone's on aspirin and so forth, can we do more with respect to reducing their cardiovascular risk? Because we know even the most optimally treated patients in contemporary trials, they're still having events that are pretty high. So that's a series of trials that are summarized in that Science supplement about that. And other topics, also trials going on in the realm of imaging and using AI, and I'll touch upon some of that. But also research going on here, not just about trials, but trial designs. That's trying to optimize trials, trying to make the process of discovery more efficient, more effective, safer for patients. Also a lot going on here is detailed in that Science supplement about promoting cardiovascular health, in particular through education and of young people. Dr. Fuster touched upon that in his talk. And something no one's really going to talk about much at today's symposium, which is very clinically oriented, but there's also a lot of basic and translational science going on at Mount Sinai Fuster Heart, in particular having to do with metabolic and immune and neuronal pathways in atherosclerosis, also having to do with that heart, brain, and immune system interaction. Great research going on here as well with respect to AI and genomics and intravascular imaging in the cath lab. You met Drs. Kinney and Sharma a little earlier at the start of the symposium. They're leading a lot of that research. But now let me move to the top 10 trials. And for any Mount Sinai faculty where I didn't include your trials, I apologize. I could only fit in so much here. And I really focused on trials that our faculty are actually leading, not just participating in. And start with the Victorian 2 Prevent, a trial that Dr. Moran is on the executive committee for. That's an important trial looking at secondary prevention patients, so patients that have cardiovascular disease randomized to the siRNA PCSK9 cholesterol-lowering injectable drug known as Inclisiran versus placebo. The trial is fully enrolled, and hopefully the results will be out sometime in the next year or two. This is an important study to see whether that approach, which has great theoretical appeal, giving an injection in the doctor's office every 6 months, where you would hope that the adherence rates would be very high, might then result in a reduction in cardiovascular events. That's Victorian-2 Prevent. Victorian-1 Prevent's the trial I'm chairing that is looking at the same drug versus placebo, Inclisiran versus placebo, but in primary prevention, that is lower down the risk ladder. You heard Dr. Martin mention Vesalius, that'll be presented at the AHA. That's sort of been billed as a primary prevention trial in the medical press, but that's actually not really accurate. It's, for the most part, a secondary prevention trial, but this is a dedicated primary prevention trial. It's fully enrolled, 14,000 patients as of last November. Of course, these are low event rate trials, so it'll be several years before the results are known, the events accrue. Another trial having to do with LDL lowering and Inclisiran, Dr. Fuster did briefly mention this, is the PRECAD trial that he's leading, taking young folks and seeing if aggressive LDL lowering is able to prevent plaque progression as assessed by 3D vascular ultrasound. Of course, in young people, you can't really do an event-based trial. It would have to be tens of thousands of patients followed for a decade or so. So in lieu of looking at clinical events, plaque progression is the endpoint here, but using the 3D ultrasound that he'd alluded to before. As well, in the launching phase is the intervention that Dr. Moran and Dr. Banaka from Colorado are leading. This is a really important trial, again, looking at potent LDL lowering with an siRNA Inclisiran versus placebo, in this case in patients with coronary or peripheral revascularization. And it's an important population because at large centers like this, we do a lot of coronary and peripheral revascularization. The technical expertise, the results are outstanding, but can we do more than just put them on a statin and whatever antithrombotic regimen they're on? Can we really aggressively lower LDL cholesterol and further reduce events? So that's an important trial. Another trial that Dr. Moran is chairing along in this case with Dr. Adrian Hernandez from Duke is the Artemis trial. And this is an important conceptual trial looking at whether inflammation really matters. We talked a bit about inflammation. Dr. Martin showed some data about that as well. And the importance of it. But here, the goal is to look at an interleukin-6 inhibitor, ziltivekimab is its name, versus placebo in patients with a STEMI or an NSTEMI to see if it reduces cardiovascular events. So important, of course, just in terms of valuing this drug, but even beyond that to see, is inflammation a modifiable risk factor in the context of acute coronary syndromes? Other trials that are ongoing have to do with the coronary sinus reducer. I don't know if everyone's familiar with that. It's a device that looks sort of like a stent that can be put in a coronary sinus. It's approved in some parts of the world, not in the US, for treating refractory angina. It's an interesting sort of a device. This is a recent editorial with one of our fellows, Michael Vavronakis, where we review the data and sort of conclude that there needs to be more data. That is, the trials to date have been a little bit shaky, if one is being honest, with a lot of mixed signals about whether it works or not. And in fact, there is a trial that's ongoing that Greg Stone, one of our faculty members here, along with Tim Henry, is leading, the COSIRA-2 trial. It's a sham control trial, which is the right way to do these sorts of trials, versus this coronary sinus reducer to see what the effect might be on clinical endpoints. And the fact that it's sham controlled, I think, allows a real assessment of things like exercise time on the treadmill, quality of life, et cetera. Another trial that is being led out of here is PROTECT-4 by Dr. Stone. Again, this is a trial of patients that are randomized after undergoing coronary intervention, either for chronic coronary syndrome or an ACS, to either mechanical support, specifically the Impella device, or control. And I think that'll be important to really nail down what the role is of mechanical support. These devices are expensive. They do tend to generate a lot of complications. and whether they really do have a broad role in complex interventional procedures or high-risk interventional procedures really remains a matter of debate. Another program led by Dr. Stone here and Dr. Godino from one of Dr. Harrington's faculty, a cardiothoracic surgeon from Cornell, is the RECHARGE trial. And this is looking at that age-old question of PCI versus CABG, but in a newer context, in the context specifically of women and underrepresented racial and ethnic minorities, basically Black and Hispanic patients, to see which one might be better. And not just looking at the usual sort of thing, death, MI, stroke, that's been studied quite extensively, but also things like quality of life, patient-centric endpoints, really important to assess. Another trial I'll mention, one that I'm chairing, Dr. Moran's on our executive committee, is the SOS-AMI trial. This is a trial of selatogrel, which is an injectable ADP receptor antagonist, so clopidogrel, prasugrel, ticagrelor, oral agents, cangrelor, intravenous. This you give subcutaneously, and when I say you give, I actually mean you give. So what's being studied here, I think, is an intriguing concept. The idea of a patient with a history of an MI who is then randomized to carry around an injectable antiplatelet versus a placebo-containing cartridge. And the idea is if they think they're having another MI, to self-inject themselves, sort of like an EpiPen. If a patient thinks they're having an allergic reaction, someone near them, their loved one or someone would inject them to try to abort the allergic reaction from progressing. It's the same concept here. If the patient who has previously had an MI, who maybe has some sense of what the symptoms are like, feel they're experiencing those sorts of symptoms again, they would self-inject themselves and call 911. I don't know if this drug will actually work for this indication or not. That's why we're doing a large randomized clinical trial. But I think the concept is really quite provocative. The idea of patients administering therapies for themselves in the context of acute coronary syndromes. And I suspect, as has happened with allergic reactions in the EpiPen, that this will find a role in cardiovascular medicine, if not for this drug, for other drugs in the context of ACS, arrhythmia, atrial fibrillation, SVTs, and so forth. So I do believe this will change the paradigm in terms of who can initiate therapy and when, that is, giving the patient some control of their care. I also think this is SOS-AMI 1. Maybe there will be an SOS-AMI 2, maybe not, but I think if there were, the idea of coupling wearables with this approach, to me, is really exciting. That it's not just relying on the patient to say, yeah, I think I'm having another heart attack, but rather to couple that with different monitoring, ECG monitoring off a smartwatch, a variety of looking at different vital signs, maybe using AI to help gauge the probability that it's a real event, to guide the patient whether they should or should not inject whatever the therapy might be. So at any rate, we've enrolled about 10,000 or so patients and about another 10,000 or more so to go. And then now another trial I'll mention here that is being led out of Mount Sinai. I'm chairing it. David Marin, who's the head of prevention at Stanford, is co-chairing it. Bob Harrington's the chair of our data safety monitoring board, is the TRANSFORM trial. And this is a trial of primary prevention type patients, 7,500 of them, who are being randomized to one of two treatment arms, either to usual guideline-based care, doing whatever the guidelines say, treat the cholesterol with a statin, treat the blood pressure, do whatever the guidelines are saying is good to do, or to CT angiography-based care, where their arteries are imaged non-invasively, and then depending on what is seen, their medical therapy is tailored or fine-tuned, essentially using FDA-approved medicines, but in ways that go beyond what the evidence or the labeling or the guidelines would suggest. So, for example, using things like SGLT2 inhibitors, but in patients without diabetes, or heart failure, using icosapent ethyl, but in patients not necessarily with elevated triglycerides, using PCSK9 inhibitors, but in patients that have LDL levels that fall within the guideline ranges. So basically doing things that aren't totally proven, but with drugs that are known to be safe in other contexts. And then there are three parts of the trial. The first is TRANSFORM Predict, And the idea is just to see if we actually look at plaque, is that better than, say, using the ACC-AHA risk score or the prevent risk score or whatever other risk scores people like, which oftentimes in clinical practice aren't really used, but in theory could and should be. So can we do better in terms of predicting future cardiovascular events? That's Transform Predict. Then there's Transform Plaque, and the idea there is to see if we can cause plaque progression to be diminished, lessened in terms of the aggressive medical therapy that we're using in the investigational arm. And I didn't mention, but there's a CT that's obtained at baseline, but there's also a follow-up CT at 2 years. So the idea with Transform Plaque is to see, can we keep the plaque from progressing? The control arm, in fact, also does have a CT, just it's a blinded CT, but there is a CT at baseline and at 2 years, so we would analyze that at the end of the trial. And then sort of the aspirational goal is Transform Outcomes, to see whether this strategy of looking for plaque and acting on plaque actually improves cardiovascular outcomes. And that's a pretty ambitious goal, but we're going to see what it shows. And if the trial is clearly positive, hopefully it'll change care. And if it's negative, hopefully it'll keep this proliferation of CT angiography that's going on in asymptomatic, otherwise healthy people from continuing, because obviously there are healthcare costs to that, and there are also potential downstream consequences in terms of unnecessary invasive procedures, complications from procedures, and so forth. And the idea really is to stage plaque so that if there's stage 0, meaning no plaque in green, that's pretty good. On the other hand, if it's stage 3 plaque in red, that's pretty bad because that correlates with a pretty high rate of events. So ultimately then the hope is to see whether we can elevate heart attack prevention to the level of cancer prevention, much like mammography, colonoscopy, and in smokers, lung CT scanning are evidence-based on randomized clinical trials, insurer covered, and in the guidelines for primary prevention. Our hope is, if the trial is positive, that we can do the same thing and transform how coronary artery disease is prevented. Well, with that, I'd like to thank you for your attention. Thank you for attending the morning part of this symposium. We are almost out of time here for the morning session to keep things on pace, so I will take the prerogative of not having the faculty panel we were here so that you don't lose your lunch. But if there are any questions that we didn't answer, please come up to the front and the morning faculty will answer. And in terms of reconvening, let's see, it is, we're essentially right on time at 11. If you can make sure to come back at 11:45 sharp, but until then, please go downstairs, enjoy the brunch, and do visit the exhibits. Thank you so much.
Okay, I think we start on time. The morning session, fantastic. Hopefully we can duplicate this noon and afternoon session and with a very selected topics. And the format, I think we're liking it. Of course, we'll take the opinion, the top 10 points, advances made on rather than giving a regular, otherwise lecture. So there are plus and minus of both. Because to put together, just you make a 10 points to consolidate in the end is a little difficult, but we'll take the vote. This is the exercise. Okay, with that note, I'll start this afternoon, and hopefully everybody will just trickling in after a good lunch. But some people did say that food is warm and tasty, although I don't eat, vegetarian. But with the start of the afternoon, just like early morning, Dr. David Rich, our president and director of clinical services for the system did. This starts with Dr. Roxana Meran. As you all know, she'll be the president of ACC and has been at Sinai for about 12 plus 14 years. Endowed professor, you already have a lot of titles, but more importantly, what she has brought to the institution, to our Mount Sinai Fuster Heart Hospital, the academic touch, our ranking upon being a trialist and perform the trial in-house, everything. So no separate organization, like Twilight of so many patients with 8,600 plus patients, all were managed here. And we are so thankful, myself and our Fuster Heart Hospital, for her services, and I know she'll be very busy next 1 year, but that's okay. That's part of the deal. It gives us the reputation. So Roxana, come here. I know I did speak to her that I don't know what she'll say, top 10 ACC initiative, but let's see.
Thank you. Thank you, Dr.
Good,
Sharma.
good. Beautiful.
Well, first of all, I want to thank Dr. Sharma, Dr. Kinney, and especially Dr. Bhatt for inviting me to speak. There's a tradition that the ACC vice president gets to speak at this meeting. And so therefore, leaving Argentina and coming here, leaving behind 14,000 participants and the other, to be here with my family at Mount Sinai for the last 15 years. But of course, I trained here. These are hallowed grounds. And very, very close institution to the American College of Cardiology. For those of you who may not know, that history goes very, very deep and very, very old. The Journal of American College of Cardiology was founded in this institution by Dr. Simon Dack. He was also the president of the American College of Cardiology. And importantly, Dr. Valentin Fuster, for many, many years, has been not only a master of the ACC, but also, very importantly, served as the editor-in-chief of JACC, the Journal of the American College of Cardiology, right here for almost 12 years. So there is a lot of history, and there are many. Dr. Dangus is a master of the American College of Cardiology. Dr. Kinney has received awards from the American College of Cardiology, and we definitely want Dr. Sharma to be there on the podium at the time of my convocation when I become president in New Orleans. We have to be very proud of our institution. Many of the best-in-class cardiologists have come here. This is the home of cardiovascular disease. We all know where we all came from and how much impact this institution has had. So it literally is an honor to come here and to talk to you a little bit about the top 10 initiatives. There are thousands of initiatives. It's literally overwhelming. But over the last 6 years, I have served on the board. But of course, Dr. Bhatt served on the board, so did Dr. Dangus. There have been a lot of previous leaders of this institution, who have been previous leaders and current leaders of ACC as well. So let's start, the top 10 initiatives. The disclosures were listed before, but they're here now. A lot of it has to do with the academic research organization. As for ACC, I am the vice president, and I do receive a stipend for that. So here's the leadership and governance of ACC. For those of you who may not know, I'm sure you've met Dr. Chris Kramer. I think he was here last year for this meeting. But he is he's an imaging specialist. Probably he's the chief of cardiology at University of Virginia. And there's me. I can't even believe that I'm there, and I will move over to your left, next year. And then we have our treasurer, Dr. Kandawal, and David Winchester, who's the chair of the Board of Governors. Remember, every state in the United States has a governor of ACC. We care a lot about every single healthcare professional, not just the physicians, but also the nurses, nurse practitioners, physician assistants, the entire CV team, and you'll hear about that. And a lot of it also has to do with the fact that our immediate past president is part of the CV team. She was a nurse, and the very first nurse to be the president of the American College of Cardiology. So if you don't know what this college is doing for you, let me be clear that the mission is very strong and very, very much dedicated, and it is a simple mission to transform cardiovascular care and improve heart health for all in capital letters. This is truly what we are hoping to do and will do. And I believe, as president, I will work very hard with all of the other organizations so that we do not work in silos, because we do not move needles in silos. We will work very closely with the American Heart Association. As you know, the president is also here and came from this institution, Dr. Stacy Rosen, and I look forward to working with the American Heart Association as well as the European Society of Cardiology, Tom Lucia, who I'm hoping we can bring here as a visiting professor at some point. The vision is clear. Absolutely clear vision with a clear lens of a world where science, knowledge, and innovation optimize cardiovascular care and outcomes. Think about those words: science, knowledge, true science, knowledge, innovation. Those three coming together to optimize how we care for patients with cardiovascular disease, with the core values that are clear with regard to patient-centered teamwork and collaborations, but important professionalism, excellence, and equity. We did not go back to scrub up our documents with DE&I because we care about equity, equality, and transforming the care for all. So I think it's a very important one. And how it works, that the Board of Trustees come together every 4 years and come forth with what the strategic plan would be for the next 4 years. And we did this last year. It takes us a year to come up with this because we look at everything that's going on, and the board makes the decision with a lot of effort through retreats and through multiple meetings. And here are the 4 pillars of our strategic plan: care delivery, professional home, ACC as your professional home, and organizational sustainability and actionable knowledge. So how will we do this? By addressing healthcare equity in cardiovascular care, assessing AC's educational portfolio, building continuous cardiovascular clinical competence, which we are doing this through a lot of the work that we are doing and all of the educational materials, but very importantly, making it easier for you as clinicians and healthcare providers, for those inflicted with cardiovascular disease, to have the guidance at the point of care on your cell phones. Very, very easy, accessible in a digital format, and you will see how this is going to take shape, and then transforming care delivery in new areas. So in the spirit of the top 10, here are the top 10 initiatives of the ACC. Top 10 of literally 1,000 initiatives and more. I come back to quality, equity, and value initiatives. This is extremely important. The American College of Cardiology DE&I initiative has not changed or been shaken. The new administration does not have any effect, because we truly believe that cardiovascular, human health is a non-partisan, non-political, and has to be out of politics and how we move forward. We must deliver care to all. Diversity helps us to understand better the presentation of disease, and very importantly, sex as a biological variable is a very important piece, that women have to get the exact same care as men, and we need to understand their cardiovascular disease. So this accountable execution of this is realizing the value of diversity and living our core values. So if you look at this, we are doing in particular the diversity of backgrounds, experiences, and perspectives in leadership, and cardiovascular care delivery, business, education, and science comes up front, understanding how important diversity is. And to ensure that cardiovascular medicine in general and the ACC in particular attract and provide rewarding careers and leadership for everyone. Why is this coming here? Dr. Sharma, why do we have, okay. And opportunities for full range of talented individuals. In other words, all of you, healthcare providers, are talented. You should all have the same opportunities, and ACC will ensure that. And also the diverse health needs of cardiovascular patients and populations are met by cardiovascular clinicians who are sensitive and prepared to meet the unique needs of these individuals according to their cultural, racial, ethnic, gender, background, and all multiple dimensions of diversity. How do we do this? Because we care about transforming cardiovascular care, the delivery of it is very, very important. The Care Transformation Initiative is very, very important for us. And none of these are ranked in the order of the top, the best, or whatever, but the truth is we are doing all of these all at once. Building a clinical data, operational data, and accreditation infrastructure for high quality provision of previously inpatient cardiovascular services. Dr. Bhatt has served on the accreditation committee for many, many years. Actually, he was the inaugural chair of that committee and has done an unbelievable job setting the standards for that type of a care delivery in making sure that ACC is looking at accreditations to make sure that things are being done in the best possible way for our patients. And this is through defining best practices with various care teams, processes, and very important reimbursements that are attached to this, and looking at the different places with different volumes and also different geographies. The digitally enhanced care model is a must. We are absolutely embracing the digital health initiative that came from the previous, even almost a decade ago, initiatives from the board that both George and Deepak served on, where there was this digital transformation that now is translating to digital care models for our patients. And then, of course, and importantly, advocating to shape the structure of payment models. And we are absolutely advocating for each and every one of you. You may not know what ACC is doing. I will show you what we did last week to support these care models. And transforming care for all means that we have to be the patron for pretty much everyone who's part of this equation. So 2,000 plus hospitals and healthcare systems that are in our group, over 16,000 members outside of the United States, but over 64,000 members now in the entire members of cardiovascular healthcare delivery. The team, physicians, nurses, allied healthcare professionals, medical students, internal medicine residents, family practice, they're all our members, and we are growing. And of course, our JACC journals that deliver the science, and of course, these very expanding sections that are particularly important in different areas of cardiovascular disease, and then our international chapters. We are transforming care straight on. And of course, we're very worried about the workforce. Dr. Sharma, we know that the workforce is very, very under a lot of pressure. They need a work-life balance. Their work is too much. We know that there's a lot of depression and anxiety, and balancing the supply-demand is going to be an issue, and we need to keep cardiology family-friendly to be able to make sure that we're attracting the best-in-class people to come to our subspecialty, the most rewarding one. Cardiovascular disease is the #1 killer of men and women, and we must attract the very best-class clinicians and physicians who want to work in this important initiative to improve human health. We cannot do it without you all there. So the unfavorable work-life balance, the inefficient and insufficient, both inefficient and insufficient supply of physicians, and of course nurses, allied health professionals, these are weighing us down, and we absolutely have to think about that. And by the way, we have sicker, older patients, a lot of complexity of cardiovascular care, healthcare costs going up, and reducing reimbursement. We must balance this, and we are working on that. And so transforming care delivery will be very, very much in front of us as one of the important initiatives. Guidance at the point of care is also important. In order to reduce your burden as healthcare providers, we're working to quick, searchable, easily accessible information that provides answers for you as clinicians at the point of care delivery. This is for diagnosis, understanding prescribed drugs, different paths, treatment paths, and incorporating the guidelines in there to help you make decisions that are actually through our guidelines. In fact, implementation science comes from delivery of the scientific data that goes into the guideline documents and then is translated to patients. That step needs to happen. We want to make it easier for you, and best practices and best delivery mechanisms with multiple channels, and we are doing all of this for the clinical workflow. Take a look at the resources. I bet many of you don't even know about these resources. There are mobile apps, risk calculators, estimators, guidelines, everything available to you through the acc.org. If you go there, there's practice improvement kits and very important patient education materials. You don't have to make those for your practices. It's all there for you. And very important is these guidance documents that are coming out. The guidelines, we have 4 coming out this year, and we're working with the acute coronary syndrome and high blood pressure that just came out, and very important concise clinical guidance that are derived from these guidelines so you could have it at your fingertips as you're taking care of patients. And then, of course, really important expert documents that are coming out and performance measures, especially for chronic coronary disease. So this is very, very exciting. The JACC Journal is really a brand name that every single clinician recognizes, even those who are not in cardiology. The Journal of American College of Cardiology started in this institution. I am so proud to be standing here in the same institution where this journal began. Now we have 10 journals and a very new editor-in-chief taking the reins from the one and only Valentin Fuster, who has said it in such a great way that Harlan can only expand on this, and he's really brilliant with a fantastic group that not only includes intervention, imaging, JACC Asia, heart failure, electrophysiology, and very important new editor, Dr. Gilbert Tang, who's joined from this institution as editor-in-chief of JACC Case Reports, and he's doing an unbelievable job. We should be very proud of him. And of course, we have basic science and JACC Cardio-Oncology. And by the way, the Cardio-Oncology JACC editor-in-chief will be here on Monday delivering the Simon Dack professorship, if I'm correct, Dr. Bott. And then this will have a new look and a new era, and what they've already done is taken the guidelines and making it digestible for you. It's tremendous what's going on there. Sustained clinical knowledge is very, very important. As you can imagine, we said about delivering actionable knowledge with powerful education engagement platforms. And trusted, accredited CME and CE programs that we have available. You could collaborate, and great opportunities on there with disease awareness and, of course, guideline adoptions and important learning formats. Some of this you could use, again, delivering actionable knowledge at the bedside. You could go to ACC anywhere, and there are maintenance pathways. You know the self-assessments. It will keep your knowledge right up to date, online courses, and of course the annual scientific meetings. And we also have our international group. There is a fantastic newsletters that are being made. The very important newsletter on the NCDR and accreditation. I really highly suggest that you look at that, because quality is just as important as what else we are bringing in. And of course, the Cardiology magazine, there is just so much to read. Literally, it's a source for cardiology, and ACC wants to make sure that you find ACC as the home for all cardiologists and healthcare providers in cardiovascular disease. Let me tell you that behind the scenes, advocacy is a very, very important piece to stabilize the clinician economic and reduce the friction. This is a very, very big group. Our PAC, the Political Action Committee, is strong. I just came from the Legislative Congress of three full days and 1 day, literally storming the Capitol. And I'll show you. The mission is to support federal candidates who can help us advance legislation and policies that improve health care of our patients. All of it is mission-driven, ease the delivery of high-quality, cost-effective cardiovascular services, and fund research and prevention. This is all of us at the Capitol on October 8th, just 9 days ago. A very proud moment for all of the colleagues who took days out of their working days to come forth and to meet with senators, legislators, congressmen and women to make sure that we are working to transform cardiovascular health for all. And on our agenda was all of the cuts, all of the reductions in some of the reimbursements to physicians, especially with regard to left atrial appendage closure and other procedures. But importantly, with regard to Medicare and Medicaid cuts, we were very, very steadfast speaking to our congressmen and women and senators, and we believe that they will sign on to the bills that we are supporting. So this is a incredible proposal of the physician fee schedules that we were very strong on. Every single time that they want to make cuts, it's about the physician fee schedules, and we're steadfast against this, and we're working very, very hard to take a look at all of these things to make sure that these reductions of RVU works are not happening in PCI, in left atrial appendage, in efficiency adjustments, and very, very important other models. The workforce, coming back again, professional membership. 64,000 members from everywhere, multiple sections in different subspecialties within cardiology. And your membership is not just a membership. You leading the way as being a member of AACC in cardiovascular science and education, optimizing patient care through all of these things that you see and I've already talked about, and then the trusted source of news with all the data that I just put in front of you. We care deeply about this, and we believe that the workforce is where we need to strengthen this workforce, and especially thinking about our future. We cannot have people walking away from cardiovascular disease and joining the banks and businesses of medicine. We need to keep them in delivering the care, and we are doing that. Our global cardiovascular health has been scaled up. ACC is a global organization. I just came from Argentina. Our president is in China. The immediate past president is in Mexico. We are all over the globe making sure that we deliver the message with regard to the global imperative of moving the needle for cardiovascular disease. You must know that the decline has slowed down. For young women, it's on the rise. Maternal mortality at the highest rate, mostly due to cardiovascular disease, underdiagnosis of valvular heart disease, peripheral arterial disease. These are all on our agenda, not just here in this country, but also across the globe. So we are doing everything that I'm telling you across the globe and more. And the way we're doing this is working on an NCD Academy to help, and a lot of this is online, in multiple languages for our global colleagues, advancing STEMI care with a Gaudi international registry, localizing education with the trainer programs, and multiple other areas. These are all listed here, and very important is this leadership forum for the global leaders that we are working on that Dr. Bill Zogby has led, and it's incredible. Our ACC Global Snapshot is not small. As you see the number of multitudes of the members and very, very important institutions outside of the globe that we work very, very closely with. We're getting to the top 3, but literally honestly, it's not a top. It's very difficult to rank these, but certainly as incoming president, you know that the next 3 are extremely important for me. Research enablement of real-world data and pragmatic trials. We cannot get answers to simple questions waiting 10 years. Should I give clopidogrel or aspirin for chronic maintenance? We must have these answers faster and much, much more swiftly than what we have today. And there is a way forward. Customizing and working with our industry colleagues with regard to understanding how we could support innovation and growth is another piece that we are working. Real-world evidence is out there. Many of our industry colleagues have this. The NCDR is the collection of all real-world evidence, not just in PCI, but multitudes of other fronts, valvular heart disease, all the procedures, left atrial appendage closure, and more. So there is capability for us to answer questions better. And this real-world evidence is where we believe there could be huge benefits, not just to our pharma and device companies, but also to health payers. By understanding the care pathways, the care quality, optimizing resource allocation, and supporting this value-based reimbursement strategies. And of course, very important to government agencies, especially in delivering and access to care for all. But one of the greatest things that we could do is literally transform how we're doing our clinical trials in more pragmatic, adaptive platform trials where we could, just like the Oxford group did in recovery, where they found the answer of what to do with the COVID pandemic. Cardiovascular disease is killing patients during this lecture. At least lots of patients died during this lecture across the globe. We should be able to have the answers, very, very similar to how we got the answers, by having a single protocol where we introduce new or old questions and we answer them, and if things don't work, we bring in a new question. There are ways forward, and we believe this is exactly how we should be going, and ACC is supporting that. Modernizing how we evaluate data and how we use data operability is the most important way that we could get answers to everyone. NCDR is a haven of data. Think about what we have. These are our registries. The cath PCI you all know about. The ablation registry. The chest pain MI registry, we also give to this. The EP device implant registry. The impact registry. The left atrial appendage closure registry. And the very well-known STS ACC TVT registry. And this is valvular disease. Imagine the number of data elements that are in here and what we could do with understanding some of these questions. There's been 25 years of NCDR, and certainly we're all looking forward to what can be done with futuristic approach of finding ways to get data to the bedside for our clinicians to be able to work this. And importantly, the opportunities to improve the value of these data are very, very much available, and understanding how we could deliver this at the lowest cost, but with the best benefit for our patients. At last but not least, absolutely, digital health and artificial intelligence is at the top of the list for what we need to do at ACC. We are embracing AI. We are not running away from AI. We believe that clinicians who walk away from AI may not be able to survive because AI is here to stay. But what we need to do is to use it as augmented intelligence rather than artificial intelligence to help us deliver, to take the burden of some of the administrative work that's being done first and foremost so we could begin to focus on our patients. You remember when electronic health records came, how many of us pushed back and didn't want it? But now, when you go into the electronic health records, you're seeing everything in front of you. You no longer have to call Tom, Dick, and Harry to get the cabbage report. It's all there. You have all of the echo reports. Everything is there. It has made us better clinicians to be able to do this. And we have to, of course, make it better. There is an artificial intelligence resource center on our website. We are working diligently on this to see what's the best way forward. And our innovation program is extremely strong. There is an innovation program that's working and figuring out who's doing what and who's doing it at its best for best healthcare delivery to our patients. Imagine what we could do. If we are going to transform cardiovascular care, we have to embrace technology that's here in front of us. And of course, we have education and webinars to make everyone familiar with AI. And understanding the regulations and the policies of AI are also crucially important, all of them there in our website. We believe that the only way forward is not by ourselves and using membership fees to do this, but rather partnering with private-public partnership with all of these companies to better understand what are they doing and how can we at ACC make sure an emission-driven organization with high integrity to be able to deliver this to our patients, to our clinicians, to make this world a better place. The strategic plan, by the way, is directly relevant to AI. We imagining that the clinical guidance that's usable at the bedside, at the point of care, will be done through AI. We believe the answer to the questions of research questions are through our real-world data and the capability of registry-based randomized trials with a single protocol and getting those data. We have to figure out a way that people aren't doing double work of the work and the data that already exists, that they're not there redoing it all. And creating the best practice framework for care delivery, pathways, and implementation for health systems in conjunction with our partners at MedAxiom, an ACC-owned company. Think about cardiovascular care with the digital twin technology. In the past, we had data that came from signals, imaging, genomics. That's what we're doing now. We look at the anatomical electrocardiographic data. We look at the signal analyses. We may, in the models that we are doing, use some of the neural networks, and then we apply it to how we plan our procedures and pathology inferences. The future is about wearables, electronic health records, environmental data, patient populations in different parts of the world. The models are now generative AI with large language models, and the application is for the first time truly having individualized precision medicine and risk stratification, generating missing data using digital twins, and understanding clinical trial designs that will be different. All of these key elements have to be included with an equitable deployment, infrastructure and investment, ethical considerations, reliability and trust, and important federated learning and collaboration, and very important clinical validation. This is how we make AI possible to help us, not take over us. We will not be replaced as clinicians. So as I stand in front of you, do not be afraid of AI. Embrace it and learn how we could use it to make our lives better and make our delivery of our care better for our patients. That is how we should be thinking. And I believe research will also be using digital twins in the future. That's how we'll get our answers faster. This requires a whole nother lecture, and I'm already at the end of my time. Let's make sure that today's challenges for tomorrow are absolutely there for clinician well-being. Clinicians, you matter to us. You are our members. We are a membership organization. There has to be value to you, the member. There must be innovation, leadership, a global footprint. We have to collect data. Health equity has to be there. We need to be inclusive and diverse. We have to have guidelines that then are then translated to clinical guidance and clinical practice. We have to advocate for all of you. We must make sure that you're accredited and doing great quality work. And we will transform digitally and transform cardiovascular care. ACC 2026 will be very, very great. It will be in New Orleans. There'll be lots of, for those of you who want to do, please make sure you come. Come because I'll become president on that Monday. But I want to thank you. Thank you so much for having me. And that's the top 10.
So tell us about ACC, knowing that every year they keep cutting some RVUs and physician payments. So what is the ACC?
I knew that would wake you up. Yes, so we're very, very much, you cannot know that a lot of the funds that we all in the board approve from the finance committee is to make sure that our advocacy group is strong and pushing back on these cuts. So we are working very, very hard with CMS, FDA, all of the payers, insurance payers, and really advocating for all of you, the members. But it is a very, very difficult path. These things are pushing us to the end. And we are spending a lot of money, but we have not given up. And this advocacy and what we do for all of you in terms of preserving the physician fee payment schedules, those are really, they're right there. They want to cut us off. The moment you make procedures more frequent, easily accessible, and you're sending the patient home as if they came in for their teeth cleaning, they want to pay you as a tooth cleaner. So we need to make sure that we preserve what we are doing, showing the kind of need. And by the way, they see that cardiovascular care and morbidity, mortality hasn't moved. Why should we be paying so much if there's no movement in reducing the burden? If the United States is now behind China, what are we doing wrong? And so that's how the government is thinking in terms of cutting, and we have to really, really help and make sure that this doesn't happen. And believe me, we're advocating for each and every one of you, especially for our nurses, nurse practitioners, the entire CV team, and the telehealth, cutting telehealth for, it's huge. It's very, very negative in the patients who cannot come. So who do you hurt? You hurt the person who doesn't have money, who's old, who's very sick and cannot take the train and the subway and walk to get here to Mount Sinai to see Dr. Sharma. But if your nurse practitioner could see the patient and deal with their medication and still have some payment because there is work that she's doing, reviewing, all of that, her time is valuable and is your time, then we really could help that patient and improve their outcomes. So those are some of the things we're doing.
Now, clearly the ACC is your friend. I mean, that's the only organization along with probably AMA.
It is the only organization that's pushing hard, and we're working very closely with the AMA, by the way, yes.
All right.
Thank
Thank you.
you.
Beautiful lecture. Okay. We continue our second topic, as you see here, coming on, about the top 10 advances in heart failure is being given by very expert in this field, Dr. Mandeep Mehra, who is the William Harvey Chair in Advanced Cardiovascular Medicine, and he's great expert, taught us a lot of in the field of heart failure, transplantation, and many of the guidelines. So really we are going to hear from him on the top. The rest of the bio, everything is available on the website, but I'm so glad that he could come, and he has a little time short, so questions, be ready for any questions you need to ask him after his presentation, because then he'll be leaving. All right, Mandeep, thank you.
Thank you so very much, Dr. Sharma, and it's such an absolute privilege to be here with you all. You can always sense the passion of a place and its forward-looking direction just by the tone and the energy and the vibrancy in a room. And if there was anything that you take home from the last talk, it is passion and vibrancy, and I congratulate you for that. Legacy in a place is always determined by the resilience of their people and the forward-looking momentum. And we have such wonderful people here, masters of technique, masters of research, masters of policy, leaders that are second to none. I miss some of my friends who have uncharacteristically moved from Boston to New York a few years ago, like Deepak did. I know he is doing great, but I miss talking to him every day, Roxana, and it was one of the things that I missed the most. So it's such a privilege to be here. And I'll take you on a very quick odyssey of what I think are the top 10 or so advances in the field. But as I thought about it, my thinking was that I not only want to show you what is now practically, clearly possible in terms of advances, but also advances in thinking and advances in science that will clearly shape our immediate future. So let's go on this journey, and first let's establish where we are today. Quite clearly, we now think of heart failure in a universal definition, and that universal definition really has just three domain characteristics to it: early left ventricular dysfunction, symptomatic persistent heart failure. We've gotten away from calling it chronic stable heart failure because we understood that by calling it stable, people developed a general inertia to therapy. So we changed the nomenclature to symptomatic persistent heart failure so that people would understand that it is a disease associated with residual risk and needs to continually be treated. And then there's this group of advanced heart failure patients. And the real distinction between these groups is that one is tackled through a neurohormonal and metabolic therapy pathway, while the other, at the extreme end, the 10 or 15% of patients who transition to advanced heart failure demonstrate exhaustion of the neurohormonal axis. So there are a number of foundational therapies. But what's the real challenge with all of this? The real challenge here is implementation. As much as the progress has been made in this field, we have a tremendous implementation gap, such that while most people would say that, you know, about 70% of people are on foundational therapy in our place, when you actually look at the data very carefully and you ask how many of them are on target doses of those foundational therapies, turns out it's somewhere between 1 to 15%, depending on the institution. So clearly we have a lot of work to do, and these efforts need to be moved forward in a positive way. One of my former fellows and now a very prolific scientist, Madhu Vaduganathan, worked with Scott Solomon some years ago and actually created this idea of how much life prolongation can be had with ensuring this foundational therapy and implementing it. And it turns out that for a 55-year-old or a 65-year-old, the typical population of patients that we see, there is as much as 6 to 8 years of life prolongation that can be attained. Now, of course, the challenge with creating data like this is that the assumptions here are that there's perfection of 100% access to therapy and more than 90% adherence to therapy and very low adverse event rates. And in the real world, that's just not true. So we don't get to see that. And somewhere along the paradigm shift that we have with these therapies, we get perhaps only 1/5 of the life prolongation that we actually could get with these therapies. Now, I will start by pointing out that William Withering, who introduced digitalis to us and cardiac glycosides in a clinical manner, is still alive and well. And Withering's digitalis seems to not have completely withered, as we have seen recently. And I'll share with you where that data is at this time point. So we are moving from digoxin to digitoxin, and there's been a reemergence of cardiac glycosides, at least in terms of data, somewhat weak, but still of significance to discuss today. Back in 1997, Salim Yusuf and others really pushed the mantle forward by investigating digoxin in the DIG study in sinus rhythm patients with heart failure. And in the primary endpoint of this was all-cause mortality, and that was not affected by digitalis. digitalis and digoxin at that time point. There was an increase in toxicity, so people just didn't pick it up, because in those days, most of the clinical trials, like with ACE inhibitors and beta blockers, were looking at mortality-related outcomes. And one would only advocate therapies in that realm at that time point, back in the late 90s. Turns out that if you look at the secondary endpoints, and if they were actually adjudicated in the light of today's data, you would actually consider it a potentially approvable drug from the data that was presented in 1997, because the combined endpoint of all-cause mortality or heart failure hospitalization appeared to be significant. Even hospitalizations for heart failure alone were clearly quite significantly decreased, and death from worsening heart failure itself almost reached significance around that time point. So this really resulted in not much use of digitalis and digoxin. And in fact, there were challenges in the sense that women who were exposed to digitalis in the trial were disadvantaged to some extent, with a signal of increased harm in later studies that came out, secondary post-hoc analyses, and they really created a dissonance in our thinking of not using digitalis, and we stopped using it generally. Until recently, the DIGIT-HF trial was published. This used digitoxin, not digoxin. So there are two glycoside plants, digitalis lanata, from which digitoxin is created, and digitalis purpura, from which digoxin is created. Digitoxin is a longer acting and hepatically cleared molecule. And in this study, which only included 1,200 patients randomized to a placebo-controlled arm, there was clearly a significant reduction in the primary endpoint of death from any cause or heart failure hospitalization. Very modest. You see the curves actually converging again, but it's also because they didn't have enough patients to follow in the long run. The bottom line with this trial is that it was underpowered. They really wanted to enroll 2,400 patients, and if you think about it, the entire number of patients enrolled in the DIGIT-HF trial was half the number of deaths in the DIG heart failure trial in 1997. So clearly the fidelity and precision of this data is questionable, but yet it did raise the issue from one standpoint, and that is, if you look at the combined all-cause mortality or heart failure hospitalization endpoint from the DIG-HF trial, and you look at the same endpoint in this trial, they look eerily similar, suggesting that if instead of digitoxin or digoxin, you call this an SGLT2 inhibitor, for instance, in HFpEF, you might actually have considered it as reasonable therapy in patients with heart failure. Now, a few things about foundational pillars of therapy in HFpEF. In the old days, whenever we would present a data on heart failure, and the first slide on heart failure with preserved ejection fraction used to be a blank slide. We used to say, here's the evidence for HFpEF. And now I'm pleased to tell you that that's no longer the case, and there are at least 3 reasonably foundational therapies that I would argue have withstood some of the scrutiny and clinical trials in HFpEF. Those include mineralocorticoid receptor antagonists, SGLT2 inhibitors, and GLP-1 agonists. And I'll just very quickly run through where the advances in this are and where the current understanding is in the field. So the first trial in this was the TOPCAT trial, which was conducted from the Brigham by Mark Pfeffer and colleagues. And this trial actually was a neutral primary endpoint trial until it became obvious that there was some significant geographic heterogeneity, which is shown over here. That if you look at the Americas, which basically includes Canada and the United States, compared to Russia and Georgia, that not only was there a discriminatory component to the frequency of events across these 2 regions, but that if you only isolate the data to the Americas in this post-hoc analysis, that there was a clear reduction in the primary endpoint of CV death, aborted cardiac arrest, or heart failure hospitalization with a hazard ratio of about 0.82. It's important to keep that in mind because we now have another trial with finerenone, which is a non-steroidal MRA, that actually suggested the exact same thing. And if you look at the rate ratio in this case, not the hazard ratio, but the rate ratio, it's about 0.84 for the same endpoint, suggesting, again, very much like the digitoxin and the digoxin trials, similarity in these endpoint outcomes, suggesting that this is a very reasonable therapeutic stance in HFpEF patients or those with an EF above 50%. Now, whether a steroidal MRA is better than a non-steroidal MRA remains an open question at this time point. And while we think that there might be a lower rate of adverse events with non-steroidal MRAs, what is more important is access to this therapy and making sure that people get one of these agents. The other issue relates to SGLT2 inhibitors, and this is a wonderful piece penned by Dr. Braunwald in the New England Journal of Medicine, where he suggested that there is not just one mechanism by which SGLT2 inhibitors work. We always thought they were a diabetogenic prevention drug that was glycosuric, and it turns out that while that is a fundamental effect of these drugs, that these drugs may actually act through many other cellular mechanisms, perhaps through ketones, perhaps through decreasing insulin resistance, perhaps through other activity in many ways that one still doesn't comprehend, but they seem to work. Now, if you look at the sum total of the aggregate data, with SGLT2 inhibitors, and of course, Dr. Bhatt has been a pioneer and leader in that with the Soloist trial and with that particular SGLT2 inhibitor. But if you just think about this class, one of the things that has become very obvious with SGLT2 inhibitors, which we have not seen with any other drug class in heart failure, is that there is some kind of an effect on renal endpoints as well with these drugs, whether you're diabetic or you're non-diabetic with heart failure. Turns out that we have not seen that renal effect with enough precision in HFpEF, but we've seen that in HFrEF pretty reasonably. So these drugs are clearly placed for both heart failure with reduced ejection fraction, but more importantly also with heart failure with preserved ejection fraction. The cost effectiveness of using them in HFpEF is not as clear as with HFrEF, but suffice it to say that most of us would advocate the use of SGLT2 inhibitors in that scenario, at least for heart failure hospitalization reduction. Now, the third class that has shown clear benefit to some extent in the early trials are the GLP-1 agonists. And this is the Summit trial data showing the outcomes with tirzepatide for heart failure with preserved ejection fraction and obese patients. And this clearly showed that death from cardiovascular causes or a worsening heart failure event were impacted in a positive manner here with a significant difference with this drug class out to just as much as about 2 years. Now, it also improved quality of life, which is very difficult to show in heart failure-related pharmacotherapy trials, but it did show that. And what is interesting here is that the mechanism of action is becoming very, very important for us to think about. So one of the most important advances was to try and figure out what happens to the physiology of fat, if you will, that is actually pericardial or paracardiac fat. And it turns out that in a sub-study of the Summit trial, that tirzepatide use was associated with not only a reduction in epicardial fat, but also in paracardiac or visceral fat that is obviously biologically quite active, which has led some, including Milton Packer, to propose the adipokine hypotheses now, which I've never seen such a flurry of papers in JACC where the entire issue of JACC is nothing but related to adipokines. And I know, Deepak, you had a paper commentary as well, which I thought that Subodh Verma in your paper was probably one one of the best written commentaries in that entire compilation. But suffice it to say, the idea here is that it's somewhat preposterous to only implicate one pathway in HFpEF, but the idea is that if you consider HFpEF to be a disease of obesity and of visceral fat changes, and that just like the neurohormonal hypotheses in HFrEF, that there is a adipokine hypothesis in HFpEF, where you have adipokines which are initially cardioprotective, but as disease starts to get manifest, they become compensatory, and once they lose their compensatory mechanism, they become maladaptive, as is the case with traditional neurohormonal therapy. That hypothesis has been proposed so that treating adiposity in patients with HFpEF may be a singular target, but of course treating hypertension is equally important because the population attributable risk of hypertension in HFpEF and heart failure in general probably outpaces the population attributable risk of obesity. One could argue that the definitions of obesity as we adjudicate them may be open for question, and we can discuss that. What is unique, though, about GLP-1 agonists is that while they seem to work in HFpEF, they don't seem to work in heart failure with reduced ejection fraction. In at least 2 trials, the LIVE trial and the FIGHT trial with liraglutide, have suggested that to be the case. And what that perhaps suggests is that the adipokine hypotheses may not be as important in heart failure with reduced ejection fraction. And in fact, the use of GLP-1 agonists in HFrEF may be more directionally prone to either no benefit or harm, and that is certainly an issue that needs to be kept in mind. Now I'm going to move forward very quickly and point out to you some oncologically inspired therapies in heart failure. And quite clearly, cardiac amyloidosis is the first thing that comes to mind with all of the flurry of therapeutic interventions. Just to frame this for the audience, there are 2 kinds of amyloidogenic protein substrates. One is AL amyloid, the source is in the bone marrow, and TTR amyloid, the source is in the liver. And we now know very well that a number of treatments, either stabilization of the amyloidogenic proteins in blood, or the complete reduction of the generation or production of these drugs, of these proteins, may in fact be very, very important in reducing morbidity and mortality in patients with cardiac amyloidosis. Now, to frame this, the way in which you can reduce production of TTR, for example, in the liver, is through using silencing RNA, vaccine-like drugs, such as vutrisiran, or a antisense oligonucleotide drug like inotersen, or you have now CRISPR-Cas9 therapy, and we'll discuss that briefly because this is a very important construct that is developing where you're once and done, where you give a gene-modifying molecular scissor-like therapy that completely abrogates the production of these agents. The other strategy is to use TTR stabilizers, such as tafamidis or diflunisal in different areas. And so this somehow reduces the outcome from morbidity and mortality with amyloidosis. Now, one always wonders that once the protein isn't in the heart, why would these drugs actually work? What is it about the disease? Certainly, disease progression can be decreased by the use of these drugs, and that signal has been seen in most of the trials where NYHA class 3 or 4 patients with cardiac amyloidosis don't seem to benefit from drugs like tafamidis. And the reason they don't is because they don't remove amyloidogenic protein that is already in the heart. So what is the mechanism by which these amyloidogenic protein reductions actually work? And most likely, we are now understanding that the reason for this is that the prefibrillar species of these proteins that are abnormal oligomers that then deposit in the heart are actually directly cytotoxic, and they're directly toxic to the mitochondria and to other cellular elements. And by reducing that direct cytotoxicity, one can inhibit some of the actions on the heart. It's almost like reducing cytokines in sepsis, for instance, and improving cardiac function. So there are two mechanisms of action in our thinking of how amyloidogenic treatments work. Now, this is a CRISPR-Cas9 based technology, molecular scissors, just to give you a very, very rapid sense of how these work. Let's say you want to change a gene in the liver. You would actually take a lipid nanoparticle in which you would put a TTR-specific guide RNA along with this enzyme Cas9, and this would then, through endocytosis, enter into the nucleus in the liver, go in and basically edit out the TTR-producing gene, and in essence, it would reduce the production of TTR with just a single dose of medication. And you would say, well, what evidence do we have? And in fact, this movement has gone a bit quite far, with at least 36 patients dosed now, which have been reported, of which this represents about 33 patients who actually were fully dosed. And it shows that with a single intravenous dose of this particular medication, that there's almost a 90% reduction in TTR production with this for at least 3 years out so far, suggesting that there is, in fact, a possible vaccine for amyloidosis as well in the future. And this particular direction of therapy is a major advance in our thinking because, as I'll share with you, there are at least a few other examples that could impact heart failure. Now, the biggest advance, I think, in amyloidosis, which is still in its nascent form, is about actually removing amyloidogenic protein from the heart, which has already been deposited. And this is an antibody, N1006, which basically is a selectively binding antibody that binds to misfolded TTR amyloid fibrils, but not to native TTR. So it's highly selective to an abnormal oligomer that has already deposited. And the early data with infusion of this antibody in a few patients, and this is now the subject of a much larger clinical trial, is that you can in fact decrease the extracellular volume with the use of this antibody. So stay tuned for this. This may be a very important advance in the field. Switching gears for a moment to hypertrophic cardiomyopathy, myosin inhibitors have been a great advance. Again, our own Dr. Braunwald appeared to have single-authored a paper, once again at his tender age of 96, on the role of myosin inhibitors. And it turns out that myosin inhibitors have been a great advance, a great story which we don't have time to go into, from preclinical to translational biology to actual therapeutics and commercialization. But in essence, we now know that in obstructive cardiomyopathy, hypertrophic cardiomyopathy, that these agents decrease the need for septal reduction surgery, improve symptoms, reduce the LV outflow tract gradient, and we do not yet know if they improve mortality, and we do not yet know if they change sudden cardiac death. That is still a open question. But in terms of advances, there have been two important trials that have been recently presented. The first, I would say, is the Odyssey HCM trial, which actually asks the simple question, does a drug like a myosin inhibitor work in non-obstructive hypertrophic cardiomyopathy? And the result was a bit strange because it did not meet its primary endpoint. It suggested that it does not, that this drug class is useful only in the presence of obstructive HCM. But the problem with this was that surrogate markers such as NT-proBNP and LV mass actually reduced in this particular study, raising some doubt as to whether it was just the short-term follow-up in the trial that achieved a neutral results, because sometimes there are trials where there's separation of curves after a year, after 2 years, and that may be the case here, but we just simply don't know. The second important trial was MAPLE-HCM. In the algorithms that you always hear about HCM as well, let's start a beta blocker first, and if that doesn't work, then use mavacamten as a second agent. This was a head-to-head study of aficamten versus metoprolol directly, and this actually seemed to be superior to metoprolol in reducing the symptoms and in improving peak oxygen uptake on exercise physiology. So stay tuned for this of moving these drugs in obstructive myopathy to a more proximate algorithm component, and stay tuned for non-obstructive HCM. Now, a few words about the pathophysiology of HCM, and our particular group at the Brigham, led by Carolyn Ho and Cricket Seidman, showed very early on that one of the big problems with HCM is not just the myocyte, but it is actually the extracellular matrix, in the sense that when you do see left ventricular hypertrophy in phenotype obvious HCM patients and you do MRIs, a lot of what you see is scar or late gadolinium enhancement, suggesting that it's not just a disease of the cardiomyocyte, and it might very well be that there are two components to it, which is an extracellular component as well as a cardiomyocyte component, because we know that even in carriers of the mutant gene, that there is evidence of increased collagen turnover in these patients. Now, this can actually be looked at in the form of molecular scissors or gene editing work, and some of the basic science advances that Cricket Seidman's lab is making is in deactivating these pathogenic genes in HCM using a single drug. So this is actually a mouse model of a mutant form of... Did I do this? It's the mouse model. It's the...
That happens almost every day. Not at all. And no one left the room, which is the most important thing. So I can still go on for a few more minutes. Thank you. So what you see here is that the use of a CRISPR-Cas technology, using, instead of a lipid nanoparticle, which is tropic to the liver, what is tropic to the heart is adenovirus. So you use AAV vectors to actually move the gene of interest through CRISPR-Cas technology. And you can see very nicely that in those that were treated with this, there was a 70% reduction in the area of fibrosis with this particular agent. So stay tuned for this, because we may in fact have a gene editing way of treating this by decreasing fibrosis. Now I'm going to quickly spend another 3 or 4 minutes to bring you up to speed with tackling a key vulnerability in heart failure and factors that influence transitional risk. So we know that we have to put people on GDMT, or guideline-directed medical therapy. We understand that. And in those with more advanced stages of symptomatic heart failure, we shift from neurohormonal therapy to what I refer to as invasive Laplace therapeutics, where you address the shape and the strain and stress within the heart and the cavity. You can use CRT for that, or you can use valvular disease treatments for that, or LVADs and heart transplant. But in between, one still has an opportunity for intervention. We haven't figured out what to do with the patients who leave the hospital exactly, who are on reasonable GDMT. How do we manage residual risk in these patients if they haven't reached the point of other advanced therapies? And in that sense, hemodynamically guided monitoring with implantable sensors, PA pressure monitoring, has been shown to at least decrease heart failure-related hospitalizations. Whether it reduces mortality remains uncertain at this time point. But there are some new advances that are coming up, and which is to actually look at the venous circulation and think about congestion in a much more proximate way. Turns out that your splanchnic venous reservoir actually acts like a ketchup bottle, and in fact, during sympathetic stress will push
blood into the IVC, which starts to buffer the system. And this whole notion of how we learned about heart failure as backward failure is perhaps not true. It's probably veno-forward failure, which one should think about in terms of redistribution of blood. And putting in a sensor that can in fact measure collapsibility of the IVC and its dynamic relationship to breathing might be a way to go. In fact, we have been working on just this and created a new physiologic parameter of an ambulatory congestion score that a clinician can use very easily, where we have shown with reasonable fidelity that the real paradigm shift with using this sort of a modality could be to actually use self-management for patients. So put the disease back in the hands of the patient, let them self-manage it with a clinically overseen model of care delivery, where there is a daily way of measuring whether a patient is still within physiologic realms or has transitioned into pathological realms of redistribution of blood flow well before the filling pressures go up. And that's the potential for this, and we are going to start a clinical trial called the NORM-HF trial next year on this. Now, just a few words about VADs and transplants. Deepak, do I have another moment to cover this? Yeah. So I will just point out that there is basically two concepts that I want to point out in advances in heart transplantation at this time point. One is that we have improved the sources of where we get donor hearts from, number one. And number two, we have improved the way in which we bring these hearts forward. And the second concept I want to point out to you is that we're now rethinking the way we think of strategies for caring for advanced heart failure patients into a paradigm of net prolongation of life. What is that? So the first observation is that there are about 75,000 patients with advanced heart failure in the US, and we service only about 7,500 a year, 3,000 with an LVAD, and about 4,500 with transplants. Now, there has been this increase in transplants largely because of donation after circulatory death, new sources. We won't go into the details of that, but I will point out to you that what has changed is that our old system of bringing hearts in little lunch boxes on ice has changed to much better preservation and now perfusion techniques. We won't go into the details of that, but that has expanded our reach. We can now go in and expand the ischemic time, which used to be 4 hours, to as much as 9 to 10 hours now in most cases. So we can actually access donors from anywhere. We've done heart transplants in Boston now from donors retrieved from Alaska, from Puerto Rico, and many other places, and we're doing this almost uniformly at this time point. Another technology with the left ventricular assist devices, this is the HeartMate 3 pump, which Sinai has great experience with, of course, is a wonderful, fully magnetically levitated technology on a platform that has actually changed the way in which these patients can now live and survive on ventricular assist device therapy as destination therapy or as bridge to transplant. And this particular pump is frictionless. It actually has an artificial fixed pulse and is wide and consistent blood flow pathways, so there's less hemolysis. What has this translated into? Well, it has actually changed the median survival of patients to well over 5 years now. And young patients, less than 50 years of age, tend to survive out to 7 to 10 years without complications with this particular pump. And most of these advances have occurred because of the introduction of better engineering technology. But still there is a gap. Most people don't know how to express the benefits of LVADs. And so I just want to go over that with you. The type of patient we want to put an LVAD in is a patient who has either a median survival of about 9 months, which is an inotropic therapy bound patient, or a median survival of around 18 months, which is a patient who is in ambulatory class 4 heart failure. In these patients, the use of this technology will actually improve survival by more than 5 years. Now, what that means is there's very few therapies in heart failure that actually triple, quadruple, or even pentuple the survival, and this is one of them in well-selected patients. But it isn't survival with misery. It's survival with reduced the quality of life goes up. the burden of disease is reduced significantly in these patients, and NYHA class functional 1 or 2 is retained in almost 80% of patients out to 5 years. We have tried to create communication algorithms to help people understand when to refer these patients, how to refer these patients, and have even created something which is on the right side, which is lvaddecisionaid.com. You can access this website. You can, in fact, put in your patient's characteristics and derive a personalized outcome score out to what the expected survival on an LVAD would be today, out to 2 years or more in these patients. Now, one of the opportunities with LVAD therapy in patients, which is not accorded by transplantation, is the opportunity for remission in heart failure. If you look at this X-ray very carefully, there's an LVAD placed in the heart, but the drive line, which is the power source to it, is cut. This is called decommissioning of the left ventricular assist device, and instead of removing the devices, now we decommission them and leave them in the patient's chest. This is basically a way of treating patients, particularly young patients. They may actually have a 40% chance of achieving sufficient remission if you look at patients under the age of 50 with recent onset heart failure who have non-ischemic cardiomyopathy, 40% of them. And that's not an opportunity to be missed. So that's why we have been now pushing the idea of net prolongation of life. In fact, the young patients who have no comorbidities, when a transplant center looks at them, they say, this is a really juicy patient for transplant. And what we're saying is that that's the absolute wrong way of looking at it. That if you actually want to prolong that patient's life, you need to think about an LVAD first strategy in appropriately selected patients, take them through to another 10 years, and then do a transplant. Because if you take a transplant today, the median survival with a transplant is 12 years. The chance that a patient can be retransplanted is only 4 to 6%. If they need a retransplant. Whereas the median survival with LVADs in young patients is well over 7 years, and that's only because this technology has been around for 7 years or more that we've had the chance to measure it. Final words about xenogenic transplantation. This is still an effort in evolution at this time point. We have still not been able to overcome the immune challenges with this particular issue. And frankly, we don't know what to do with this in cardiac transplantation. We will learn from our kidney colleagues first and then move this to our arena in heart xenotransplantation. There are also social and ethical barriers and healthcare resource-based barriers that are critical in this. This was the pathology of the first porcine to human gene-edited heart transplant that was done. And by 60 days, this heart was lost. And when the autopsy was done, what was unique is that all of a sudden there was a complete loss of the microcapillary bed. There was capillary rarefaction. It was almost a very accelerated form of vascular rejection or antibody-mediated rejection. And we still don't understand this very well. And therefore, I think it's going to be a little while before we move this to the heart realm. Now, a few words about AI. You've already heard about this today, but I will just tell you where the field is moving on population-wide health with advances in heart failure. We now have EKGs that can in fact inform left ventricular dysfunction with reasonable fidelity, and this is going to be very important as a very cheap way of looking at who is developing LV dysfunction and who can be treated with preventative therapy early on using just electrodes. Now, how this is implemented with what cost configuration remains to be seen. Another very interesting AI technology is vocal biomarkers in heart failure. It's very interesting in that AI can help you pick up subtle changes in jitteriness or shimmer, which is amplitude sensitivity or stability, or the harmonics of to noise ratio in these, and even the phonation time as people are speaking. And you can pick up these changes very nicely and see who is actually decompensating and who is not. And maybe this might be even better as a congestion test proximate to even other IVC-based parameters. The other way of using AI in heart failure is to use it for phenomapping and for better guidance of who should get an ICD or not. In non-ischemic cardiomyopathy, we still are confused in today's day and age as to who should have an ICD. In ischemic cardiomyopathy is much more clearer, but maybe AI will help us get to better risk stratification. So I'm going to end here by pointing out that maybe the future is in bioengineering a human heart. This is Doris Taylor's work, where they take a porcine heart, decellularize it, basically down to its skeleton, and then take induced pluripotent stem cells from a skin, and we can basically then create a new heart, which can then be shipped back, and you can actually transplant that as an autologous heart transplant in the future. So this, we think, is going to be the future. So I'm going to end with this and point out that using CRISPR-Cas technology and vaccine-like therapy with molecules like silencing RNAs is probably the best future and the greatest advance in heart failure. Why? Because it will prevent it. We can prevent Lp(a). We can actually reduce PCSK9 with single drugs. Shown to your lower left is zilebesiran, which is a drug that reduces blood pressure. And we are even getting smarter with anti-obesity therapies. So if we can tackle lipids, hypertension, and obesity, we think we will get very far in this syndrome. And thank you so much for tolerating me for a little longer than I should have gone.
Beautiful. All right, then questions for Dr. Hera? Either you send it or we have the, okay. Yes.
When you decommission the LVAD, what if the person gets worse in heart failure? Are you reconnected or?
No. So once it's decommissioned, it's gone. The reason for decommissioning is not to have the opportunity for recommissioning it or reanimating it, but simply to reduce the stress of the operation. So remember, the right heart is not supported, and putting them back on cardiopulmonary bypass could really be physiologically stressful. So that's why we prefer decommissioning. If the heart in remission becomes worse again, then we can always go ahead and do a transplant as a rescue. Yeah.
Okay, there are a few questions already. One is about the verisuguard making a weak comeback. Could you see a role for its palliation prior to escalating to a palliative milrinone?
Thank you. So, I'll speak over it, I think. Yeah. So, so the first question was about vericiguat, which is cyclic GMP drug, and this agonist drug basically in the Victoria trial, which was in heart failure with reduced ejection fraction patients who had recent worsening heart failure, showed a very weak signal of benefit, about a 4% absolute reduction in the primary endpoint, not a clear mortality signal, but a heart failure hospitalization signal. It didn't get much pickup at that time. And then one of the things that was found in the Victoria trial was that patients with a BNP level at baseline of over 5,000 appeared to actually have harm. So another trial was done in non-worsening patients, in stable patients with heart failure, called the Victor trial, and that had a endpoint, primary endpoint, which was neutral. The secondary endpoint on cardiovascular mortality appeared to have a benefit, and one can only take secondary endpoints as exploratory in that situation. Meta-analyses suggested that there is some benefit, but if you do a Bayesian study and you think about the data on a Bayesian probability standpoint, we know there is some benefit of using vericiguat, but we also know that its effect size is going to be extremely small. And the probability that someone will have at least a 10% benefit is less than 30% on Bayesian grounds. So I'm not so sure that this is a major advance, but it is certainly an opportunity in case your patient is symptomatic.
So second question is on the ATTR. Why do you think the stabilizers have better data than the silencer in ATTR?
So actually the best study, the Apollo study with vutrisiran, actually has very good data on it. And the silencers such as tafamidis do have good data, but not great data. In fact, with tafamidis, if you think about it, they only the silencers only help, the stabilizers only help in NYHA class 2 patients. In class 3 or 4, they don't. With the mRNA silencers, there was evidence that there was benefit even across the board in those patients. So I'm not so sure that one is better than the other, because in the clinical trials, they were actually not compared to each other, but as add-on therapy in many cases. So it's still unclear as to what that is. But I think the future will be of using silencers as long as they can be accessible and cheap.
Okay, so another question is, can you comment on the role of total artificial heart, such as titanium constant flow TAH, as a permanent transplant alternative?
Yeah, so it's a great question. So biventricular support with total artificial hearts is an emerging technology. I think the device that I'm most favorable towards at this time point is actually called a Bivacor device. It's a very small device. It's a very unique device in the sense that it doesn't have two chambers. It has only a single chamber, but it phase shifts into an RV or an LV. So it actually phase shifts in the way in which it flows blood, but it's a magnetically levitated rotor. But it does require hydrodynamic shift from right to left. This has been just tested in early feasibility studies. There have been 5 cases in the US that have been implanted as a bridge to transplant. The problem is that once you do a total artificial heart as a bridge to transplant in the US, the patient becomes a high priority as a status 1. The primary endpoint of these trials was to look at 30-day outcomes at a minimum, and most of these patients got transplanted within 2 weeks. And so we don't really know what its long-term fidelity is. The only long-term patient with the Bivacor device has been implanted in Australia with a 105-day outcome so far. So I think this one has some promise. Whether it will be a replacement to LVADs, I can't be certain, because excising the ventricles actually removes natriuretic peptides and actually causes duress on the kidneys in many ways. So I'm not sure that it's going to be a panacea, but it will be a selective option for most patients.
Okay, there are 2 more questions. One is, are there different treatments for mid-cavity hypertrophic cardiomyopathy versus apical hypertrophic cardiomyopathy?
I don't think we know the apical cardiomyopathy or the Yamaguchi type cardiomyopathy as it's known. I don't think it differs in many ways from the others. I think the same treatment can be employed, but if you take the Odyssey trial, one could argue that in apical cardiomyopathy you might not get the same effects that you do with truly LVOT obstructive cardiomyopathy. So we don't know the answer to that. Great question.
Okay. And the last one is, in a non-compliant patient with severe systolic dysfunction, EF of 20% or less, do we first cath or first try GDMT and CCTA?
In a non-compliant patient, you send them to Dr. Sharma because he'll take care of them, all right? No, but in a non-compliant patient, you know that GDMT is going to be very difficult to employ. And I think that in those patients, doing things that they don't have to worry about are a way to go. So for example, if a non-compliant patient has a left bundle branch block with an LV dysfunction, I actually think about CRT earlier than waiting for them to be on GDMT, because I haven't seen left bundle branch block improve very often with GDMT. So I think these are 2 separate etiologies. So there are different, you have to individualize to a certain patient's phenotype in thinking about these.
Fantastic, my friend. Great. All right, and sorry for this disturbance of what happened with the happened actually even the cath lab. Can you imagine you are doing a complex procedure and all of a sudden this fire drill starts? And we have been actually working through the hospital that at some key places like auditorium, with the procedure rooms, and so this should not be the nuisance, which can create trouble. All right, so we go to the next one, another very interesting and hot topic about the hypertension. We all know had been a trouble for many patients to be managed on, and for it we have a very great expert, Dr. Luke J. Leffin. He is the co-director of Center for Blood Pressure disorder at Cleveland Clinic, associate professor, multiple papers, and expert in this field, of course, will give us key important points. How do we manage the top 10 advances in hypertension? All right. Great.
All right. Well, thank you very much to everyone for the invitation to speak here. It's great to be here. And so, well, let's get started. If I was giving this talk about 10 years ago, this is what I would have showed you, okay? ACD combination, that's really all we had. Then about 10 years ago was the Pathway 2 trial, and we know that spironolactone is next line therapy for resistant hypertension, and that's sort of where we were. There was some stuff on the edges. What we know, particularly in the last about 5 to 7 years, is that hypertension care, which is incredibly, hypertension is incredibly prevalent, but it's really had a renaissance because we're understanding that we're not doing a good job treating it. And I would argue that that right now is not good enough for us, and the data would support that. If you look, these are the circulation AHA statistics that are published every year, and unfortunately, this chart does not change very much, okay? On the left side, we see control rates of hypertension, and this is to a 130/80 or less definition, and we're less than 30%. And it doesn't matter if you're Black, white, Hispanic, Asian, although there's small differences. We do a poor job of controlling blood pressure in all those groups. We do a poor job in elderly and younger people as well. So we need to move the needle a little bit. And so the overarching question that I asked myself as I was coming up with these top 10 was, and I want you to think about it as I talk, is how can we more effectively control blood pressure in our patients and more globally in our communities? So here's the hypertension top 10 list. I won't read them all right now, and this is not in no particular order, but I think it's really important, and I'd like to touch on as many of these as I can over the next 25 minutes or so. So many of you know that really very recently, back in middle of August, American Heart Association, American College of Cardiology, multi-society blood pressure guidelines were released. And a great document, worthwhile looking at the key points. It was a little bit iterative in how it was presented. There wasn't any huge changes, but I'd like to highlight a couple, okay? Number one, and this is something that we can really practice every day with our patients in clinic, is although many of us are trying to get them less than 130, which is what we've done, there's new language that's highlighted here, with encouragement to achieve a systolic blood pressure less than 120 millimeters of mercury. And this is building upon data from SPRINT, which targeted a blood pressure of less than 120, but only achieved 121 for systolic blood pressure. But more trials have shown that the lower the better in terms of blood pressure reduction. And this doesn't matter if your patient has or doesn't have diabetes. We know that this should be achieved if reasonable, if we're not adding a fifth, sixth medicine and getting into side effects. What we also know is, this is a little bit more clear, that patients with stage 1 hypertension, we want to give them about 3 to 6 months to do the lifestyle, but really don't kick the can down the road, or don't let them kick the can down the road any further. After that, we need to start thinking about medication choices in these individuals. What I think was something that is really actionable with our patients right now is it's now a class 1A recommendation that the treatment of blood pressure prevents mild cognitive impairment and dementia. And I like to refer to this as sort of the fifth finger. So when I'm talking to my patients, and we start really broadly, and we say, well, why do we want to treat your high blood pressure? We want to prevent kidney disease, strokes, heart attacks, heart failure, and now I've been able to add that fifth finger, dementia. And I'm probably not surprised that most people perk up, okay? We have good treatments for, heart disease. I mean, we just heard about great treatments for heart failure. We don't have anything for dementia. And so, as was alluded to earlier, this gets people talking and thinking, yeah, my aunt had dementia. I don't really want that. So how can I be more aggressive, more adherent, all those things? All right, so those are some of the big things with the guidelines. Some other changes are sprinkled throughout the other top 10 points. The next thing that's really important, and even as cardiologists, we need to be doing this, is really testing patients for primary aldosteronism and dysregulated aldosterone. This is seminal work from back in 2020, looking at 4 major hypertension centers and looking at the prevalence of excess or autonomous aldosterone production. And this is even amongst amongst patients with untreated normotension, about 11% had primary aldosteronism. And if you go up to treated resistant hypertension, that's approaching 25%. And then in between for those untreated stage 1 and stage 2. So we know autonomous aldosterone production, otherwise that are branded as dysregulated aldosterone production, is prevalent, and we need to be recognizing that in our patients. This was really more prominent in this set of guidelines, okay? Everyone with resistant hypertension, irrespective of if they have hypokalemia or not, should be screened for primary aldosteronism. That's very clear, and that's with just an aldo and renin, okay? We do not need to stop medicines in this scenario as well. The only ones that we should stop for about 4 weeks, at least for the initial screen, is going to be spironolactone or pleuronone, our MRAs. And then importantly, although it's only a 2B recommendation, is they say you can consider testing all patients with hypertension for primary aldosteronism because it is so prevalent. This backs up other guidelines. Now, this is from the Endocrine Society, which were published in July of this year, and this is their primary aldosteronism guidelines. They advocate, as well as the ESC hypertension guidelines, for screening all individuals with hypertension for primary aldosteronism. And then there's a nice algorithm there about how that we actually think about it once we get those data back. And so as cardiologists, if this is all you really have to do, and then send it to a hypertension specialist, send it to an endocrinologist, but at least if we're looking for it, if we're not looking for it, we're never going to find it, and we're not going to be able to treat patients effectively. All right, number 3, single pill fixed dose combination therapy. This is, we do a horrible job at this in the United States. They're better in Canada, better in Europe. It's very clear. The data is clear. People don't take multiple pills. They don't want to take multiple pills. They may if they have heart failure or something that severely impacts their quality of life. The vast majority of people, hypertension, particularly sort of long-standing, doesn't impact their quality of life until they have a stroke or heart attack. It's a silent killer. I mean, we talk about our patients all the time. So we need to be starting patients that are 140/90 on fixed, single pill, fixed dose combination therapy. That's pretty clear. Now, those individuals with stage 1 hypertension, you can start with a single antihypertensive drug is reasonable, but now American and European guidelines both align with saying we should be on, amlodipine benazepril or amlodipine olmesartan, some combination if we're in that 140 or greater blood pressure range, and so important to understand that. We also know that we're moving away from the inertia of thinking that these drugs and combinations are expensive. They are not. One of our residents at Cleveland Clinic did this and looked at the cost of these drugs at Mark Cuban's Cost Plus Drugs or GoodRx. These combinations are not that expensive, okay, when you look at on a 30-day. And so they're widely available. And there is even some 3-drug combinations. One that I'll point out, and it's not clinically available yet, but these studies have been done, and they're looking to launch by the end of this year or early next year, is a really exciting triple combination of amlodipine, telmisartan, and indapamide. And if you're not familiar with, one of the downfalls of some of the combination pills is most come with hydrochlorothiazide, which as you know is our weakest thiazide-type diuretic. This comes with indapamide, which is a little bit longer acting, closer to a 24-hour effective half-life rather than the 16 to 18 hours of hydrochlorothiazide. And we don't really know what the pricing is going to be, but when you talk to the company, they're trying to aim in that sort of that $30 to $40 per month. So that's not going to be for everyone, I'm not saying, but it may be an option for some individuals if they're paying, $14 to $16 for, 3 separate pills. Would they be willing to pay, $30 to $40 for just a single pill once a day? So that's called Widoplex, so as a brand name. So keep an eye open for that. All right, number 4, renal denervation. It's been a long journey for renal denervation. I'm not sure if Dr. Bhatt is still in the audience, but he knows sort of the real ups and downs of this. About 10 years ago, renal denervation had a major shift because of the neutral endpoint for Simplicity HTN-3. Then there was a lot of time, a lot of energy, a lot of money invested into saying, well, why didn't those trials work, and what should we be trying to do? And I think a real big milestone in renal denervation these days is now it's in the guidelines. It's a class 2B recommendation that in carefully selected patients, renal denervation can be considered. This guideline was very conservative in how it looked at renal denervation, so it recommended very strict criteria based on the trial criteria. So 140 systolic and 90 diastolic have to be higher than, and you have to have a GFR over 40, and you have to be on optimized medical therapy, which if you delve a little bit deeper in the text was 4 drugs and uncontrolled, so including those patients on spironolactone, not your true definition of resistant hypertension. And so you have the list there of some of the contraindications, but we're doing it more and more frequently at Cleveland Clinic, and it may be something that's important down the line as we get more data. One group that I think is underappreciated with this are the patients that you go into their medical chart and they have about 20 allergies. They take their losartan and their toe hurts and they're not going to take it. We know and we see this, and irrespective of whether the side effects that they get from drugs are, if they're real or they're perceived, it doesn't matter, because they're not taking the drugs. So this is an opportunity for us to get roughly about 1 blood pressure medication worth of blood pressure lowering in these individuals in a single same-day procedure. Beyond the guidelines, so CMS has a national coverage determination out for renal denervation. This was a placeholder slide that I was supposed to update October 8th because the final decision, they go through all the draft comments and everything. However, we still don't have that because of the government shutdown. But I expect soon, once that government, when things open up again, we'll get the final coverage and see how CMS is looking at it, what and how it will be covered nationally. And it was generally a pretty favorable statement initially. Also, renal denervation, the next generation of renal denervation is not just looking at denervating the renal arteries, but also the hepatic artery as well, and seeing can we have improvements of cardiometabolic risk factors such as hemoglobin A1C, insulin sensitivity, et cetera. So those are pilot trials, but more to be determined and to come in that scenario. All right. Aldosterone synthase inhibitors is number, I think it's 5. We know, and I alluded to it earlier, that aldosterone production is bad for most organs. Excess aldosterone production is bad for most organs. And we know that you don't have to have overt primary aldosteronism to have high blood pressure due to autonomous aldosterone production. We can see this really in primary hypertension as well. Aldosterone synthase inhibitors are a new class of medications, and you don't have to take my word for it. There's a lot of people that think that these are really a success story and really the next generation of very effective blood pressure lowering drugs. What is an ASI? Well, essentially it disrupts aldosterone biosynthesis, and it's different from a mineralocorticoid receptor antagonist, which blocks the mineralocorticoid receptor where aldosterone binds to. Prior generations of this, what they weren't is they weren't selective for what's CYP11B2, which is on the bottom left-hand corner of that picture. And so they also inhibited CYP11B1 and decreased cortisol production. We know with these newer generations that they're more selective, much more highly selective for CYP11B2, reduce aldosterone production, which without impacting the cortisol axis. And that's why there's a lot of industry development in this space. So here's the overview of really 4 drugs. They're being studied for a variety of indications. Dexfadrostat on the bottom left, really the major that it's been tested in is primary aldosteronism. Baxdrostat and Vicadrostat are being studied in heart failure as well as kidney disease. Vicadrostat is not looking at the hypertension angle of things, so I'm not going to talk about that. Baxdrostat has looked at hypertension. We'll go through that. And then lorundrostat, at this point, has been studied in hypertension, CKD, and interestingly, an ongoing study in obstructive sleep apnea as well. So what are these data? So these were presented at ESC just back in August. This was the BaX-HTN trial, pivotal regulatory trial of Baxdrostat compared with placebo at 2 doses, 1 and 2 milligrams. And it was 12 weeks, double-blind, placebo-controlled. Office blood pressure was the primary endpoint. And what was seen was anywhere between about an 8 and 10 millimeter of mercury reduction in terms of blood pressure. And that's placebo subtracted. And so very promising in this scenario. BaX24, which is their 24-hour ABPM study, is going to be presented at AHA in a few weeks. Advanced HTN, this is near and dear to my heart, many years with this. This was presented at ACC last year, published New England Journal in April of this year. This was the phase 2B of lorundrostat, so another ASI, looking at 24-hour ambulatory blood pressure changes. And as you can see here, placebo-adjusted change was between 6 and 8 millimeters of mercury in 24-hour ABPM. Now, it's important to remember, comparing office and ambulatory or 24-hour ambulatory, you can't look at it sort of one for one or similar. Typically, ambulatory blood pressure reduction is less than what we see in an office setting. Now, this was an interesting trial in that we put patients on a standardized regimen. And so it wasn't just usual care. We maximized what they were on and then added lorundrostat. Subsequent to this was the pivotal phase 3, which was office blood pressure on the background of usual care compared with placebo, and very or strikingly similar to the baxdrostat data, right about 9 millimeters of mercury in systolic blood pressure reduction. And it didn't really matter any of the other factors. All the subgroups looked good. So what is needed to support its clinical use? Well, these really. We've got upper left-hand corner here. One thing that we haven't seen, and we probably won't see from industry, is head-to-head compared with spironolactone. But, let's see. Let's to be determined there. All right, next, angiotensinogen-directed therapies. These are exciting. Angiotensinogen is really the top of the renin-angiotensin-aldosterone system. Can we modulate those levels and actually reduce blood pressure? Let's see. This is an increasingly crowded space, so we will get that answer, okay? There's a variety of siRNAs, and there's one antisense oligonucleotide that's being studied as well. The one that has far and away the most data are the zilebesiran trials, which were alluded to last time as well, and so we'll talk about those. The phase 1, that was in New England a few years ago. The Cardia trials, 1, 2, and 3, have all been published within the last couple of years, or at least presented. And then really what the big plan there is, though, is a cardiovascular outcomes trial with zilebesiran. Here's Cardia 1. This was phase 2 on the background of no blood pressure medicines. And what was seen was a placebo-subtracted 24-hour ABPM reduction of about 15 millimeters of mercury across a variety of doses, okay? When you got into looking at it in the background of a single drug, so either in combination with indapamide, in combination with amlodipine, or in combination with olmesartan, you see that not surprisingly, a little bit more efficacy in combination with the diuretic, a little bit less with an ARB, about 5 millimeters of mercury. And just one thing I neglected to say, these are subcutaneous injections every 6 months, like most siRNAs. So interesting. Now, Cardia 3, which was also phase 2, was just presented at ESC. I won't spend a lot of time on this, just saying that the results for it were a little bit underwhelming, okay? The way they did the statistical analysis, it actually wasn't significant with either dose, but the company pushes ahead. And the Zenith trial is their cardiovascular outcomes trial that will randomize patients 1-to-1 to placebo or zilebesiran and see how they do from a 4-component major adverse cardiovascular events. So we'll see. But that's coming out, and that's potentially a long-acting once every 6-month drug. Tonlamarsen is a once-a-month subcutaneous ASO suppressing drug, AGT suppressing antisense oligonucleotide, and this is being studied in the Cardinal trial, and that will be wrapping up relatively soon here. And so we'll have could it be even safer than an every 6 month? We'll see. We'll see what the future holds too. It's publicly available knowledge. We've heard a lot about CRISPR-Cas9 therapy today. CRISPR Therapeutics has publicly announced that they're going to do gene editing trial for AGT and see what that is. Maybe we can give a one-and-done injection to these folks, or infusion, excuse me. We will see. All right, incretin-based therapies. We know that obesity-associated increases in blood pressure, there's a lot of reasons why blood pressure increases with obesity, and all these mechanisms operate simultaneously. We also know that there's relatively inconsistent effects of a variety of prior blood pressure, or excuse me, weight loss drugs in reducing blood pressure, but definitely with semaglutide, we do see more than we've seen with other classes of obesity pharmacotherapy. Interestingly, the SURMOUNT-1 trial, which was tirzepatides and one of those key weight loss trials, showed that even among patients with a baseline of 123 millimeters of mercury of systolic blood pressure, you saw about a 7 millimeter mercury drop in office. There was an ABPM sub-study looking at 600 of those individuals, and you saw really sort of similar and even more robust results, about a 10 millimeter mercury reduction in ambulatory blood pressure with the tirzepatide 10 milligram dose. And that, again, was consistent across a variety of subgroups. One thing that I've been interested in for a while, and I'm happy to lead these trials, they're called the ATTAIN hypertension trials, looking at the small molecule orforglipron, which is an oral GLP-1 receptor agonist. And what these are looking at is, can this drug lower blood pressure, okay? We know it lowers weight, but what does it do to blood pressure? Are there other mechanisms by which it can work? So we'll see. And interestingly, in the guidelines, they now say that GLP-1s may be effective as an adjunct to lower blood pressure, and it's a 2B recommendation. All right, additional new mechanisms to lower blood pressure. There's been a few recent high-profile negative trials. Osadurenone in its Clarion CKD trial failed. There's a really interesting piece on Fierce Biotech is, I guess, on a website about that and recently, so I encourage you to check that out. There was XXB750, which was an NPR1 agonist that failed, but there's new other therapies in the pipeline as well. PDE5 inhibitors for hypertension may be an option. Modified atrial natriuretic peptide drugs may be an option. And actually, I was talking to Dr. Eldabi, who runs the hypertension center here, and I think at Mount Sinai, you're going to be a site for that, so that's interesting. What about wearable devices for blood pressure management? Well, the guidelines were pretty clear. It's a class 3 recommendation that there's no benefit among patients for using this. But that hasn't stopped companies. Apple actually released shortly after that, telling us that now our patients are going to use their Apple Watches to get hypertension notifications. Now, I will give them some credit. They are not giving patients a number, okay? That is fraught with a lot of obviously legalities, but also accuracy issues. But what they're going to do, not dissimilar to atrial fibrillation, is they're going to features on that, is they are going to give patients a warning and say, you may have hypertension based on this. Now go down this pathway of checking your blood pressure at home with a validated device, and then talk with your clinician about what you should do next. So be prepared for a few MyChart messages about that. All right, in my last 2 minutes, I still want to touch on the fact that the basics still matter, and that's point number 10. We have all kinds of new therapies. We talked about renal denervation. We talked about all these new fancy drugs, maybe even gene editing as well. But whereas I tell my patients, lipid management or lipids in general, the levels are about 70-75% genetic. The rest are lifestyle. Hypertension's the opposite, okay? What we're at is we're looking at about 70% lifestyle, 30% medications. And so what I really emphasize to all my patients is that the same or very similar tables have been produced in every guideline for the past 25 years in terms of blood pressure. Saying if we reduce weight, if we exercise, if we eat a healthy diet, including low sodium, we are going to lower blood pressure. I try to give my patients a chart like this every time I see them, and this is how much blood pressure is lowered with a lot of these interventions. Low salt diet's worth about 1 blood pressure medicine or 1.5 in most people. And I even tell them, and a lot of times, your ARB that you're taking, it's not going to be nearly as effective if you're overdosing on salt. So just something to keep in mind moving forward is we got a lot of new fancy tools. Well, I'm excited about the future for hypertension, but we still have to get back to basics with our patients. And it's surprising, even when they've reached the level of seeing a cardiologist or a specialist in hypertension, a lot of them are not quantifying how much salt they're having, et cetera. So the last point I'll leave you with is that hypertension in particular, because it is so prevalent, because over half the US population has hypertension, just physicians, just clinicians, we can't do it alone, okay? It needs to be a team sport. We have to engage our dietitians and nutritionists. We have to engage pharmacists, physician assistants, nurse practitioners, the whole team there, and then even exercise physiologists as well, if patients have access to that, to really help lower blood pressure. And so with that, hypertension is complex. There's not just one mechanism. We need to do a better job treating it. New medications and renal denervation are important new developments, but the basics still matter. Thank you very much, and I'd be happy to take any questions.
Fantastic. So the questions are already here. Now, what are your thoughts on the lack of emphasis on isolated systolic hypertension and the elderly population in general in the current hypertension guidelines?
Yeah, I think that, we can sort of cut the data from the renal denervation trials a lot of different ways. When we think about isolated systolic hypertension, some cuts show that it is beneficial. Some emerging data, particularly registries, now that it's clinically available, suggest those patients, because some of that hypertension is just driven by arterial stiffness and not an underlying sympathetic activation, that they may not derive as much benefit. And that may have been one of the challenges with the earlier renal denervation trials too, was that inclusion criteria was so broad.
Okay. Then is it acceptable to use Aldactone every other day with an ARB to minimize hyperkalemia?
I think that if that's working, I think that would be reasonable, right? I mean, I think that we know that spironolactone raises potassium a pretty significant amount. We thought that maybe the ASIs would negate some of that effect. That really wasn't borne out in either the baxdrostat or lorundrostat trials. There was still an increase. But I mean, I think that in certain circumstances, I will dose, spironolactone Monday, Wednesday, Friday, for example, and that can help patients.
And actually, the other question really which bothers me also in the office, that how do we really diagnose white coat syndrome? Patient comes in the office, BP is 180 to 200. Patient brings the records from the home, blood pressure is always 120, 140. What do we do?
Yeah,
very common.
Incredibly common. What I tell my patients is I do not put any stock in the office blood pressures. And I tell them it's not because they're inaccurate. They're very accurate. Our team is very good and well trained. However, we know that out of office blood pressures are the key, okay? And so I give everyone a handout. There's great resources on ACC.org about that, about how to measure blood pressure accurately at home and different ways to do that, in the morning and occasionally at night, before medicines, et cetera. And then the definitive test is a 24-hour ambulatory blood pressure monitor if you really want to get down to it. But I don't put a lot of stock in those patients that just have elevated blood pressures in the clinic. And I definitely wouldn't treat them more aggressively unless we have corroborating data for high blood pressures at home.
But let me ask you, is not that bad that even if under the stress pressure is 200, it's still bad, right? I mean, it is in the office. I know they are under stress, but then they are they're driving the car. There is a congestion. There are issues happening on the road. The pressure is still high. So does it matter whether it's in the office you got a blood pressure of 200?
So the data would suggest no, it doesn't, but there's a caveat to that. So in patients with white coat effect, so that means elevations in the office, but treated hypertension at home that are controlled, they have no difference in their outcomes compared with people with just controlled blood pressure at baseline. However, patients with white coat hypertension who don't have an underlying diagnosis of hypertension, so they're not treated and not checking at home, they do worse. And the thought process behind that is that then we always say, oh, it's just white coat hypertension, don't worry about it. And we don't actually get them to track their blood pressure more regularly outside the office. So we know that at some point, most of us in this room will transition to hypertension, and the out-of-office blood pressure is what really predicts cardiovascular risk if we're checking outside the office.
All right. So I think we learned a lot in this field of hypertension. Fantastic. All right. Continuation of that, we have another expert. in the field now, the diabetes and obesity, by Dr. Jeffrey Mechanic. He's a professor of medicine and the medical director of the Krevis Center for Cardiovascular Health at Mount Sinai Fuster Heart Hospital, and also the director of metabolic support for our division, and very expert, written multiple books, travels have globally, teaching everyone what to do, what not to do in terms of the food, and of course, keep yourself healthy. And he's going to teach us a lot of tips and tricks of tapped-on advances in the obesity and their diabetes. Thank you.
Thank you, Samin. Dr. Kinney, thank you. Dr. Bhatt, thank you for inviting me. It's always a pleasure. This is home, so it wasn't that much of a commute to get here. What I'm going to do is we're going to shift gears, but not really, because there's actually been quite a lot of overlap, if you haven't noticed, right? And some of the top 10s you have heard before. I'm going to perhaps give you a little bit of context. Here are my disclosures. We're going to talk about a different framework to anchor or interpret some of the data we're going to go through, and that's cardiometabolic-based chronic disease. You see, chronic disease is really the issue, and in fact, most of our patients have multiple chronic diseases going on at one time. Maybe 80% of people over 60 are going to have 2 or more chronic diseases. I'm going to divide the top 10 into first obesity. We'll split them halfway, 5 for obesity, 5 for type 2 diabetes. But I'm going to curate these papers in terms of what's pragmatic. So there's a lesson that you can actually take right back to your encounters with patients. So here's the model. Rather than looking at cardiovascular disease in isolation, each of the cardiovascular diseases and their own mechanisms, what we've done is we've looked at these cardiovascular diseases in terms of drivers, key mechanistic drivers, physiologically. And in fact, when you look at metabolic drivers and cardiovascular disease, hence cardiometabolic, you find that you're talking about atherosclerosis, atrial fibrillation, and heart failure. What we've done is we've built up models. Instead of saying obesity, which is stigmatizing, we use it in terms of abnormal adiposity, which incorporates ectopic fat and an abnormal adipocyte secretome, and adiposity-based chronic disease, actually been adopted by the Europeans as part of their guidelines. For diabetes, instead of looking at prediabetes in isolation or insulin resistance in isolation, putting them all under the umbrella of dysglycemia-based chronic disease. The two intersect, you can see on the right side where the orange is, they intersect at this key point of insulin resistance. And then everything feeds forward down to 4 stages of the chronic disease: risk, pre-disease, disease, and then complications. And ultimately, the goal is complication-centric, to prevent these complications. And you want to start as early as possible because of this exposure effect. All right, let's get rolling. We don't need our seatbelts. We got 10 papers to go through for the top 10. Let's first talk about intermittent fasting. I'll beat everybody to the punch because that's always a question. What do you think about intermittent fasting, right? What do you think about ketogenic diet? What do you think about all of these things that you read in Vogue and Cosmo and on the web? Well, here's a paper that came out looking at 4 to 3. And it's 3 non-consecutive days of, it's not absolute fasting, 80% restriction. And compared to, in the comparator group, daily caloric restriction, about 34% on average each day. Randomized controlled trial, 165 patients, 18 to 60 years, overweight to obese, looking at the BMI, and a 1-year study. They had high intensity comprehensive behavioral and exercise, so that's for both groups. It's an intent to treat analysis. There was a dropout of about 24%. This is not really a representative population. You can see in terms of male, female, and ethnocultural populations, not really generalizable. The patients with the intermittent fasting consumed less energy. Here's how I put it together. It's a potential tool, but really unproven in the long term. So if you have a patient and you're just not able to get anything done, this may be a tool to jumpstart the process. And it applies, in fact, not only just for weight, but the ADA has this in their standards of care. So if you need to get somebody controlled from a diabetes standpoint. So it should be in your armamentarium, but I would not put this in the bin of some long-term intervention. All right, we got 4 papers for tirzepatide, followed by 2 papers on semaglutide. These are the questions that everybody asks, and everybody is writing these drugs. I've just been tasked to chair a guidelines on muscle loss for the incretin-based drugs by the DNSG Diabetes Nutrition Study Group of the European Association for the Study of Diabetes. Hot area, right? So let's sort of go through it. This is the SURMOUNT-1 paper from the investigators, New England Journal of Medicine, looking at patients who had pre-diabetes, looking at diabetes prevention with tirzepatide. So it's a subgroup analysis, 176 weeks. It was during COVID, so there was a pretty decent dropout rate. Intent to treat analysis, and there was improvement. There was a benefit in terms of primary prevention. Patients without disease, they had pre-disease, and decreasing the rate of converting into disease, and that was with tirzepatide. So 3 years of treatment with tirzepatide in persons with obesity and prediabetes. So these aren't patients without obesity, patients with obesity and prediabetes, and substantial and sustained weight reduction and a lower risk for progression to type 2 diabetes than with placebo. Bear in mind, different ethnocultural populations, you have different conversion rates. Right, you go to MENA, Middle East, North Africa, you have very fast conversion rates. South Asia, Southeast Asia, very fast conversion rates. Here in the US, relatively slow conversion rates. So these kinds of studies need to be replicated in different populations. A head-to-head study, how often do you see these? Tirzepatide compared to semaglutide, our DREAM study, what we really wanted to see. We want to see whether it's more efficacious, and we want to see if the difference of side effects. Let me just give you the long and short of it. There was more weight loss and there was more reduction with A1C with tirzepatide, right? And you have 2 brands of tirzepatide, one FDA approved for type 2 diabetes, one FDA approved for obesity, the same with semaglutide. If you look at the GI side effects, so this comes up, and this is part of the nuance when you talk to patients, right, about the GI side effects. Actually, there were less of the GI side effects, 2.6% compared to in tirzepatide, compared to 5.7% 2.6% with tirzepatide compared to 5.7% with semaglutide. So less GI side effects with the tirzepatide. So you had more weight loss, more A1C reduction. But how do you put this together? We have a thing called insurance here, right? So yeah, we would love to use tirzepatide. You get your pre-authorization back. Either it's not covered or their copay is still like $1,700 a month, right? And it's a problem. So you need to first, I got no problem starting with the tirzepatide, but then you have to be prepared and let the patient know up front. You're going to work with them. You're going to run all the different options. There's a Lilly Direct option. There are different pharmacies you can go to. The nurse practitioners really need to be trained and develop an experience getting these drugs. We're pretty successful, but it does require an army behind every clinician to get this done. You've already seen this. Dr. Mera presented this tirzepatide for heart failure and preserved ejection fraction and obesity. So the key here is these are patients with obesity. We'd love to see this study done in patients with lower BMIs, right, who didn't have the ostensible indications for the incretin mimetic drugs. But in these patients, 48% had type 2 diabetes. You saw a reduction in CV mortality. And what we're going to do is we're going to see more of these studies for other things. We already have it for sleep apnea, but we're going to see it for addiction, for cognitive dysfunction, for cancer, for peripheral arterial disease. There are a host of other conditions that, for the pleiotropism of these drugs, that are going to be emergent. Lastly, for tirzepatide, I want to talk about muscle. It's very important to understand this concept. There's a lot of banter that goes around on the internet, and you hear it maybe in lectures, you hear it in some conferences, that these drugs cause muscle loss, right? And that you need to have higher protein in your diet, and you need to have progressive resistance training. Well, let's look at the data. What's actually happening is, yeah, the volume of the muscle goes down, but that's probably because of successful and desirable mobilization of the ectopic fat that's in the muscle. That ectopic fat comes out, the muscle function improves, but cosmetically or in front of the mirror, the patient's going to say, I have less muscle. When you examine the patient, less muscle. You need a hand grip device in your office to follow muscle function. Now, we need more studies to look at this. There are not that many studies as here with MR. We need better imaging for muscle. We need to understand this physiology better. We have some retrospective studies, registry data that confirm this, but it's not hard and fast. We also need to know what the optimal lifestyle should be for patients on these incretin mimetic drugs. And you know what? What's really important? Should we be de-escalating these drugs? I could argue that actually we should be. Contrary to what you've heard, that they're on it for life, maybe we should be escalating lifestyle to allow us to reactively de-escalate all of this pharmacotherapy. And we need data for that. We need to have medicines, and we need to have strategies and tactics on how to prevent the weight regain as we de-escalate and withdraw these medicines. Those are the research gaps. Cagrilintide, semaglutide. Cagrilintide is an amylin antagonist, and it binds the calcitonin receptor as well. This is a combination medicine. Basically, I included this study because this is coming out. There's a whole pipeline of more incretin mimetic drugs. There are going to be drugs that are going to have anti-sarcopenia agents on it. Glucagon's going to be on it. And all these drugs are in the pipeline. The older drugs are going to go generic. That's going to satisfy and solve a lot of the socioeconomic issues. But you can see here you had relative parity in terms of weight loss and A1C reductions with tirzepatide. Moving on, this is looking at semaglutide and cardiovascular outcomes in high-risk patients with type 2 diabetes. And with atherosclerotic cardiovascular disease and type 2 diabetes, also with chronic kidney disease, oral semaglutide is now showing this benefit. So if you recall, when all the CVOTs came out, we really didn't have oral semaglutide show superiority. There was non-inferiority, but not superiority. Here we have a little bit of superiority. Not much, but it's there. Efsitora is going to be a new insulin. We're looking at the end of 2025 for it to go to the FDA and then get approved. This is a weekly insulin. So it is an option now for your patients who have decreased beta cell reserve, right? And you want to come in with insulin where there may be some adherence issues. In general, as endocrinologists and as cardiologists, we really don't want to have so much insulin on board. It's anti-lipolytic, it's harder to lose weight, there's some atherogenicity associated with it. But if you need it, if there's decreased beta cell reserve, if it's late in the course, you're burning out the beta cells in type 2 diabetes, a lot of patients are just simply not going to do multiple injections a day or even daily injections. So this is an option. Keep your eyes out for this one. Non-inferiority study compared to glargine. This is an interesting study looking at chronic kidney disease in patients with type 2 diabetes. A lot of us, our common practice is maybe to add an SGLT first, think about finerenone, and sort of do them in a stepwise pattern. Here's a study looking at introducing both of them at the same time, initially. And showing some benefit in terms of blood pressure and GFR, in microalbuminuria. The potassium elevation was there. It was a little bit, it wasn't statistically significant, But this was, I thought, a very interesting study and something that may impact some of your practice patterns. We're going to move into 10A and 10B, right, to close it out, and this is on lifestyle. So to the left, this was a study I had just, when I was at EASD, and the paper had just come out and we were reviewing it. So this is an extension looking at the DPP trials, but all the way out to 21 years, right, and seeing persistence of that sustainable benefit and metabolic memory and legacy and all of that. But this is having a benefit going out to 21 years. Now, yeah, the curves are converging for lifestyle and metformin. Remember the 58% versus the 31%. They're converging going out to 21 years. But lifestyle on metformin really having some of that long-term benefit in terms of primary prevention, decreasing the conversion of prediabetes to diabetes. Then on the right side, Jordi Salas had sent this to me right after we were meeting in June. This came out, looking at the Mediterranean diet and PrediMed Plus versus the standard PrediMed. And standard PrediMed really didn't have that reduction in calories, but the PrediMed Plus had a reduction in calories and had a pretty sophisticated, comprehensive physical activity program, which actually also included flexibility and balance studies, decreased proprioception as we grow older. And actually, there was a nice benefit showing reduction in diabetes incidence in people who had overweight, obesity, or abnormal adiposity. All right, let's go through our conclusions. I'm running ahead of time. I'll give you some minutes back, Samin. This year's top 10 are interpreted in the context of this cardiometabolic-based chronic disease, not looking at a particular state in isolation, but rather imagining all of those early drivers and exposing opportunities for early and sustainable prevention, not waiting and waiting. Intermittent fasting is safe and efficacious, but still relatively unproven in the long term. We really don't have those long-term studies, but it is a valuable tool to keep in reserve and have in your armamentarium. Tirzepatide, if you look at the available incretin mimetic drugs, looks like it's performing the best in terms of benefit, weight, A1C. Also, you've heard about blood pressure, you've heard about benefits on cardiac function, and we have sleep apnea. There's innuendo and observations about addiction. Actually, I have 2 patients I've started with alcohol abuse disorder, and there's data on that. The cancer issues are emergent. There was a little bit of a scare among the endocrine field about an increased risk of thyroid cancer. Turned out it was an epidemiologic artifact. We're just looking for it more. A lot of people are doing ultrasounds, and everybody they're starting on the incretin mimetic drug. So yeah, there was a blip. You control for that. There's no increase in thyroid cancer. The medullary was in the murine model. So there's no real reason to go ahead and order calcitonin and get ultrasounds unless there's an established or family history of MEN or medullary carcinoma. But tirzepatide, and that, by the way, applies to all the incretins. Tirzepatide looks better, but you need to have that infrastructure so there's no practice gap. You need to have your team ready to go through all the insurance. Cagrilintide, amylin agonist, a promising incretin mimetic drug. I think I said antagonist before. Agonist, a promising incretin mimetic drug for abnormal adiposity and dysglycemia. It'll be coming out along with others in the pipeline. Oral semaglutide now showing some superiority, not just the non-inferiority from the prior CVOTs, and useful to reduce cardiovascular events in high-risk patients. So this was what was different about this study is it was high-risk patients. They did have chronic kidney disease. It was a longer-term study, so they were following patients for more time. Efistora is a newer weekly insulin and to be considered in select patients, particularly those who may have some issues with adherence. Think about starting both finerenone and EMPA, or not just EMPA, but an SGLT2 at the same time to reduce CKD progression, and again, in these patients with type 2 diabetes. Lifestyle intensification, practice gap. We need to develop more structure to be able to implement the lifestyle intensification, but the data are there with or without metformin, and for realizing some of those sustainable benefits in preventing type 2 diabetes that now are borne out by the 21-year data from DPP that I showed you. Predimed Plus, having that caloric restriction with the Mediterranean diet and comprehensive care, including physical activity, progressive resistance training, aerobics, flexibility. Balance study really seemed to help out in mobilizing some of the ectopic fat, decreasing abnormal adiposity, and general health. So with that, I'll stop. I think we have, you got some of your time back, and I'm available for
great.
questions. Thank you.
So I have actually, there's a question here. Once target weight is achieved, should GLP-1 and agonist be down titrated to attenuate risk of rebound weight gain and sarcopenic obesity rather than stop abruptly?
Yeah. So the question is about de-escalation and what do you do? And we don't really have guidelines that help us with that. Hopefully these will be forthcoming. I'm a big proponent of de-escalation, particularly for pharmacotherapy. We just included a chapter in our latest lifestyle medicine book. There are two kinds of de-escalation. There's preemptive, where the patient just really doesn't want to be on the medicines. You spell it out, okay, this is what you're going to need to do. You start cutting back. It's up to them to escalate the lifestyle. The other is reactive. So if you consider Michael Lean's study, Roy Watson's study with DIRECT, right? Every single person, when they entered DIRECT, all the blood pressure medicines were stopped preemptively. Because we know when you start losing all of that weight, all of a sudden the patients are getting dizzy and pre-syncopal because there's too much blood pressure medicine on board, so you preemptively lower it. So my bias is that when I'm starting an incretin mimetic drug, and this is more for weight loss, not so much for diabetes. Diabetes, they may need to be on it long term, but for the weight loss, I will put it out there. And they'll ask, Doc, am I going to be able to come off of this? How long do I need to be on it for? You all know that. That's the first thing that they say. And I'll give them that opportunity to step up the lifestyle. The other thing is we don't live in a binary world. Why can't they de-escalate? Something happens, they go on a cruise and there's some stress in their life, then they can re-escalate. What's wrong with delegating some of this to a patient-centered care, right? But we need to have the evidence to support that. As far as the muscle goes, this is actually one of the arguments in favor of the new high-dose semaglutide oral that's going to be coming out. And one of the markets is going to be, you have somebody on injection weekly, right? You want to de-escalate, get them off. You can then flip them over to the pill. And now it's a little bit easier. They feel like they're accomplishing something. But then you could even de-escalate that. I just want to throw in, you've all heard the term microdosing. There's no such thing as microdosing, right? But what they really mean is you can delegate to the patient. You don't have to do it every 7 days. It's not biblical, right? You could do it every 10 days, every 14 days, as you want to. But as long as there's medical supervision, that's the important point. The doctor needs to be involved.
Yeah. So actually, I see many patients, they do complain that on Ozempic, which is a semaglutide, the weight they did not lose the weight, but on tirzepatide, Mounjaro,
yes,
very consistent weight loss. Any mechanism or any reason for it?
Yeah. So the point is there value of switching from SEMA to tirzepatide, or even in reverse? So if you have somebody with adverse effects, sure, you can switch. There's no guidelines what dose. Usually I'll take an intermediate dose of tirzepatide to a maximum dose of semaglutide. So if there's adverse effects, you can switch both ways. But more often than not, somebody is on their max dose of semaglutide. They're not really getting the target weight loss we want. You've intensified everything else. I'll switch them to tirzepatide, and more cases than not, they will succeed. Mechanism. So it turns out that the GLP-1 will suppress glucagon. In tirzepatide, you have the GLP-1 and you have the GIP, gastric inhibitory polypeptide. And the GIP actually stimulates, nudges up the glucagon a little bit. We all thought maybe the glucagon going up, that was causing the proteolysis and some of the muscle loss, probably not. But if there's going to be a mechanism, that could be one of the mechanisms, is these subtle changes in glucagon, which, by the way, that's why these triple incretins that are coming out, glucagon's going to be part of that. You'll be seeing them in the next year or so.
Okay, few more questions came up now. Do the weight loss medication need to be stopped prior to surgery or interventions? If yes, for how long?
Right. So this is actually an easy answer. The real answer right now is probably a week. A lot of people are very nervous. The anesthesiologist, they'd like 2 weeks. There are some guidelines that say maybe 3 days before something minor. The problem was there were some patients that had some gastric content, and everybody was getting nervous, and 1 week was this arbitrary, you just skip one dose. And then some centers institutionally said, 1 week, we don't really feel comfortable, let's make it 2 weeks. They go back on it afterwards. You need to just inform the patient when you start that if they have a procedure, to ask the doctor whether they should be stopping it or not. Some endoscopists may have their own rules, so it's really important to advise the patient to discuss with the treating physician what their rules are. But 1 week to 2 weeks.
Okay. So another one we actually addressed to us, that too many doctors used to smoke, but now stop. Is there data that physicians are healing themselves and losing weight? I don't know losing weight. I don't think physicians are losing weight, but smoking, yeah.
Yeah, there's something called for obesity, I participated in a paper with some colleagues at Columbia on the hormonal versus the hedonic model of obesity, right? So hormonal, we know what all that is with the hypothalamus. But there is this hedonic model that there are pleasure centers in the hypothalamus, and you take away one pleasure, you need to make it up with another pleasure. So you take away the smoking, notwithstanding the nicotine and nicotinic receptors and other things, and all of a sudden food-seeking behavior and appetite and MC4, melanocortin-4, everything gets revved up, and you have orexia, more appetite, and the weight goes up. There is more of a public awareness, right? There are less physicians smoking now and less physicians walk. I mean, back when I was in medical school here, you could smoke on the floors. I mean, there were physicians literally smoke. I remember at Texas Heart, actually it was Methodist, Houston Methodist, a very famous aortic surgeon, right? Used to come by and round in the DeBakey ICU, 103 beds with this cigarette, just flipping it on, everything moving. That was his rounds with the cigarettes in the ICU. So times have changed. This is behavioral economics. How much does a pack of cigarettes cost, right? And this is just culture. And why can't we replicate this for our food and for other behaviors and supersize me and running paths and urban infrastructure? We know the theory. Why are we unable to implement it? And we've written some papers on this. This is probably, we need more legislative acts ultimately. That's another talk.
Good. All right, if any other questions, if with that note, we conclude this fantastic
Great. Thank you.
education. All right, good. Great. Okay, so ready for now two very important topics on the structural heart and the all interventions. So here, the next one is by Annapurna Kini, Annu as the director of the cardiac cath lab, and more important now, the director of AI in the cath lab, which you're hearing a lot of social media and so, and of course the interventional director of the structural program as well as the fellowship, both interventional and structural. She's going to give us update on the top 10 advances in the transcatheter structural heart intervention. Annu, welcome.
Maybe these topics are very interesting. That's why, Dr. Sharma, you always keep them in the afternoon after lunch. Now to make sure everybody is awake and listen to the top advances of the valve. So, we all know very basic 4 valves, and once upon a time, all these 4 valves had to be taken care of by surgery. But guess what? Over the last 15 years, things have changed, and they all can be done percutaneously, means through a small hole in the groin. So we deal with mostly the aortic, which is there, which actually first approved in 2011, subsequently mitral in 2013, and tricuspid as of last year. So we are going to go through all this, some important things. So before we get into what the advances have been, the guidelines have been changing, and what we learned when we were medical students is if you have valve problems, they got to be symptomatic. Some kind of symptoms have to be there. Subsequently, it went from symptomatic to asymptomatic, but severe valvular disease was what they had. From there, we are moving on to moderate to severe, which is called as progressive, with or without symptoms. So that is where we are. So we got to keep this in mind as we are going through this lecture. So the first will be what we have learned in the TAVR, which has been there. Like I said, I think the first trial came out in 2010, and approval happened in 2011. So there have been several trials between 2 valves that you see there. One is a balloon expandable valve on the top, and on the left corner is a self-expanding valve. So all these trials over the last several years, what we have learned, that TAVR is now preferred, safe, and effective option for treating severe AS across the different, I would say, risk. So those risk, which is about when the patients are going for surgery, that's how the risk is calculated. So low risk, what we say, is less than 3. Anything more than 6 and 7, we call it high risk. So then the question comes for physicians and cardiologists like you, then who should be getting surgery? Okay, if most people can get TAVR. So that is what we are going to learn. So the most important question we face is, what is the life expectancy of the patient that you're seeing? So if your life expectancy is more than 20 or less than 10, and then we figure out maybe what we should talk to the patient. So all the guidelines, the center stage right now is a heart team discussion. So heart team discussion includes interventional cardiologist, the cardiologist, or yourself, physician that's making, and more important is a patient. So you can say whatever you want to the patient, but patient makes a final decision. So these are the important factors that we need to take into consideration, which is very, very important, is the age. And that is what even the American guideline says, age 65, age 85. Above 85 favors TAVR, less than 65 favors surgery, because that's also the valve duration and life expectancy. In between is questionable. You can have a 78-year-old robust patient with few other severe coronary artery disease, maybe a candidate for surgery. Then, of course, surgical risk, which we said, frailty, valve morphology. Most of the patients have trileaflet valve, but if they do have bicuspid aortic valve, which also I will go over, then you should consider maybe they favor SAVR. Then, like I said, the femoral access, right? With the access, 90 to 95% is femoral. For some reason, if femoral access is not feasible, and we do use carotid, direct aortic, and couple other, we should not. If that is the case, you should again go back and address this. Is this patient probably better served by surgery? Concomitant other valvular disease. Okay, so you have 3 valve disease, maybe better off going for surgery rather than percutaneous, and coronary artery disease, which we know you have 3 vessel left main complex coronary artery disease. Now we have to take care of coronary artery disease, valve problem. Patient is 70, a good patient, maybe should go for surgery. And then other important factors, rare, but yes, you have aortopathy. Okay, patient has dilated aorta, can have septal hypertrophy, endocarditis, probably not. A young patient, for whatever reason, has a porcelain aorta. okay? Probably better off with the TAVR. So these are all the important factors that we take into consideration, but what is the important message here? Age, so less than 65, more than 80, less than 65 SAVR, more than 80 TAVR, in between heart team discussion, no matter what, heart team discussion is the key. And this is something everybody talks, and you will hear this over and over when you go to various meetings, that you think about the patient, which is the lifetime strategy for the patient with aortic valve disease. And more than 80, we know. You do TAVR, okay? Sometimes they live over 10 years, so now at 90, they're back to us. Maybe we do TAVR. Then you have a younger patient. That is what? The patient is young, not ready to retire, but he does not want 4 to 5 weeks off from his job and says, no, I'm not going for surgery at this time, okay? I want TAVR. So do TAVR. Maybe he lives another 10 years. What should you do now? Do we do a TAVR in TAVR, or do we consider SAVR? So at that time, if he's a good candidate, maybe he can go for SAVR, lives another 10 years. Okay, then we again do another TAVR. So these kind of discussion need to happen with the patient, and patient makes the decision in these kind of cases. Despite all the guidelines and what I have shown you, what happens in the real world. So this is what TAVR versus SAVR guideline, which you see here, over 6,000 patients across here in the United States, what you see. Less than 65 years of age. Half of the patients of the TAVR are less than 65 years of age. And maybe the reason that I'm trying to tell you is the same, that patient decides, I do not want, because I'm not thinking of living another 20, 30 years, just give me the easy procedure and be done with it. So less likely to have bicuspid aortic valve disease, but more important reason is they want easy procedure, go home early, and then definitely probably they might have had a CABG before. This is another thing that's happening with the, pressed button early, that what is happening in the real world, about over 100,000 procedures, and right now we have another valve that has been approved by the FDA. Now going to bicuspid, right? Why bicuspid is so important? So there are various kind of bicuspid, type 0, 1, 2. So it could be a single raphe or double raphe. That's how we call bicuspid. But more important is it just the single raphe, or is it the calcium that is on top of this bicuspid? A simple small registry showed that a simple bicuspid, it is comparable to surgery. Okay, that doesn't mean that you take every bicuspid and say, okay, we can do TAVR. So this is another study based on valve morphology and outcome on bicuspid valve. So if you see that, right, you see the calcium, so mild calcium, single raphe, okay, maybe that patient can do better with TAVR. But if you see the third group, which is calcified raphe plus excess leaflet calcification, that is the worst group, and look at the outcome, all-cause mortality, about almost 25%. So if you see a patient like that, you got to be very clear that your outcome is poor and discuss surgery with that kind of a patient. So that is why when we see bicuspid, again, heart team, and be very cautious, give all the data out to the patient, and then patients can make the decision. So this is a subgroup analysis of one of the trial which compared TAVR versus surgery. So overall, the group did very well, but when they did a subgroup analysis, which was a small number of patients, about 50 patients who had bicuspid, again, why bicuspid don't do well with the TAVR? Because you see the CT scan showing a lot of calcium right around here, okay? So if that's the case, you will have a lot of paravalvular leak. That is one. And two, for whatever reason, there is disabling stroke, because when we are doing the valve and probably a BAV, that calcium probably gets dislodged, and there is CVA higher in this patient. So need to be discussed again with this patient. So if there is paravalvular leak and we think there is a paravalvular leak, should not go for surgery. So this is another, I would say from a registry data, not a randomized trial where they compared SAVR versus TAVR for bicuspid, look at the outcome, which showed that TAVR did poorly in bicuspid. Again, the conclusion was surgery remains better because of lower mortality in patients with bicuspid valve. Then comes what else is there. Like I showed you, if you have severe AS we say if in an echo your gradient of more than 40, which is mean, and can we do something for this patient before they become symptomatic? So the name was early TAVR. So before going there, there have been two randomized trials, which is comparing asymptomatic patients for surgery versus conservative treatment. So if you see there, conservative treatment definitely had higher incidence of all-cause death and other events that they happen in two trials that have recovered as well as AVATAR trial. This was just actually presented in TCT last year and came out in New England Journal early this year. Early TAVR, about 900 patients, close to 900 patients, randomized 1-to-1 of asymptomatic severe AS. And how did they know they're asymptomatic? They made the patient go on the treadmill about 6 minutes or so, no symptoms, no change in blood pressure, and they were randomized to either surveillance versus TAVR. So of course, if you see the overall outcome of death, stroke, unplanned hospitalization, okay, we got to pay attention there. Significantly, you cannot do clinical surveillance. That is what the message from here is. But if you go deeper down, okay, what exactly happened, and this is a little bit of criticism in this trial, that after a month, if you see there, the so-called the patients who were into clinical surveillance start getting not randomized, got TAVR. So if you see there, by about 24 months to 36 months, about 86% already got TAVR. So this was an open label, which means now the patient knows that I did not get the procedure, and severe AS, I think maybe start getting symptoms. That's one. So this was presented in ACC, a sub-analysis again. What exactly happened? Why did those clinical surveillance patients, why did they have to get TAVR? If you see that, what they did was they went deeper down and said what exactly happened when they delayed the AVR. What they call AVR is some kind of a treatment that they got, but majority of them get TAVR and are delayed only by 11 months or so. So if you see that 87% of the so-called patients who were in surveillance went into the aortic valve. So this is the key message for all the cardiologists out there. So if you have somebody asymptomatic, severe aortic stenosis, right? And now you say, I just want to watch because no symptoms. Guess what happens? Delayed AVR with acute valve syndrome. What acute valve syndrome means, there is urgent hospitalization for some kind of a symptom. Most often it is heart failure, about 14.9%. And that is why I think what we have learned from this trial, though we know the crossover was a lot of crossover, that even if they're asymptomatic and severe AS, something has to be done. Do not, keep them, wait and watch. So this is another trial with AVR versus TAVR. And what this says is there some test we can do? What they did was MRI, checked for myocardial fibrosis. When they had myocardial fibrosis, they did poorly when they looked at it. So essentially saying, don't wait for myocardial fibrosis. You have severe AS. We are not saying that everybody should get MRI, but if they have severe AS, send them so that they can be evaluated. Next comes, I did mention about that if these patients are going for TAVR, should they be protected because there's a risk of stroke. So important trial, which was Protect TAVI trial. If you look at the number of patients, over 7,000 patients, okay, half and half randomized. One to CEP's cerebral embolic protection device, okay. So a group got it, a group did not get it. And overall message is there was no difference, which is a disabling stroke versus even minor stroke. So routine use, so this is publication from New England Journal. Routine use of CEP did not decrease the incidence of stroke within 72 hours. So they used to be patients, we used to routinely do it. Now we are doing it only for high-risk patient. High-risk patient is patients have already has a prior stroke, or they are a valve-in-valve because the risk of embolization is higher. Bicuspid, like I showed you, a lot of calcium. So these are the only group of cases that we will now do cerebral embolic protection device. This was a comparison. So protected TAVR was done here in America. BHF Protect TAVI was done in Europe. Combined both, and what did it show? Again, no difference, because the one protected TAVR did show that disabling stroke was slightly lower when you use CEP. But when they combined the data, there was no difference, and that is what it says though. Then is there some treatment for aortic regurgitation? So far we spoke about aortic stenosis. One trial that showed there is a valve that we can do, the valve that we normally do, because patients with aortic regurgitation do not have calcium. So why does the valve, we go there, we dilate it, but the valve stays there. Why does it stay? Because calcium is used to anchor it. So in patients with aortic regurgitation, you can see that there's no calcium, so you need different kind of a valve which anchors into the leaflet or the annulus. So this is one trial said that it is feasible, it is a single arm, and it is doable. So it is. It has been approved, but we are doing it very cautiously. Then question comes, patient has had prior surgery, right, valve surgery, and can they get, when there is a restenosis of this valve or there's progression into aortic stenosis, can this prior surgical valve get a TAVR? So it's called as valve-in-valve. So we have to be, I'm being cautious is there's a valve-in-valve, which is surgical valve, and now there is TAV-in-TAV. Means the patients are over 10 years of the TAVR, because we started in 2011. If they have survived, they're coming back. So they are called TAV-in-TAV. So that is also being done. So if you see here, SAPIEN valve, earlier used to be X3, but now we call them S3. They have been done. It is called as a valve-in-valve registry, and it has been approved that we can use the TAVR valve in prior surgical valve. Other question always comes is asked by the patients, family members, and the referring doctors. Okay, what do we tell the patient? Because if they are seeing a cardiothoracic surgeon, they will say, okay, we have been doing this procedure for over 40 years, and we have a good track record of having the durability of the surgical valve for over 10 years. They usually say 10 to 12 years. So when they ask that the question to us, we are like, okay, we used to say 6 years, 7 years and all that, but now we have a data, the NOTION trial, where they compared SAVR to TAVR, and you can see that both valve degeneration there was no difference. So we can tell the patients, yes, it can last up to 10 years when they come and see you in your office. Moving on to mitral valves, which is what you know is the primary MR and secondary MR. So primary is about, I would say, 1/3 and 2/3, like you see there. And primary MR mostly surgery, is the secondary MR functional, where we know where the clip can work. So what does the guideline say? For primary MR, first and foremost, you have to see what is a surgical risk. Unless they are prohibitive or high risk, they cannot be referred or cannot have what is called as a percutaneous treatment with a clip, which was approved in 2013. In secondary MR, where we see is a dilated LV or dilated atria, for whatever reason they are having this mitral regurgitation. Again, first and foremost is a fantastic 4. You got to make sure they are on good medical therapy, which is not just diuretics is usually for symptoms, but all the other medications they have to be on, and the EF is low. So we were part of the trial which I'm going to show, co-op trial. It was not easy to randomize, because as soon as you start the medication, patients feel better and the MR used to decrease. So you need to have moderate to severe mitral regurgitation on good GDMT. So even the CMS now says that you need a heart failure doctor to see this patient, but many of you who are here are excellent cardiologists. By the time you send the patients to us, they are on good medical therapy, and if that's so, and we still see mitral regurgitation, one test they need to get is a TE, and after that, if we know that these patients are that we can do the clip and they're suitable, then we proceed with the clip. So the trial that I just mentioned, one of them was done, the COAPT first trial that was done here in America, mitral FR was done in USA, but both had two different results. There's important reason for it. So if you see here, the primary endpoint was hospitalization for heart failure, definitely a significant decrease in COAPT, no change in mitral FR. And the secondary and the first, I would say the only important trial that showed a benefit of death, okay, was in the COAPT. That means after you did GDMT, the big difference between mitral FR and COAPT was all comers were enrolled in mitral FR. They got the clip, then they went into GDMT. Compared to COAPT was different. You had to do GDMT and then they got the clip. So that is why we think they did better off. Means we were very selective who got the clip, and we will also show you the reason why. Then they repeated another trial in Europe, which was Reshape, where they used 3+ and 4+ MR. Here, there was no death, no difference in death, but the combined of recurrent heart failure and CV death was better because now they did the trial on medication. With all these 3 trials on board, guidelines have changed now. So if you see here, the biggest difference, the US, if you see the ERO, which more important is LVEDP per ml. Look at the mitral FR, LVEDP per ml, 250, which means it's a very dilated heart, compared to Reshape is in between COAPT. Essentially, we are trying to say is that COAPT was a very strict trial to enroll patients. And I think if you want to take home message is here. What does a COAPT trial show? If you see, it's called as disproportionate mitral regurgitation. The meaning is that you have LVEDP in the bottom. So when your diastolic volume, not EDP, end diastolic volume in the bottom, so it has to be, mitral regurgitation is disproportionate to what the volume is, telling that it is real compared to Reshape and mitral FR. Other meaning, simple meaning is do not wait too long, okay? When you see that there is LV dysfunction and there is moderate to severe mitral regurgitation, you have started them on therapy, but they need to be referred to a tertiary center for evaluation for whether they are a candidate for mitral clip. That is the take-home message from this. Several trials are ongoing right now, okay, from low STS score. Look at the age of the patient, 65 years, and what are they comparing? Okay, they're comparing clip to surgical procedures. So in the next couple of years, we should have some results with that. Then comes, okay, we can do the clip. Can we place a valve in the mitral area? Is it possible? If you see there, guideline says it is doable, but look at the number of valves. The fact that you have several valves, what is it trying to tell us? That we don't know what we are doing. Each shape is different, everything is different. The reason for that is, these are the various other procedure that they're doing is, if you see the mitral valve, it is very complex, not as simple as aortic valve. You know, aortic valve tubular, you have 3 leaflets, calcium, we go there, we place the valve, we come out. But mitral valve is not that easy. What the biggest challenge we face that when you place a valve in the mitral area, it causes what is called as a neo-LVOT. It creates a new outflow tract, and that outflow tract can now create gradient into the aortic valve. So that is why you see there are various shapes. We have tried various different shapes. None of them is functional. Other thing is, how are we going to get this bulky valve into the mitral area? Okay. We started with a transapical, which means you need a surgeon to give us an access. Like we said, when it is becoming cumbersome and too complicated, we interventionalists do not want to get into that area. So now we're trying to do transeptal, but still have not figured out what shape and what size we can get there. So there is a one feasibility trial which has shown that yes, you can do it transeptal procedure. And other one that we just mentioned was that if patient already has a mitral valve surgery done in the past, can we use the so-called aortic valve in the mitral position? And yes, that can be done, and that is only done with the balloon expandable valve, which is the SAPIEN valve, and that also has been currently approved, and we do that procedure. Moving on to tricuspid, which is again like the clip for mitral. Can we get a clip for tricuspid? So what is interesting of a tricuspid? So if you see here, as people age, if you at the age of 75, you combine AS, AR, MS, MR, okay? Together it is one, but TR is prevalence is very high. And it used to be, say, called as a forgotten valve, untreated valve, because when we actually used to see the patient, I'm saying like 10 years ago, severe TR, what can you do? Nothing, just give Lasix, and that's what we used to do. But more important also, you see that is the surgical options. People don't like to treat, don't like to take them for surgery. Outcomes are very poor. The mortality is 8 to 10%, which we will show. So very few patients get treated. The question is, can something be done to them? So again, going back, common cause for TR is secondary, because there is something happening on the left side of the heart, pulmonary hypertension, and you have TR. So often we take care of the left side of the heart, whether it is mitral or aortic, and we hope TR gets better. Primary is very rare, and that's what you see. Again, tricuspid anatomy is very complex. Why is it complex? The atrioventricular node is right there, okay? And you have 3 leaflets. Mitral was way easy, 2 leaflets. Anterior, posterior, clip 1, 2 would be easier. This is not that easy, number 1. Number 2, the imaging of tricuspid also is very hard. You need imaging, so the imaging can be done by either TE, or sometimes we use a small catheter through the groin and do it. But either way, but why we need to know this AV nodal? Because the need for pacemaker is very high, and that is what the even the trials have shown that. So the guidelines are saying that if you have TR, especially when you are doing left-sided surgery, take care of it. TR with symptoms, surgery. So every time there is surgery, surgery, and surgery. That is what it is happening. But if there is a TR and, same, if they have a high risk, if they have symptoms on treatment. Now the treatment is what? Most often these patients do have LV dysfunction. They have other concomitant disease. So they got to go on the GDMT for the left-sided. So you do that, give Lasix, still have symptoms, then clip can be done. So if you see here, again, surgical treatment are several. Transcatheter also. Several have been tried, but what have only made to the market is the clip, exactly what the clip that we showed for the mitral, but they've created slightly different for tricuspid area. And the other one that got approved was the valve, which is called the EVOQUE. We will show it. And this is why I think it's important that percutaneous treatment is better, because look at the surgical mortality, almost 8.89% or so. So we were part of this trial called TriLuminate, where the first that was presented in 2023 was a small group of 350 patients, 1-to-1 randomization of medical therapy versus TriClip. So if you see there, device group and control group. So in the device group, significant reduction of the TR, but when they did the paired analysis and at follow-up at 30 days is same thing. The device group, it was only mild or trace MR, which is the green, okay? So they remained that way. So they did do fancy analysis, we call it, which is the win ratio, which is a combination of multiple outcomes. And that was positive. But the only thing in this trial, because most often what do you think? For recurrent heart failure admission, that was not different. What was different was the KCCQ, which is you usually ask the patient the questionnaire, are you feeling better? That was the only different. And this actually, the full cohort was presented by Gilbert Tang and came out in the trial that 2 years follow-up, what did it show? Decreased rate of heart failure. So it's probably taking a longer time to show the benefit. Now it is showing at 2 years there is a decreased rate of heart failure admissions to the hospital. Then we are going to the valve replacement, which was again, which is the TRISCEND trial. That is what we are going to present. Now, why this is important? Because when you see these patients in the office, most often these patients who come with tricuspid regurgitation, look at that, 90% of them already have atrial fibrillation. Majority of them already have a pacemaker. So could this tricuspid regurgitation be related because of the pacemaker wire? So that is what happens with that. Like I showed you, the anatomy wise, about 17% of the patients required new pacemaker after doing the valve in the tricuspid area. That is what it is. And the most important is that majority of this patient had to go home on anticoagulation. If they were AFib, they're already on anticoagulation, they'll continue anticoagulation. Suppose that 5% of the patients who were not on anticoagulation need to be on anticoagulation at least for a couple of months just because it is a low pressure side which is on the right side. That's important. This is what I was talking about, the win ratio. That is, it's a complicated statistics, and this is now being used in many of the trials because they include too many variables all the way down, which is also included 6-minute distance test. So what did it show? That patients, they did better, but more important was just functional than what they found was the quality of life. So not hardened, okay? Hardened point did not change. So TTVR was superior to medical therapy alone, improvement in symptoms and quality of life. So maybe we have to wait a little longer to see if they really had any difference. Now the question, often you will ask me, before I get the question there, who should get a TR or TTVR? So that is all based on echo. What is the leaflet gap, coaptation, the size, the length, the size of the RV, and the one thing about TTVR, if we think they are not clip patient and we think that they are going to get a valve, they need to get a CT scan. So we understand that this valve, we are able to navigate into the RV, and same that RV, it may not be challenging. Suppose they have a pacemaker lead, we may want it extracted, but otherwise we will exclude it. In that situation, we need an EP doctor with us to do immediate pacemaker at that time if they need it. Otherwise, the need for the pacemaker, which we showed you, also is very high. Several other trials are ongoing for that reason. Next one is, if they have concomitant coronary artery disease, what will you do? Okay, so this is very important. That one trial which showed you saw patients with aortic stenosis and now they have disease. So if you do 50 to 90% lesion, they had FFR guided. FFR is you check the pressure gradient across the lesion, and then had TAVR versus they went for aortic valve replacement and bypass surgery. Guess what? The people actually did better when they got FFR with TAVI. There was another subgroup analysis of a Notion 3 trial, which was completely FFR guided PCI versus conservative management, right? And of course, patients who got FFR guided PCI during TAVR did better. So if you see that, what did they do overall, which is MACE, and the next one was MI and urgent revascularization. I think we always win for urgent revascularization, that if you have taken care of a lesion, they do not come back with the symptoms. The study that is ongoing, which will probably are part of this study, is a complete TAVR study where patients have CAD, they undergo TAVR, then they go to get randomized to either getting PCI after TAVR or we do medical therapy on these patients. And this is, it's not that easy to do coronary artery intervention after having TAVR. That is why we have an app which tells us how to engage and do the PCI. Then the final is what are the new guidelines that we have in management of valvular heart disease that just came out from ESC. So like I mentioned earlier, and we are going again back to the same thing, the center stage is what? That you have to have a heart team discussion. That's what everybody talks about. That is a heart team discussion, and patient is the one that finally making the decision, and then you need to patient-centered evaluation for the treatment. And in the initial assessment, what you need to do is make sure you have the complete multimodality imaging that is included. So we went through this. So TAVR is class 1 for patients in America more than 65 years of age, and decision guided by detailed anatomic and clinical factors, which we have gone through with lifetime strategy formalized. Okay, so it has to be discussed with the patient, the lifetime management, which we went over. What is the lifetime management? For mitral regurgitation, they have made it class 1. We, in the United States, we are still not class 1, recommended for suitable, okay, that is secondary mitral regurgitation, whether it is atrial, ventricular. But ventricular is what they're talking about, that now they've divided it. In the past, we never had it. They've divided atrial versus ventricle, but let's concentrate only on ventricular, that you got to be on GDMT. And if you are on GDMT, that means you have to start on medication, still as mitral regurgitation. That becomes class 1 for us now. And if you have mitral valve disease and concomitant CAD, consider mitral valve surgery. That's the only thing. And a patient with aortic regurgitation, like we have said, it becomes class 2B, and TR now finally has got into that transcatheter therapy is finally making into the guidelines in there. So when patients are coming with for aortic stenosis evaluation, one thing we do say is we need to rule out coronary artery disease. So CCTA is now made into the guidelines as a class 1. If not, we still go with the invasive angiography, because what happens is they already need a CT for analysis of their valve. That CT versus coronary CTA is a different acquisition. So we cannot make them go through 2 CTAs. Instead, then if the CTA is positive, now they come back for angiography again. So what we do is just go for invasive coronary angiography, and look at what the guidelines are saying is class 2A. That if you have more than 90% coronary artery disease, class 2A to consider PCI before TAVR. And this is a very, very important topic, and I know I will have questions on this. After procedure, what do you do with this patient? Do we give only aspirin or aspirin with clopidogrel? So there are trials. This is popular TAVI cohort A, and if you see that, if you give both medication, we all know the bleeding risk is very high, but what happens to the ischemic risk? There was no difference. What it's trying to tell us is that you don't need 2 medications, okay? So what we used to do and what we will do. Currently, you will see when the report comes, patients are getting aspirin, and we say give clopidogrel for 3 months if they don't have coronary artery disease. If they have coronary artery disease, they got a stent, of course they'll be on Plavix for a longer, maybe 6 months up to a year. Now the future, and you see the guidelines, we will show you that it's telling us only aspirin is good enough. And routine use of anticoagulation is not indicated, because there was a trial called Galileo which had to be stopped early because of the same bleeding risk. Then going to cohort B, the question comes, patient is on anticoagulation for whatever reason. Should we continue that, or do we add on top of that clopidogrel after aortic valve replacement? So same, you have anticoagulation for whatever reason, and now you add clopidogrel, bleeding risk is very high. So ischemic risk, no difference, slight difference. So what do we then say? You don't need to add another agent. That's why the current, that is, if you are on any kind of AC, which is a warfarin or any of those Novak, Dovax, you continue that. You don't need to add, okay, aspirin or clopidogrel. That is what the guidelines are saying. And clopidogrel is only needed, okay, if patient has CAD and intervention of the CAD with that patient got a stent, and that also from 6 to 12 months. So guidelines has included that. You see that if you have TAVR, all you need is aspirin, okay, for 12 months. And for some reason, if the patient is on oral anticoagulation, you just need to continue that. You do not need to add any of the antiplatelet agents. Now going to after any kind of tear, like I said, if you have a mitral clip, it is up to, we do give Plavix for 3 months, aspirin Plavix, but there's no study to say so, but it's just a consensus statement. And TAVI we just mentioned, and for after, I would say tricuspid clip, they would definitely need anticoagulation. 90% of them are already on anticoagulation. We will continue. If they are not, 3 to 6 months, they will need anticoagulation with that. So what are the take-home message? TAVR is now preferred, safe, effective treatment for severe AS across all surgical risk group with expanding use in younger, lower risk, selected bicuspid patient. Very important, selected bicuspid patient. And MTR, both for degenerated and functional MR, but what you can see is that in functional MR, the surgical treatment ongoing, but in functional MR, very important is they have to be in GDMT, then we do it. So what TER and TTVR is less invasive for a tricuspid, effective options for severe TR, improving symptoms and quality of life. So depending on the anatomy, we will decide whether the patient will get a clip versus the valve. Antithrombotic therapy, we went through very well. And I think guidelines are there, and our job is that guidelines are there to guide us. And more important is when the patients are referred, heart team discussion, multimodality imaging, and then we do what is right for the patient. Thank you for your attention.
Fantastic. Very detailed description of various advances. So there are a few questions, starting with, what strategies or optimization could reduce pacemaker implantation rates after TTVR, and have CT analysis identify related factors?
Yeah, so very, very interesting point. When we are doing TAVR, which I did not, because I don't think you'll have a whole day session of just structural. For TAVR cases, also there's a risk of pacemaker, used to be very, around 10%. We are now down to 6-7%. So there's a technique, okay? You look at the EKG, whether they have right bundle, left bundle, or incomplete. That will tell us the need of whether they'll require pacemaker or no. If there's a lot of calcium, we try, like you see here, the bundle of his and your, those pathways are very close to where we are placing the aortic valve. So we try to place the valve higher than what we need to do. So we will be very cautious when we are placing the valve. We need to pace the patient so blood pressure becomes low. We take a lot of precautions. But when we are doing tricuspid, as much as we want, it is not that easy, because the procedure itself is imaging guided, and the way the valve is placed, there's very little precautions we can take to decrease the need for pacemaker in tricuspid.
And majority of them already have a pacemaker of the tricuspid when we are
About
working
40%, yeah.
and then high incidence. So nothing has been done for the tricuspid point of view. Then would you recommend TAVR in asymptomatic low flow, low gradient patient as well, or only in asymptomatic high gradient AS?
Those trials were for a high gradient patient, because low flow, low gradient is another different symposium, I would say. Various, it all goes how you elicit the symptoms, and how the LV is, the output is. So all this, so far we have data, is mostly for high gradient patients.
Yeah, so all it required that the velocity was more than 4 meter per square to be enrolled both in the surgical trials as well as the TAVR trial of the asymptomatic aortic stenosis. Then the last question is, what about use of SGLT2 inhibitors and other agents for preventing progression of aortic stenosis?
I mean, based on the mechanism of action, I don't think that they can prevent aortic stenosis, progression of aortic stenosis. We know how this is, take out rheumatic. If it is just based on the age and how the wear and tear happens, it's mostly calcified, right? So statins have been tried with no difference, though, I do recommend patients to be on statin thinking it may help, but no study itself, but I think there are trials that are being there for this, try these medications.
Okay. Then last question here is, how much calcium does a patient need so that the TAVR can be safely performed without the risk that it displaces? Is there a cutoff of the calcium score?
Not really, but the grading of severe is based on the amount of calcium that is there. So 1200 to 1500, so that's a cutoff rate. But we have, as long as the valve, many times we see calcium and you give a number of 100, 200, that's the number we get when they go giving a CT scan. But the valve is thickened, okay? And very rarely you have thick valves, very little calcium, and that is doable. But it is not the same when it is aortic regurgitation, because most often the valves are not thickened and regurgitation mechanism is totally different. That is why you need a special kind of a valve when you are taking care of aortic regurgitation.
And actually the last question is very much focused on you. Are we using data for machine learning algorithm in this structural space? If yes, how is it impacting?
Yeah, so we actually did it. We presented it in Euro PCR last year. That how do you do? Nobody asked me that question. How do you select the valve? Who should get a balloon expandable and who should get a self-expanding valve? So right now, like we talk about, that subject was never touched, is experience of the operator, experience of the physician, and then we say this is probably the right thing. There are certain guidelines. So we actually put all the data we had, depending on the valve selection, and we came up with a model saying that the valve selection can be done. So right now, I know during the talk, nothing was discussed on can we use machine learning and any of these artificial intelligence models for clinical outcomes. Not yet, okay? Because the way we have to do is you have to first train those model to know what the physician knows. Okay, they got to come to our level. Once that is done, maybe then we can use that model to say, can they be better than the physicians? So it's a long way to go, but I think just like it was discussed, Dr. Mehran mentioned, ACC is all over it. And we in Mount Sinai, myself have a lot of interest in this. We have a lot of innovation, our own research lab that we are using these machine learning models. So more to come. Maybe next year we will tell you a few other things.
And actually there's another very interesting provocative question that once the Lp(a) therapies are approved, will the aortic stenosis will be eliminated?
We need a crystal ball in front of us.
The statin didn't work?
Lp(a), let us work on coronary artery disease first before we go to aortic stenosis.
Yeah, so SGL2 receptors did show that post-TAVR, after you started it did help. Recent paper just came out that decreased overall event rate, post-TAVR events were decreased, just like diabetic patient, post-MI patient, same thing in the TAVR group also. But whether pre will do, I am not aware of any
trials
starting pre, reducing any changes. If anyone other expert here, Roxana, Deepak or so.
Huh?
Yeah. In the pre.
Lp(a) trials for pre-TAVR.
I don't think we're gonna cure aortic stenosis with just Lp(a).
Maybe the CAD.
That's
Maybe
what I meant. Let's focus on Lp(a) and
maybe
CAD.
we can cure control the CAD. All right, with that note, fantastic. We are about half hour late. We will ask him, but I think we'll be good. Okay, get ready. And those who have shown that tolerance, as you see, things just came. One of you will go home with the nice, what is that? iPad, which will be taken up.
The final slide was our symposium. We forgot.
Which symposium now? Gone.
Huh?
Yeah. Yeah, we have the valve symposium.
Yeah. One
Okay.
second, guys. Can
All
you
right.
go back to my slides? I mean, many people here would love to attend that.
They have it outside, right? They have this, outside they have it. The valve symposium.
No, they have?
Everybody come to the valve symposium.
No. Oh, yeah. Go back and show the last slide. Oh, yes. Oh, yeah. Right there.
It's a very special day
Yeah,
that day.
yeah. Very special day. Kiski made sure everybody knows.
Not forget December 11th, and October 17th.
Happy birthday to Dr. Mehran today. I don't know how it happened. Today is her birthday, December 11th is my birthday. So that is why I make sure everybody comes.
Okay. All right, so let's go through now. Another will be very, I would say, heavily data-driven talk for next 30 minutes. I don't know why they wrote down 20. I know we are late, but we still have to go through the message. But it does not matter. As you know, my last slide will put everything together. What you need to take home in terms of what we have learned in this. Now let's see. Okay. Oh, so it only can move by this, right? Okay. So just to say, I always start my presentation paying the tribute or thanks to the guy who made it happen, Anders Grundtvig, who did the father of angioplasty, the first one done in 9/16/77, just with a balloon angioplasty. A dream was catheter-based percutaneous treatment of vascular disease in alert and awake patient. And this is where our live symposium started. That he used to, then came to Atlanta, initially went to San Francisco, then went to Atlanta, where he used to bring all the interventionists in our auditorium situation, set up, doing the PCI, everybody watching it. So C1. Then give all the equipment because companies were very limited. So how to make the device, we had to a balloon catheter, the wire, the guide catheter, go back and do one, and then teach one. So C1, do one, teach one started with Anders Grundtvig. And how things have happened, and I'm sure up in the heaven, he's sitting, must be seeing it, that how safe it is. His third case was a trouble. Went for open heart surgery, and after fifth case, he was let go from his place because complications started happening with the balloon angioplasty. The key is now it's safe. Like our complication, less than 1%, 30-day event, and less than 5% at 1 year. Second, appropriate, we want to do that it's going to benefit patient. We have the guidelines called appropriate use criteria, AUC, guidelines of the ACC&C DR, and that basically tells you that you do where it makes sense, not just by doing that there is a blockage, you take care. So that's why we go to a lot of physiological testing, imaging testings, and so. And then lastly, ambulatory. As you know, the 60% are same-day discharge, 95% discharge next day. So it really has gone a long way from there. And that has happened because of the lot of advances, and of the advances of 2025 we are going to talk right now. The first one is mechanical circulatory support in cardiogenic shock trials. So there are few trials which have been the balloon pump, Impella, or CardioHealth, which is ECMO. So these are the three devices have been tried in various settings. The last one, which is the ECLS shock, that is the ECMO, and 30-day, and then they have the 1 year data showing no benefit of using ECMO in cardiogenic shock. So we say many of the maybe patient will go home early and recovery will be different. None. So totally no benefit of ECMO in cardiogenic shock. Then we have a trial which took a long time to complete, danger shock, both done in the Denmark and Germany. About 360 patients use Impella, which is called microaxial flow pump, versus standard of care, and followed these patients, and basically finally we found a real device which decreased the mortality by 13%, 58 to 45.8 in these patients, and benefit started very early, as you can see from that graph. Despite that there were some issues with the device, and those were that higher vascular complication. You can imagine that if your vascular complications goes down, maybe the difference would be even better, will be more. The device at present, Impala is 14 French. We are at present investigating 3 new Impala type devices which are 9 French. And there this limb ischemia, bleeding all will decrease. So benefit could be even bigger in the oncoming, they will be available by end of next year. Then now we have the 10-year follow-up of the danger shock trial, because right from the beginning, it still remain about 16% benefit, and it was in the all group. So just to say that yes, Impala finally won in the cardiogenic shock. Then the shock caused by the heart failure. This is a balloon pump versus standard of therapy in cardiogenic shock by the heart failure, called L shock trial, and basically showed again no benefit of balloon pump. So negative ECMO, negative balloon pump, plus Impala, and you can see that more bleeding and other event rate with the balloon pump and so. So that led to the guidelines that microaxial intravascular flow pump is still 2A in patient with STEMI and refractory or cardiogenic shock. It hasn't made it to 1 yet, but I'm sure with updated guidelines it will make, because this was still earlier guidelines than this danger shock trial. And what also has shown is the class 3 is the balloon pump or ECMO in patients with cardiogenic shock, because it has not shown to be any beneficial. Second point, the immediate versus stage complete revascularization MI trial. Remember, it has been shown that full revascularization in multivessel STEMI is better. Then question was, then their trial showed that whether you do the stage in hospital or outside, at the same time, or you do it in the stage intervention. There were 2 trials were done, and they actually got to the guidelines also. BioVasc showed that immediate complete revascularization was better than stage. Why? Because while patients were waiting, developing unplanned revascularization or MI. 2 trials, and the second trial was the same, multi-stars, again showing the same, that while waiting in the stage group was harmful. Although there was a complete MI trial, did not show much difference in that, but other 2 trials showed. So therefore, now the question was, stage is better, the full revascularization better. Then question is, what if you do it in stage versus you immediately do all of the vessel? At time 0, patient comes in, STEMI, not a cardiogenic shock, maybe a little heart failure, okay, but if patient comes in, not a shock patient, multivessel disease, do you right on day 1 or you do it in day 3? Stage in hospital revascularization for multivessel, this was a trial done to answer this question, and of course you can see that imaging was done in about 1/4 of patients, the one immediate group versus second group. There were minor differences, but not much, but most important message is here that immediate revascularization versus delayed stage revascularization, but same hospital admission was not different in overall, except in some subgroup. And what the subgroup was, that patient was in heart failure, elderly patients, and even also multivessel disease. You see that curve more on the right side. So key is patient with heart failure, elderly patient, multivessel disease, don't do all the vessels same time. That is troublesome. So I think this trial, in my opinion, has not changed what we have been doing at present. We always have been doing that, do the culprit vessel, and unless it's a second vessel is looks like 90%, 95% subtotal, very ulcerated lesion, we wait. And then do it after a few weeks. That actually has been the overall practice, and I don't think it's going to change even based on this trial, because the patient with heart failure or other is better to wait anyway. Then the drug-coated balloon. This is a field which has been evolving in last few years in America, while this has been kind of old news for outside USA, because we just got the DCB approved, drug-coated balloon, and many trials, and basically DCB can be used for 2 purposes. One is for the ISR or for the de novo vessel, and ISR basically we already have a stent. So now you prefer not to put another stent, and all the drugs which we used to use for the drug-eluting stent are put on the balloon. The advantage of the DCB is very simple, short depth. Patients who are bleeding risk, you don't want to put a second stent, is the right one. and of course decrease inflammation, less side branch closure, and let's see where we are. What led to the approval of the first drug-coated balloon in America was the Agent DCB of Boston Scientific, and it was single stent was 56.7%, multiple stents was 43%. So majority were kind of half and half, you can say, and they compared against balloon angioplasty. The DCB compared against balloon angioplasty for in-stent restenosis. And what did they find? Clearly the benefit, lower TLR, lower target vessel MI, although technical success was identical, individual endpoints were better in the Agent DCB compared to balloon angioplasty, and there was no stent thrombosis because there was no stent. So it looks great. The only problem is that what we do usually when you have the DCB, when DES restenosis, guidelines say DES is a class 1. Is recommended over drug-coated balloon for treatment of ISR. Right now, there are few other trials ongoing. One of them will be presented end of this month in the TCT, solution ISR, which is the sirolimus randomized against the DCB against the second comparator group where 80% was the DES and 20% was balloon angioplasty. So we'll see that will be a true trial that comparing against the DES, which is what the guidelines are. So we still continue to do a majority of the cases when your ISR of the stent, put a second stent. In some selective cases, we do a drug-coated balloon. One of the limitation also is the reimbursement of the DCB, which is cost is about $5,500, very selected group. It has to be like outpatient, Medicare, some Aetna, they reimburses, otherwise institution loses money on them. Then second question came, what about in the native vessel? Not in the ISR, native vessel using the drug-coated balloon. This is a trial from China using a paclitaxel-coated drug-coated balloon versus Firebird, their sirolimus drug-eluting stent in a simple cases. And what they found, now all of a sudden you see the DES is better than the DCB in the native vessel. In the ISR, DCB better against balloon angioplasty. Now you are doing a native vessel, comparing DCB with the DES, and clearly seems to be that there is an advantage of the re-DES rather than DCB. Now, say, what happened in individuals? So we found that in the small vessel, both DCB and DES were identical, but large vessel, real advantage of the DES over DCB. So clearly that small vessel, maybe you can think about putting the DCB in cases where issue about the antiplatelet therapy, but large vessel clearly should be the re-DES. Then issue is the bifurcation trial. You know, patient have bifurcation lesion. We used to put 2 stents. There is some issue about in those cases. Some do bad, some don't do that well. So question is, what if you put a drug-coated balloon on the side branch? Again, the trial was done with a DCB bifurcation trial where they compare side branch not with a stent, just with a balloon angioplasty. So what they found basically, again, the advantage was there. The DCB group did better compared to the non-compliant balloon, but it was not compared against the DES in the native vessel. But still you can make it a point that side branch doesn't have to be that every case you need to put a second stent. The bifurcation lesion side branch drug-coated balloon could be okay. So this is what we do now. Actually, we kind of started doing now because of it's still limited because of the reimbursement pattern. But many people do that. If your concept is go away from the DES for some reason, it's reasonable that you having a DCB strategy. But DCB strategy has to be that your lesion has opened nicely by a technique, and your DCB are just putting it as a last stage, kind of coat the lesion with a drug. But lesion has opened nicely. So therefore, you have a lesion preparation with a pre-dilatation, rotational atherectomy, whatever need to be done, and your angiographic results are good. If you want to imaging or physiology, looks good, then it's okay to do the drug-coated balloon. And if not good, then you put a DES. So basically what we are trying to say is the DCB alone is good enough in some cases compared to DES, and particularly cases where we worry about very long lesion, side branch, or patients who have bleeding issue. And what basically are the indication, where would you use DCB, DES ISR, a small vessel, side branch, and then high bleeding risk patient where the depth interruption is needed. And we actually have a nice review article in JAMA Cardiology about the DCB because that's at present the DCB use globally varies. In America, it's less than 1%. In UK, it's 32% of the PCI at present are being done with a DCB. So things are changing. Probably will happen in USA. This number will go up over time when we have more drugs will be available. By next year end, we expect at least 3 other DCB preparation will be available, and then the cost will go down. One of the limitation has been now is the cost of the device. Then the next advance is the imaging. So this is actually have been one of the top 10 in last many years, because what has happened is we were trained and we did until, let's say, almost last 10 years, 10, 12 years ago, based on the angiogram, we decided what the lesion was, we treated it, put the stent, be happy, everything fine. Then the whole concept, what if you do additional imaging in the vessel by using the OCT, IVUS, NIRS, to really see whether you have done the good job or completed or optimized it. And that actually had led to the multiple trials of imaging, or called intracoronary imaging or intravascular imaging, IVI or ICI, in every aspect of the vessels have been done, numerous trials, and all have shown consistently benefit of imaging over just angiography. Now, I just take one, the test example of the trial called OCUPy, done from Korea, and basically OCT guided cases, complex lesion, bifurcation, long lesion, and compared to angio guided, and the followed patient for 12 months, and what they found, they have clear-cut criteria that OCT you have optimized the stent, and they have to go through all optimization, and found basically that OCT guided group decreased the event by 30 to 50% in various aspects as shown here. So clearly OCT guidance was better, was again representation of what has been shown in multiple trials before, and then there was also done with the DCB. The article about the meta-analysis by Greg Stone in Lancet, which put all the trials together until earlier last year in each aspect of our PCI. Target lesion failure with the death, MI and TLR, stent thrombosis, and all individual endpoint on the right side, there is a reduction in event rate anywhere from 20 to 50%. The imaging trial have shown 50% reduction in thrombosis, and of course other endpoints as shown here. So yes, now the question is, should you be doing imaging in every case? Well, that actually we get little help from the guidelines, although in United States, imaging is still done only 22% of cases. At Sinai, we started becoming about 33. And basically, benefit, in my opinion, is mostly in the post, really optimization of the lesion. And the guidelines now support complex bifurcation, left main lesions. Imaging is class 1 indication, not routinely, but imaging. So that could make your 30, 40% of cases, and we are about there now. So both acute coronary syndrome, otherwise complex cases benefit. So this is, now we started the separate intravascular imaging live, which is the first Friday of every other month, because a lot of interest, and I know with the Huda and of course Kiski, our imaging specialist, and Nitin Barman is the moderator for those. And then, just like we take the risk score, there is a bifurcation risk score came from here by our own database, that 1,800 patients they analyzed with the bifurcation and come up with the score, low, medium, and high score, correlating with, based on the various risk factor of the clinical as well as the angiographic risk factor for these patients, and predicting that who will have event-rated follow-up. Then the plaque modification and imaging combined. Modification means that usually what we do a balloon, open the blockage, put a stent. But if you do atherectomy, you do a laser, so all those we call plaque modification or shock wave. So key is, the multiple trials have been done comparing OCT, IVUS, and angio guidance in the calcific lesion. As you can see here, OCT, again, little better, lower restenosis, less late loss in the target 3C trial. And then another trial which compare rotational atherectomy, IVL, or laser in calcific lesions. And you can see the second device, many times you need a second device, but overall the trial showed that the laser was not good compared to rotational atherectomy or IVL. IVL and rotational atherectomy were identical. So seems to be in a calcific lesion, the great advantage of rotational atherectomy and IVL to change it. IVL actually have a very low complication, and although the fracture also we caused a little more with the IVL, but laser overall did not show benefit, so calcific lesion, they don't do well. Again, another calcific trial using the OCT showed that by using OCT, you get a better minimum stent area, better stent expansion compared to angiographic alone in this calcific lesion without increasing any complications. Then we have another trial comparing IVL against rotational atherectomy, and basically just to show that there was no difference. So key is consistently in calcific lesions, RA, rotational atherectomy, and IVL are equal, except not every case you can get IVL because bulky rotational atherectomy sometimes is needed before putting the IVL in these cases. Now, what about the rotational atherectomy in ISR? Remember, just like drug-coated balloon. And trial showed actually even harmful, no benefit of the routine rotational atherectomy in ISR patient with this trial. Then there is another device called orbital atherectomy. The rotational atherectomy has a diamond at the tip, and here is entire, there is a special crown, also has the diamond chips, eccentric crown called orbital atherectomy. And this was an Eclipse trial about 2,000 patients comparing orbital atherectomy compared to high pressure balloon dilatation. Conventional angioplasty, some cases were done with a cutting balloon also, basically showed no difference in terms of outcome, in terms of stent expansion, rather slightly higher complication of slow flow and perforation. Except that if you did imaging, then the orbital atherectomy did better compared to balloon angioplasty. Patients who had imaging were done in about 65% of cases, and 70% was OCT, 30% was IVUS. So overall, say again, in calcific lesion, another orbital atherectomy did not work. Laser did not work. RA and IVL both are good. Then next is the depth de-escalation. So there were 5 trials were presented in European Society last month, actually 2 months now, about de-escalation, because we know that stents are so good nowadays. Many times you can stop the therapy within a month, depth, make it single. So many trials have done to identify, and the old trials, I'm just going to show the latest one, which were presented, 4 trials in the European Society of Cardiology. First one was the target first trial. What if patients who are MI but low ischemic risk, the simple, straightforward, don't have a complexity, what if you stop their antiplatelet therapy, make it monotherapy after 1 month in MI and PCI, take away the aspirin, make it a monotherapy, single antiplatelet therapy with the P2Y12 inhibitor, aspirin only, not stopping the clopidogrel it was actually P2Y12, majority of them either were ticagrelor or pressagol, but stop the aspirin after 1 month. And what did they find? By stopping, you see the ticagrelor was 73%, pressagol was 22%, small clopidogrel and special stent, and found that stopping it in terms of which is the net adverse cardiac event, was identical. Ischemic difference were no there. More importantly, you had lower bleeding by this. So taking the aspirin in a low risk MI was beneficial rather than continuing. So see how things have come. In one point, very essential, you take a DAPT, had to be strict. Now, you take away aspirin, after 1 month, nothing happened, was okay. Then there was the second trial called Neo Mindset trial. What they did is that what if you now, same type of trial earlier, take the aspirin out, but now these are the all acute coronary syndrome patient, not low risk, all of them. So we wanted to, have been some data earlier showing that acute coronary syndrome, you stop aspirin, may be bad. So this is same thing happened, monotherapy, take the aspirin out, compared to continue DAPT in large number of patients, 3,400, and you see that half were, 61% were STEMI, 31% were non-STEMI and then unstable angina, rest show here. And what did they find basically? That by taking away the aspirin, which is the monotherapy in blue, compared to DAPT in red, you start having a little trouble. So trouble basically means the event rate. First thing you had to do in all these trials, you need to understand, ischemic endpoint cannot increase. And most of the trials, ischemic endpoint were similar, and the bleeding difference happens. So this here is a little different. As you can see here, that now ischemic endpoint, 7% in the monotherapy, 5.5% in the your DAPT therapy. So all cases, low risk, high risk was a trouble, and this is actually death, MI, stroke, and you see the event rate. And the bleeding, yes, bleeding was lower with the monotherapy, that clearly was, but they were at a risk of slightly higher incidence of the MACE endpoint. MI rate, 2.7 versus 1.9, it's a little higher, and so. So then third trial, and I'll put them all together, third trial was that what if the tailored chip trial design, what does that mean? So we say that conventional, continued clopidogrel aspirin, patient with a complex high-risk PCI, but now we want to change. And change basically is that change to low dose after the PCI, that you change to low dose ticagrelor plus aspirin, 0 to 6 months, and after 6 months, give clopidogrel alone. So they have a very complex design of the trial. The 60 milligram, because these were done in Korea. Korea actually, they have done pharmacology studies before that 60 milligram is good enough. You don't need to give 90 milligram of ticagrelor. And they have shown that from their earlier small trials. And here basically was that what if you tailor that's aggressive in the beginning, then de-escalate after 6 months, and so the little complex design, but trying to see what could be the better combination, and found it that your tailored antiplatelet therapy didn't help much compared to the DAPT. As you can see here again, height of the red bar, so no additional advantage came, and rather it caused more bleeding. One, no benefit of ischemic endpoint, and caused more bleeding. So what good it is? So again, this trial failed. Then there's another trial, was in the dual ACS trial, that should shorter duration of therapy be used after MI in Sweden. It was not 1 month, 3 months. And remember the Twilight trial done by Roxana Mehran was 3 months, 3 months of aspirin and ticagrelor. And after 3 months, aspirin was dropped in one group, another one, both were continued. So 3 months, not 1 month, and 3 months, this was 3 months versus 12 months DAPT. And you can see all ACS patients, 23% on medical therapy, 71% PCI, small number had cabbage, and the trial was terminated because of COVID impact and low recruitment, but basically showed that overall from the cardiovascular death MI and point of view was no difference, and of course the bleeding was slightly lower, p-value of 0.097. So key is a plus minus trial, but all showing that 3 months was okay, not a clear-cut benefit, but trended towards benefit overall in the short duration. So mixed message, and I'll try to put it together a little later. Then the colchicine acute MI. Remember last few years, we have done many trials of the colchicine, and all showing that colchicine is good. Colcott, Lodoco, then meta-analysis became the class 2A recommendation for European society that every aspect colchicine was good. Then another major trial was done called Clear Synergy. Basically patients, it was 2x2 factorial design trial of the colchicine spironolactone. The patient with the STEMI getting PCI and starting colchicine 0.5 milligram daily, and of course within 72 hours. And of course, they got a spironolactone versus placebo, so 2x2. Our interest is only with the colchicine group. I know spironolactone group did not have any difference. So 2 aspects. Colchicine is anti-inflammatory, which has been shown that it causes lower CRP. Answer is yes. Colchicine decrease the inflammation, what it's supposed to do. Second, did it change the outcomes? Now 5-year data, no. All of a sudden, now the pendulum swung on the other side. All trials of colchicine were positive. All of a sudden now major trial with a long follow-up, no benefit. We are talking about 7,000 plus patients of the STEMI patients, and individual endpoints are shown here, and that absolutely no difference. Then they went to the individual, hazard ratio on the predefined endpoints. the one point really came up that if some patients actually, they gave those who wait the once daily versus twice daily, that patients who were overweight, more than 70 kilo, if you give twice daily dose of colchicine, was slightly better. But again, this is sub-analysis, but colchicine caused more GI side effect, so overall trial became very negative in terms of. Now, question is why? Why this happened? So what happened is, one of the effect, it caused the tubular formation. That's how colchicine basically work at the early level. But it turns out to be, once you have done the PCI, the colchicine inhibit the vascular endothelial growth factor. And that is required for endothelialization. If you do with the STEMI patients, it was a negative trial, and that seems to be one of the factors, and less endothelial proliferation. But the field has not stopped yet. There is another trial with the plaque volume change by giving colchicine. Does it decrease the plaque volume and CRP? Answer was yes. A small trial, about 60 plus patients. CRP level decreased by giving colchicine, but also the total plaque volume, atheroma volume decreased on the CT by giving colchicine. That was the XTROM trial. So see, this field has not stopped. I'm sure there are some other, you will hear more about it in the future about the colchicine, but I can tell you that clinically, when we start using, because of it, a lot of data showing with those trials, clinically I did try in few patients, but did not have a good outcome of the colchicine. Now, FFR trial, which is the physiological trials, one of the major trials, you remember, a few years ago we presented, FAME3, which compared multivessel disease, FFR-guided versus CABG, and basically showed that 1 year CABG was superior to FFR-guided PCI. Then we have 3-year data. Now you have kind of p-value of 0.07, and now they presented this year 5-year follow-up, and you see 5-year that seems to be the curves start converging, and now no longer significant. You see the p-value, hazard ratio become 1.16, and the individual endpoints are no longer different. Particularly the death, the combined endpoint of the death, MI or stroke was no longer different, but we clearly know the repeat revascularization and MI was lower with the CABG group compared to PCI. But just to say overall, it looks like that once you get to 5 years, the real benefit of the CABG decreases at follow-up. And it was more, so we know that simple cases do better with PCI, complex cases do better with CABG, remains with this trial. More importantly, what I want to show here is how our science has improved. Look on the left side, the syntax trial. Multivessel disease complex, that time we compare Texas stent versus CABG. Event rate was 14.6 in the PCI, 9.2 in the CABG. And guess what? In the FAME3 trial, 5-year follow-up, those are the cohort patient, 3-vessel disease, not much difference in the baseline, but look at the event rate, how good we have become. Revascularization, whether it's a CABG or PCI. And same way, in terms of the mortality, death, MI, stroke, all combined have been a lower. So left side was only death, right is to say that intervention, whether surgical or our percutaneous, may be part of the multiple aggressive medical therapy with the statins and with the SGLT receptors to have overall improvement. In the past, we used to have a cutoff of 22. Then one of the trials showed that 24 may be a better cutoff in terms of the PCI versus CABG difference. There was an acute MI trial, Flower MI, FFR guided versus angiographic guided. You know, FFR is used in the otherwise, but in the acute MI, the trial showed no difference, even up to 5 years endpoints that FFR guided was no difference in angiographic guided PCI in various outcomes. So the acute MI setting, FFR is of no additional use. Then question comes is clopidogrel versus aspirin post PCI long-term trial. Patient has been 1 year done, DAPT 6 months, 12 months, 18 months. Now question is which agent you stop. Many people stop the aspirin. Many people stop the clopidogrel. Now we actually have the answer to this because we have 2 trials. This is a smart choice trial, again from South Korea. Basically was that if you have completed your duration of the DAPT after PCI, so take away continue either aspirin or continue clopidogrel. That was the answer we needed. which one will be better? To follow these patients, 5,500 patients, and basically see that clopidogrel with the primary endpoint was almost the 30% decreased compared to aspirin. And the bleeding was just non-significant, but most important is that primary endpoint, so clopidogrel was superior to aspirin at a follow-up after completion. And the individual endpoints also showed that particularly patients with a high bleeding risk, diabetes, and so clopidogrel was better. And most important, we always have been teaching the stomach gastrointestinal point of view. Aspirin gives you more GI side effects, which are confirmed with this trial compared to clopidogrel. So anytime patient has the GI side effects, it's stopping the aspirin is better than clopidogrel we learned from the trial. This is actually extension of a trial, an earlier trial called host exam trial, which showed the similar benefit that stop after your 12 to 18 months of DAPT. Clopidogrel did better, and even the complex cases, patients with high bleeding risk, all they were superior by stopping the aspirin. I mean, compared to aspirin, clopidogrel was better. So you can make it a point that patient now continue long term. You need to decide with one antiplatelet therapy, probably clopidogrel is better, and it's better for the stomach point of view. And the lastly was our guidelines. We actually, after a long time from our ACC or the European, they keep upgrade every year. So guidelines came, both of them 224, European guidelines for chronic coronary syndrome. You know, old stable angina, now we call it a chronic coronary syndrome, and acute coronary syndrome is ACS. So and ACS was our ACC guidelines, and they basically went through various, simple way, mechanism of myocardial infarction, how you take care of these patients, particularly the CCTA, which we have been doing quite a bit, coronary, not just the calcium scoring, but coronary, the computerized CTA has been kind of level 1 indication, or at level in majority of these cases when you suspect CAD. And of course, many of the cases you can directly go for angiogram. You don't need to do any test in between. Lipid lowering, very important, that bring the LDL to 55. That has been quite a bit. And the patients also with they have various lipid levels. The last basically was 55. Now they actually just last month also came with a focused update on the lipid and saying that maybe you should go down to 44, less than even 55. So even in extreme risk patients. So now 55, 40, because all the trials have shown lower the better, and we're requiring additional agent to get to that level. Now others, what the new guidelines basically was that complex cases should have heart team discussion, imaging I already mentioned, and lastly is the patient choice. We as a physician have to offer to the patient that this is the right thing to do. Patient can decide after whatever the discussion with the family, but you are not making the decision while patient lying on the table. Has to be outside. And that the patient is the final decision maker. We actually have published also, we do that routinely, that almost 45 to 48% of patients where we recommend should go for cabbage, they'll decline cabbage and will come back for PCI. But that's okay. But those do have a little higher risk compared to those who are otherwise would have gone for appropriate PCI. But they're not surgically inoperable, not surgically ineligible. They just decline cabbage. They do have slightly higher risk, but this is what our practice is, and that is ultimately they're given to the kind of patients to make a final decision and so. We have talked about this already. They also emphasize quite a bit on the chest pain in the normal or non-obstructive CAD called ANOCA. Very common disease process. Patient coronaries are normal, comes back, we say, be happy. Patient continues to have chest pain. He said, no, you should be investigating those patients. And this actually a lot of emphasis on ANOCA and INOCA and functional testing. And this led to our second month of the CFT coronary functional testing with the Sweeney and Moreno as the moderator, which is happening first Wednesday of every other month because so much demand to really identify and understand that why these patients have chest pain with a non-obstructive CAD. Then antiplatelet therapy, they have actually have gone through what we do it, acute coronary syndrome, 1 to 12 months, stable syndrome for 6 months and so. Also importance was that adherence of the healthy lifestyle. Lot of focus on individual endpoint, that not only what we finished in the cath lab. In order to improve their long-term outcome, these patients have to follow subsequently in terms of medical therapy, their healthy lifestyle, keeping the risk factors too low. And basically from the ACS point of view, our guidelines is about the same, most important being that the invasive angiography in various group of patients with the ACS and non-STEMI is kind of you can justify in all, but in the low risk patient it's okay. If you can just decide based on the watch the patient and then you decide if patient fails some subsequent treatment or stress test positive, then do the angiogram. But doing angiography is still okay in majority of the cases. Only second question was, do you do right away within 3-4 hours or do it next day or so? It's a class 2A that you can do angiography within 24 to 48 hours in these patients. The second was patient which we have learned, that patient which I mentioned earlier, that full patient multivessel CAD in STEMI patients, that you do full revascularization, all culprit as well as non-culprit. And the second point was when you should do it, they do say that preferred over the PCI at the time is preferred compared to a stage approach. And because remember 2 trials showed that event rate was higher. But we actually don't notice that, but key is that don't wait too long, just after a few weeks it's completely fine. Then also the patients who are STEMI, particularly with the cardiogenic shock, you do only the culprit vessel, not the full vessel revascularization. The statin guidelines are about the same. The depth discharge, this is actually credit goes to, again, the Twilight trial by Dr. Roxana Meran, that after they became the class 1 guideline now, that after 3 months you can stop aspirin, as long as you are giving ticagrelor monotherapy. This is not for clopidogrel because that was not tested. It is ticagrelor monotherapy, and otherwise it's a 6 months for a stable patient and 1 year for same. They also have a lot of emphasis on cardiac rehabilitation, all-cause mortality, reduces readmission, and cost-effective through exercise, education, psychological support, and medication optimization. All those are very important for the work. We finish it in the lab. So this basically puts it together. Advances in anatomy just completed now. Basically, give the message that what we learned, how the practice is changing for this. What we learned, ECMO and balloon pump in cardiogenic shock, rotablation for ISR, drug-coated balloon in large native vessel, and colchicine acute MI. No good, no benefit. FFR guided or maybe even harmful some. FFR guided PCI in multi-vessel CAD, STEMI, P2Y12 monotherapy in acute coronary syndrome or tailored DAPT, which was there. OA, orbital atherectomy or laser in calcific lesion, no good. Then FFR guided PCI over CABG at 5 years, same trial. Stage versus immediate complete revascularization multi-vessel STEMI. So don't do immediate. If you need to do, stage is better because elderly patient, heart failure patient, they do better. So we rarely will do, that has been our practice. We don't do multi-vessel on the same day. Either do that day or stage. The question still, in my opinion, remain, stage should be on day 3, which will increase the length of stay in America, which is very important, or you bring back after a few weeks. So I think our policy of staging after a few weeks, as long as patients on good medical therapy, although 2 trials did show, while you are waiting for the stage, they had a higher revascularization and higher MI, but I don't think we have seen that. Then aspirin withdrawal in low risk MI, which is okay, and 3 month versus 12-month DAP post PCI is good at present and right approach. Then Impala in cardiogenic shock, IVL or rotational atherectomy in calcific lesions, clopidogrel or aspirin, long-term PCI, long-term after post-PCI, 2 thumbs up, and then the DCB in ISR and side branch, imaging, OCT or IVUS in a complex lesion with plaque modification guided PCI, and then of the European as well as our American guidelines in the PCI in chronic coronary syndrome and ACS really helped us to navigate our treatment strategy for many of these patients. So how do we put it together? If I give you our numbers, What has happened? Our Impala use was 95 in 2022. At this year, we will probably use 118. So clear increase. Orbital atherectomy and ELCA use, 5 to 3% used to be in 23. Now we have 1 to 2%. Clear decrease based on the trial, that's what our practice has been. Our intravascular imaging used to be 15% in 23, and it's to 33% at this time. Should it go a little more? Probably can go to 40, 45, because remember, the guideline of class 1 is for complex lesion, bifurcation, long lesions, and so. Not in every case, and maybe in some acute coronary syndrome. Then DCB use for ISR, of course, it was not available, used to be 1%, now it's about 10%, largely because we are part of the many trials, not because we are using clinically, but because ISR patients are in the trial. Then IVL use, which is the shock wave for calcific lesion, 8% in 23, now about 14%. Definitely has improved. The guidelines have changed our interventional practice to improve patients' outcome. This actually showed still the old slide, but just to say our superiority in terms of volume and the safety compared to other medical centers here. And then the CCC live webcast, which is now every week we have. The first used to be coronary only, then we use endovascular, then we structural, they all once a month. Then every other month we added now our microvasculature as well as the imaging. So all 4 weeks there is some live webcast happen, and that actually has been very successful with the 22 to 25,000 hits per month. And United States and India actually are the top in that group. But that's really has helped, I would say, the extending our educational mission globally in 176 countries, which is added by the largest, of course, ACC app are tremendous, but from any one institution already, only interventional the apps is all done with the Kini and her team. Every aspect of interventional cardiology has translated into some kind of app. Right now, I think 14, and then many others are coming. Purpose there is just to educate others, also those who may not be up to date with the latest data, by updating even these apps. As you can see, there is bifurcate, then bifurcate 3D. So we keep changing, then Angio 8 3D. So all these continue to change and upgrade the overall educational mission of Mount Sinai Fuster Heart and Cardiac Cath Lab to educate more people, to make them better, improve their own interventional practice, to improve the overall outcome. With that note, I'll stop here, and thank you very much. And if there is any question, I can take it. I don't know whether anybody has put the question here, but if it is, can ask. No, I think there was no question on this. All right. So we now, Kim, you are ready? Who's going to select? You. Okay. All right, make sure somebody has the number now. Last three numbers I'm going to say. 151. Yes or no? Okay. Then is 281. 281. Okay. All right. Wow. Yeah, look at this. After a long time, yes. Dr. Gulati, fantastic. So with that note, we complete our session, and thanks to Dr. Bhatt and Kini to all this together. Most important, Dr. Bhatt, because he selected all the faculty and the topics. It's a great success, and will be next year about same, I think, October 16th or same time. We try to keep it with the third Friday of October, because that we've learned that the Jewish holidays are all that. It's in between, right timing. So see you next year, and thank you very much.